Yeah, this is correct. They dated yesterday.
Hello, can you hear me?
Should I take it up?
A very good morning to one and all present here. We would like to welcome you to Apollo Hospital, Navi, Mumbai for the Critical Care Workshop in collaboration with 360-Degree Critical Care, World Society of Abdominal Compartment Syndrome, International Fluid Academy, Nephro Critical Care Society, and Apollo Group of Hospitals. We will start our day with an introduction by the course directors. Around 11 a.m. we will have our inauguration ceremony, post which we will again have some lectures, followed by lunch. After lunch will be our hands-on workshop.
I would like to begin this program by introducing our course director, Dr. Gunadhar Padhi and Dr. Tapas Kumar. Dr. Gunadhar Padhi has done his MD Anesthesia, IDCCM, ECMO Fellowship from France. He has also been awarded for Bleeding Management Fellowship from Octa Pharma Academy, Switzerland. Postgraduate DNB examiner in critical care medicine. He is also a faculty for DNB, IDCCM, FCCM, MUHS recognized UG and PG courses. He is also the lead physician of Heart and Lung Transplant Program, Apollo Hospital, Navi, Mumbai. He is the senior consultant critical care medicine. He has also contributed to 2 textbook chapters in anesthesia and equipment procedure. Also coming up with the next critical care medicine and cardiac intensive care. He has also contributed with 6 publications, both index and non-index journal. Over to you, sir.
Thank you, Ipsita. Series, where is my presentation? Presentation open. So by the time series will open my presentations, I again welcome you all to this unique nephrocritical care course, and with all the eminent faculties from outside like Australia, Mayo Clinic, Singapore General Hospital, and with all the in-house our Indian faculties. So I hope this course will definitely going to benefit you, and this is the first course we are conducting at our hospital, and hope we will conduct many such programs in the future. So basically, I welcome you to the city of destiny. This is the city of Navi, Mumbai, and this is our hospital. So this is our hospital, and it's a 400-bedded hospital with 100-bedded ICU in facility with all the infrastructures we have, like doing all the extracorporeal therapy. This is the first nephrocritical course. So basically, it's the already yesterday we have briefed regarding the course. Yesterday was the Zoom meeting, and today is the physical course. And these are the course directors and the organizer of this course: Dr. Tapas, Dr. Akshay, Dr. Nikhalji, and Dr. Ashwati, along with me. And these are the collaborations and endorsement already being briefed, like with 360-Degree Critical Care, Apollo Group of Hospitals, the Nephrocritical Care Society of India, the Society of Abdominal Compartment Syndrome, and Society of International Fluid Academy. So we are actually lucky to have almost more than 80 delegates. Basically, some of them didn't able to come because of some commitments. And yesterday we have received almost 600 Zoom registrations. Out of that, 193 were online and almost attending the lectures. Yeah. So, okay, so basically, these are the different parts where the delegates have come. Already when I went through the list, almost every corner of the India, the delegates are coming from Chennai, like from your Gujarat, from Chhattisgarh, Odisha, from Bihar, and from other parts like Karnataka. So really, it's a pleasure and proud for us. And these are the different delegates coming from across the globe, like from Europe, from Singapore, from Australia, and from Mayo Clinic, US. So why this course is unique? Basically, this is a practical-oriented, hands-on training course. The different pre-course resources already being distributed to you. I suppose you have already gone through the different videos. These are the different links to the videos like Apollo Mumbai Critical Care Learning Network, where we have extensive session on CRRT, SLEDs, and nephrocritical.com. And there are different, also we'll be giving you the nephrocritical course manual, and 4 MMC points are being allotted. So the uniqueness of this, we have a Vexus workshop at the end of the course where Dr. Toraskar will demonstrate you hands-on training on how to basically train on the Vexus. So this is a new upcoming topic, as all of you know. Like yesterday, we have an extensive talk on that from Dr. Koratala, and I think everybody should learn it. And this is a hybrid model, and all being covered by eminent faculties of nephrologist and intensivist. So, serious, this is not moving here. Serious. No, this is not moving. Here it is moving, but it's not moving here. Someone नहीं move हो रहा है ना? क्या है यार? पकड़ो इसको। कहाँ रुको एक मिनट, कहाँ जा रहा है? मूव नहीं हो रहा ना? कहाँ करूँ मैं इसको? मूव नहीं हो रहा ना इधर। क्या है यार सब? कहाँ हो रहा है? नहीं हो रहा ना स्क्रीन पे। स्टॉप क्यों है? नहीं हो रहा है उधर पे। So basically, sorry for the technical glitch, and now basically this is a practical oriented hands-on training because reading materials are already being given. So we can refer to these resources: Apollo Mumbai Critical Care Learning Network, the nephrocriticalcare.com, nephrocritical course manual will be giving you in this in your kit. And 4 MMC points are being allotted, and most important part is the Vexus demonstration. Basically, it's a hybrid model course with all eminent nephrologists and intensivists. This is the nephrocritical care manual, what we have made, and we'll be distributing you. So these are the different pages of nephrocriticalcare.com already being discussed. Like you can find the resources like AKI, acid-base disorder, dyselectrolytemia guidelines, the recent trial, the renal drug dosing, and different reviews and recent papers. So what is most important is the first half of the course is basically covered with didactic lectures by all the eminent faculties, and the second half is the hands-on training. So I will request all of you to involve your faculties and to learn them and expertise yourself the more and more into the practical aspect of the CRRT and the extracorporeal therapies. So we have divided the groups into 4 groups, starting from the ultrafiltration to hemofiltration to diffusion to hemoperfusion, and at the end we'll be taking the lectures on the Vexus. So what are the equipments we are going to demonstrate today? Like CRRT machine, CRRT with plasmapheresis and extracorporeal circuit like auxiliaries, the sled machine, the CRRT with the ECMO machine, connections and the functions, centrifugal plasmapheresis system, and not covered here actually is the Mars, because we didn't get the Mars machine because of the unavailability. And the second is the hemoperfusion cartridges. So that also, I promise that in the next course we'll be covering those extensively. And the hemoadsorption system, which is now one of the important therapies in the ICUs. Also the ECOR system with CRRT, because now a lot of newer ECOR systems are coming up with CRRT like Prisma lung and other things. Okay, so the main aim of showing these two pictures is, one is a successful person, but his success is because of the training. That is why the training is more important, like Sachin Tendulkar. The second one is Sir Winston Churchill. So what is the most important in his life is basically he is a person belongs to UK, but in the childhood and in the adolescence he didn't able to learn the English properly. He didn't able to speak the English properly, but he was one of the president. And when being invited in the Oxford University, his only 3 words are there: do not give up, do not give up, and do not give up. So that is what the mantra for today's training. If you train yourself, you practice, I think you will be one of the person or intensive who can independently run the CRRT or CRRT system in your hospital. Then this is I know the conferences are team efforts. It is not me or anybody, it's by the whole team, starting from your delegates, your faculties, and all my support system. So I thanks a million to everybody, every of them, starting from our critical care department, all the consultants, juniors, and students, and who have helped us to conduct this course. Nephro department and the faculties like Dr. Nikhalji and Dr. Ashwathi, the other delegates who have come here from the different parts of the India, and all the administration support we have, starting from our regional CEO, Dr. Mr. Marathe sir, Dr. Kiran, and Dr. Ravi Shankar, and other administrative staff. The marketing support, Abanti madam and all his team, Dhyaneswar ji, Sarita, and everybody has helped us tremendously to conduct these sessions, and they have worked hard almost 1 month prior to this conducting of this course. All the food and beverages department, the finance, the security person, Savant, the guest relation officers, John, and the housekeeping. So everybody has contributed to smooth conduct of this course, and the IT department also. Industry support is very important, I know, for any conference. So we have, thanks to all the Pfizer and team, the Baxter, they have brought all the machines here for the demonstration, the Sanofi, and the Cipla people. So without further wasting any time, I'll just like to invite Tapas to have a few words, and then we'll be starting with the lectures. I know we are a little bit delayed because of the technical issues, but beg apology for that. So thank you. Thank all of you again to have in our hospital and in our auditorium. Thank you.
Thank you, Dr. Gunadhar. Now, Dr. Tapas, who is also one of the course directors of the event. Dr. Tapas Sahu is MD, FNB, FICCM, FCCP, EDIC from Canadian Critical Care Fellowship, University of Toronto. He has done his MBA in Healthcare Management. He is the Associate Director and Head Critical Care, Medanta Hospital, Ranchi. He is also the Executive Committee Member, Society of Neurocritical Care, and was International Asia Pacific Representative in the year 2018 and 19. Over to you, sir.
अभी आपको जो भेजा था सेंड हुआ है क्या आपके सेंड हुआ है जो आपके लैपटॉप से भेजा था सेंड हुआ था क्या बोले ना कि सर्च का
So, good morning, everybody. I know there is something happening to the IT. Since yesterday, we have continuously having some or other problem, but I think that's the beginning. And with all these things, we learn one thing, that great things come with a simple and humble beginning. And maybe that's the concept with which we thought of starting this nephrocritical care concept, which is amalgamation of two important departments, domains, which we come across in our critical care practice. And believe me, in any ICU, I think all of us will agree, in any ICU, almost out of 10 patients, 5 patients would be having a diagnosis of acute kidney injury with sepsis and with some or other organ system involvement. And that's propelled us, few like-minded people. Dr. Sanand is with me here from Australia. Myself, Dr. Amit, who is my dear colleague, nephrologist from Medanta Ranchi, and Dr. Gunadhar, and so many like-minded people. Maybe 6 months back, we sat together online, offline, and thought of doing something for the nephrocritical care angle. And that could be the initial point with which we can do some better academics, education, research, and maybe our practice would be something would be changed after 1 year, 2 year down the lane. And it's a humble beginning, and I would not take much of time because we are already running late, and we will be discussing some important topics. Believe me, we started at Ranchi 2 months back with the first nephrocritical care conference, and that was hugely appreciated, acclaimed all over India and abroad. We had faculties from Mayo as well, Australia, also from Belgium. And yesterday, can you imagine, there were like 600 Zoom registrations and 200 plus online registration till 10:30 p.m. And it was 4.5 hours of, I can say, marathon discussion on the nitty-gritties of nephrocritical care. Starting from the AKI with sepsis till the recent modalities of diagnosis, nephrocritical care, that is nephropocus and vexus. So that shows the extensive coverage that nephrocritical care can have. And I believe you all can join the network of Nephrocritical Care Society. For the first time, this society has been formed all over the world, I can say. Because when we started searching for the name, we put in the Google. Believe me, we didn't find a name in Nephrocritical Care Society. Maybe I am wrong. It's a humble beginning I am saying. And my dear senior, I would say, and mentor, Dr. K.R. Ramanathan, he would be joining us very soon from Singapore. He has already left hotel. So he told me that after our course, Dr. Gunadhar would be agreeing with me, 5 days after we released our first flyer, he shared with me another flyer from Singapore, that first Singapore Nephrocritical Care Review course. So, this is not, yeah, you can show, yeah. So, and after 15 days, we got another flyer from ESICM, European Society of Intensive Care Medicine, led by Professor Dr. Marlies Astruman. She was also the faculty yesterday. And she launched the European Society of Intensive Care Medicine Nephrocritical Care Review course. So I'm not saying that we are in race with all these things, but yes, in India, we can also have good ideas, and maybe that is the initiating point of doing something good for our own people. And it's not about that it will be restricted to India. It has already fascinated the people around India also. I got the call from Nepal, I got the call from Indonesia, Bali, that yes, the people are actually liking the concept, because nephrocritical care is everything, I would say. All these facilities, maybe it's neuro, maybe it's gastro, some or other, the two kidneys play a major part. And we all know that will affect the homeostasis of our body, and that finally would, if you are good at treating at the bedside, the patient will survive. If you are not that prompt, maybe that won't be a good survival outcome for that patient. So with that humble background of how we started Nephrocritical Society, I request all of you to join the network Nephrocritical Society, which is right now free for any registration fee. You can just scan the QR code I will share within your email also, and let's drive this passion and this momentum to a new era. Thank you, all of you.
Thank you, Dr. Sabu. We will now start with our sessions.
Sorry.
I would like to call on stage Dr. Ravindra Nikalji, MD Internal Medicine, DM Nephrology. He is a senior consultant nephrologist and team lead transplant physician at Apollo Hospitals, Navi Mumbai. Dr. Nikalji has done his fellowship in renal medicine and transplantation from University of Toronto. He is a clinical specialist in hypertension, and he has published several papers in the national and international journals. He is also a member of American International Society of Nephrology. His topic for today is physiology of renal function and urine formation. Over to you, sir.
Yeah, thank you so much. So it's like a opening batsman, opening talk. I thank everybody for coming here all the way from all across Mumbai, all across India, and I'm sure you will enjoy the talk. You'll enjoy the conference. This is first ever from Apollo, and I'm so happy that I'm starting the talk. So actually, the previous speakers have, Dr. Tapas Sahu just talked about it, like how important the kidneys are, and as long as kidneys are with you in the ICU, I think the outcomes are guaranteed. And all of you know that moment it starts involving, like any of these multi-system organ failures starts involving the kidneys, the outcome changes dramatically. And it's so important to preserve the kidney function. It's so important to take care of your urine output and the creatinines during this in the patient journey through the ICU. And so we have a great team here, critical care team, and we work in coordination. So it's a pleasure to be talking to all of you today. And the talk for me, talk for me today is physiology of urine formation and electrolyte homeostasis. So it's basic talk. It's very important to know the physiology and the basic anatomy and physiology of the kidneys before you start on these. To understand how how we manipulate the kidneys, how the kidneys play a central role in homeostasis, and how the outcome changes when you have an acute kidney injury in the ICU. So functions of the kidney well known. So basic function being the filtration and excretion of metabolic waste products and foreign chemicals, drugs, toxins. Kidneys are vital to regulation of the fluid and electrolyte balance. They are important in maintaining the ECF volume. They regulate the body fluid osmolarity and electrolyte concentration. They are vital in maintaining the regulation of the arterial pressures. Regulation of the acid-base physiology. They are important in secretion of some of the vital hormones like erythropoietin, vitamin D, and metabolism and excretion of these hormones, and gluconeogenesis. So we are lucky to have two kidneys. Dr. Tapas Sahu already mentioned, helps us in doing kidney transplants. Right kidney being little lower, I mean these are bean-shaped organs located retroperitoneally, right kidney being little 2 centimeter lower than the left kidney because of presence of liver on the right side. We have adrenal glands on the superior pole, and this is the kind of an cut section of the kidneys. And these are the functional units. So right from the exterior surface, we have renal capsule, renal cortex. The renal parenchyma is divided into two parts, renal cortex and medulla, and they have different functions. This is the functional unit of the kidney, nephron. It's a very, very smart unit, which is vital to the process of urine formation, which is vital to the process of sodium electrolyte balance, which is vital to the process of acid-base homeostasis and ECF volume regulation. So the basic unit of the basic unit is nephron. It starts with the glomerulus, which is nothing but a bunch of capillaries. It starts as an afferent arteriole, and then the capillaries divide, and they form a capillary network, and then it exits as a efferent arteriole. Now these glomerular capillaries form a filtration barrier known as across which the purification or the filtration of the blood happens and the ultrafiltered forms. And this comes out into the proximal tubule. Then there is a loop of Henle, which is divided into descending and ascending limb. Then you have a distal collecting tubule, cortical collecting duct, and finally it leads into the urinary passage. So a very smart organ and a very smart functional unit. The kidney receives its blood supply through the renal artery, and the kidney receive the drainage from the renal veins. There's a lot of lymphatics around the kidney. Nerve supply is mainly the autonomic nervous supply, which autoregulates, which helps in autoregulating the blood supply, and the ureter remains the drainage unit. Kidney also interacts with various organs, so there is always a crosstalk happening between the kidneys and various organs, and it helps in maintaining the osmolarity, it helps in maintaining the electrolyte and acid-base balance, it helps in maintaining the ECF volume, it helps to maintain the hemoglobin, it helps to maintain the bones, the integrity of the bones. So really they are vital organs for health in acute as well as the chronic settings. Kidneys receive almost 25% of the cardiac output. So the large amount of your cardiac output goes to the kidneys, obviously for the purpose of filtration and the excretion. And the flow of blood is from the renal arteries, interlobular arteries, arcuate arteries, interlobular arteries, which again go into the afferent arterioles, which lead into the glomerular capillaries. Blood gets filtered and it's drained via efferent arterioles. So afferent and efferent arterioles are the main sites where the autoregulation of the glomerular filtration happens, and this leads the venous drainages to the peritoneal capillaries, interlobular veins, arcuate veins, interlobar veins, and finally renal veins. So almost 1 million units, 1 million nephrons are housed in each kidneys. The kidneys are not able to regenerate new nephrons completely, and after age of 40 years, there's an attrition. You lose almost 10% of the nephrons every year. And as I said previously, nephron has two parts: the glomerulus, which is a functional unit which filters, it forms a filtration barrier, and there is a long tubule across which the tubular reabsorption and secretion happens, and which finally leads to the urine formation. So the urine formation happens through these following stages. First, there is a glomerular filtration, in which there is a water, ions, amino acids, glucose, nitrogen-containing waste products, and other small molecules move across the glomerular capillary filtration barrier into the tubular space. Then there's a tubular reabsorption across the various sites in the tubules, proximal tubules, and this happens across various channels, various pumps, transporters, co-transporters. I'll come to that in the next talk. And finally, there's a process of tubular secretions, where the nitrogenous waste products, excessive ions, drugs are excreted, and the net result is what you get is urine. So it's an intelligent mix of filtration, reabsorption, excretion, which finally leads to the urine formation. Almost about 180 liter of glomerular filtrate is formed every day, and almost 99% is reabsorbed. So you all know that we form only 1 or 2 liters of urine every day. So a lot of work. So kidneys are working 24/7 to maintain the homeostasis in your body. And as I said, these 4 processes are involved in the process of urine formation. Ultrafiltration is the key, which is regulated by various hormonal, neural inputs. Selective reabsorption, which is again somewhat mediated by the concentration gradient, and it is under influence of the certain hormones and the downstream mediators. Secretions of metabolic waste products, secretion of the H+ ions, secretion of the potassium, and finally excretion. And these are the various sites across which the tubular reabsorption excretion happens. So bulk of the work is done by the proximal tubules, where 60 to 65% of the sodium chloride reabsorption happens. Almost 90% of the glucose load is reabsorbed in the proximal tubules, and a lot of water and the potassium follows it. Almost 90% of the bicarbonates is reabsorbed in the proximal tubules through the brush border carbonic anhydrase enzymes. Then comes the loop of Renal, where again you have a lot of channels, there's pumps, and this is responsible for around 15% of the sodium chloride absorption, almost same amount of water absorption and calcium absorption. Then there is distal collecting tubule and collecting duct, and which are under the influence of the hormones like aldosterone and vasopressin, where the water reabsorption happens through aquaporin channels, and sodium reabsorption happens through ENaC, or the epithelial sodium channels, which is under the influence of aldosterone. So a lot of inputs, hormonal, neural, physiological, which contribute to the alterations in the physiology. So it is important to understand the physiology to understand the disease. And again, I mentioned these 4 processes: filtration, reabsorption, secretion, and the final excretion. And it happens across the nephron. So expressed mathematically, urine excretion rate is nothing but this net sum of filtration rate minus reabsorption rate plus the secretion rate. And all these rates, like the filtration rate, reabsorption rate, and the secretion rates, can be altered based in a disease state. So almost 180 liters, I mentioned earlier, the amount of glomerular filter that is formed. And filtration fraction is the fraction of blood plasma in the efferent arterioles that becomes finally the glomerular filtrate. The filtration membrane consists of following things: the glomerular capillaries, podocytes, which completely encircle the capillaries and form a leaky barrier known as the filtration membrane. And it consists of glomerular endothelial cells, basal lamina, and the filtration slit formed across by the podocytes. And this is an ultrastructural view of the filtration barrier. So 3-layered filtration barrier, a very smart organ, which retains the high molecular weight substances and proteins, and selectively allows ions, water, low molecular weight substances like urea, creatinine, and the nitrogenous waste products to come out. These capillaries are unique in kidneys, in the sense that they have a large surface area, and the surface area is autoregulated to a large extent, and the mesangial cells relax or constrict to maintain the GFR. The filtration membrane is very thin and porous with a thickness of almost 0.1 millimeter, and it is 50 times leakier than the other capillary beds. And the glomerular capillary blood pressure is comparatively higher compared to the other capillary beds. So there's a concept of net filtration pressure, the pressure which promotes filtration across the filtration barrier, which is the net sum of glomerular capillary hydrostatic pressure, which promotes the filtration. Then there is a capsular hydrostatic pressure, which promotes the filtration, and the plasma oncotic pressure, which opposes the filtration. So net filtration pressure is nothing but the net result of glomerular capillary hydrostatic pressure minus capsular hydrostatic pressure minus oncotic pressure in the blood. So the net filtration pressure that we have in the glomerulus is around 10 millimeters of mercury. So which aids the movement of ions, water, and small molecular weight substances across the glomerular filtration barrier. And as I said, the glomerular filtration rate is autoregulated to a large extent in physiological as well as disease states, and that is done by regulating the blood flow. And as I said, being a smart organ, kidneys are able to maintain GFR in various states. So whether you have volume loss, the kidneys will try to maintain the GFR by reabsorbing too much of salt and water. If you are you are volume expanded, the kidneys will try to improve reduce the sodium and water reabsorption, and it helps in maintaining the ECF volume status. So this autoregulation of the blood flow or the autoregulation of the GFR, there are 3 main mechanisms which you should be aware. There is an intrinsic mechanism called myogenic mechanism. So this is the reflex constriction or dilatation of the afferent arterioles. It happens at the level of the afferent arterioles, which either increases or decreases the GFR in response to the perfusion pressure. Then there is something called tubular glomerular fluid bag, which is very important. This is a specialized apparatus and specialized cells called macula densa cells, which are located in the ascending limb of loop of Henle. These sense the amount of tubular fluid that is delivered to them and the amount of sodium or solute load that is coming to them, and they are able to, in a reflex mechanism, by changing increasing the nitric oxide production, by increasing the adenosine production, and by increasing the angiotensin II production, they are able to constrict or dilate the afferent arterioles to maintain the GFR or the filtration pressure under various states. And there is obviously a lot of neural inputs which control the GFR, the main local regulator being the renin-angiotensin system. So as we all know, renin is secreted by specialized granular cells in the ascending limb of the loop of Henle, which are close to juxtaglomerular apparatus. So renin is secreted in response to the volume status or the sodium status. Renin hydrolyzes angiotensin 1, angiotensinogen to angiotensin 1, and then angiotensin 1 is to convert it to angiotensin 2 by the angiotensin converting enzyme. So angiotensin 2 is a very, very potent vasoconstrictor it forms a part of the local as well as the systemic autoregulation. And the other hormones that impact are the sympathetic nervous systems, adrenaline, noradrenaline, your vasopressin, atyl-natriuretic peptide, aldosterone. So these are the various mechanisms through which the kidneys autoregulate the GFR or kidneys autoregulate the blood flow and helps to maintain the urine output across various blood pressures. So that was in short about how the filtration happens and which factors regulate the filtration. And now coming to the another important area of tubular transport. So once the glomerular filtrate is formed, so this filtrate is passed on to the tubules, and tubules are able to reabsorb a lot of it. Tubules are able to secrete, and the net result is what you have a final urinary concentration and final excretion of the waste products and potassium and acid. So movement of solutes and water across cell membranes is, it's done through integral membrane proteins, and there are lots of them. You are aware the channels which allow passive reabsorption. This is across the concentration gradient. There are pumps which are electrogenic, which degrade ADPs and generate energy to actively transport your sodium potassium across the concentration gradient. There are transporters like sodium glucose co-transporters, all of you are aware, where the SGLT2 inhibitors act, and this is a process of facilitated diffusion. And there are secondary active transporters also called co-transporters. So active transporters they use a lot of energies. So they use by translocating ATPase. So well-known examples are sodium potassium ATPase, hydrogen ATPase, and calcium ATPase, which are important in maintaining the acid-base balance as well as the calcium balance in the blood. Passive transport happens through a process of simple diffusion, which is across the electrochemical or the concentration gradient. And facilitated diffusion is the passive transport mediated by simple transporters called as carriers or uniporters. So like you have a hydrogen transporter, you have a potassium transporter. So once the glomerular filtrate is formed and it's passed on to the tubules, so this is what happens in the first site. As I mentioned earlier, proximal tubule is responsible for the bulk of the reabsorption. Almost 65% of the water loads, almost 65% of the sodium load, and potassium load is reabsorbed. Almost all of the bicarbonate is reabsorbed. So the proximal tubule is working overdrive to maintain the sodium, potassium, and acid balance. And these are the channels through which proximal tubule acts. So right on the left side you have a luminal surface, and on the right side you can see the interstitium or the basolateral surface of the proximal tubular cell. So we have sodium phosphate co-transporters, sodium glucose co-transporters, and sodium amino acid co-transporters. So sodium moves in across these co-transporters. And sodium glucose co-transporter is the site where which SGLT2 inhibitors act, and we have at the basolateral member sodium potassium ATPase, which drives out two sodiums and inlets two potassiums and creates an electrochemical gradient, and the glucose and amino acids exit through the basolateral membranes. And proximal collinear tubule is primarily responsible for maintaining the. Okay. So your secretion of this maintaining the acid state balance and by reabsorption of the bicarbonate through the carbonic anhydrase enzymes. Then comes the loop of Henle, where almost 15 to 20% of the reabsorption of the water and sodium happens. 20 to 30% of the potassium is reabsorbed here, and chloride follows passively, and urea is secreted from the recycling of the collecting duct. Now this segment is important for counter current mechanisms, the loop of Henle, and these are the channels which are responsible for excretion and reabsorption of the ions. The famous one is sodium potassium 2 chloride, where most of your loop diuretics act. So loop diuretics like furosemide, torsemide, or bumetanide act on this channel, and they promote sodium potassium chloride excretion. Then there's a potassium channel, which is a uniporter, allows the potassium excretion. And as usual, on the basolateral membrane, there's a sodium potassium ATPase. Calcium, magnesium follow the diffusion through the cells, So this happens. This is a passive diffusion of the calcium and magnesium from the lumen to the basolateral membrane. And then comes the distal collecting tubule, where the remaining reabsorption of water, sodium and chloride happens. And here the calcium secretion, excretion is stimulated by the parathyroid hormone. And these are the various channels in the distal convoluted tubules. So you have a sodium chloride co-transporter, which is the site of action of thiazide diuretics. You have calcium uniporter. Again, at the basolateral membrane, you have calcium sodium exchanger and the sodium potassium ATPase. And the final destination in the journey of urine formation is your late distal collecting tubule and the cortical collecting duct. Now there are the important channels that are present here is one is ENaC, or the epithelial sodium channels, which is under the influence of all of you are aware aldosterone, and most of these aldosterone receptor antagonists act on this site. So these are amyloid sensitive or epithelial sodium channels, and then you have the aquaporine channels in the basolateral membranes, which is under the influence of the vasopressin or antidiuretic hormone, and these channels open up in response to the hypovolemia or in response to changes in the osmolarity, and they allow reabsorption or excretion of water. And also not to forget these type A or type B intercalated cells in the cortical collecting duct, which are important for the acid secretion as well as the potassium secretion, and these are again under the influence of your aldosterone. So this is how, in short, the kidneys filter blood. They maintain the urine concentration of various ions, and they help in maintaining the acid-base balance. They help in maintaining the ECA volume status. I have mentioned previously only these are the hormonal mechanisms. Most importantly is your angiotensin 2 and aldosterone system. Then you have antidiuretic hormone, atyl natriuretic peptide, and obviously parathyroid hormone, which is involved in the homeostasis of the calcium. So almost the same kind of a schematic representation of right from the glomerular filtration to the final urine flow. Also, kidneys play a central role, as I said, in maintaining the osmolarity of the blood through antidiuretic hormones, and these through aquaporine channels, which is under the influence of the ADH and V2 receptors. I already spoken about the sodium potassium homeostasis through the various channels, and you know how kidneys are the sodium electrolyte imbalance happens if you have an acute or chronic kidney injury. Not to forget the calcium. So kidneys produce vitamin D. So active hydroxylation happens in the kidneys, and you have final vitamin D, active vitamin D, which is important for the calcium reabsorption. And also you have an PTH, which acts in association with the FGF23 and helps in maintaining the calcium homeostasis. So remaining few slides are basically about the markers for the glomerular filtration rate. I'm sure, there are a lot of new markers that will be talked about in the following sessions. But to date, what we have, and the most important for us or for the intensivist in the day-to-day practice is one is your urine output and your creatinine. And you are all aware that these are the two most important criteria still in all the definitions of AKI, whether it's KD code definition, whether it's an acute kidney injury network definition, and you have various stages based on just the two main parameters. One is your urine output and the creatinine. Obviously, in the acute state, we don't measure GFR. It's more important for the long-term or chronic state. So creatinine, though is an insensitive or not a very accurate marker, still remains a important marker in a day-to-day practice. It's late to rise. A lot of damage has already happened before the creatinine increases. So, but still, easily available, easily accessible. We have another markers like urea, cystatin C, which we try and Cystatin C, the only advantage over creatinine is that it is not affected by your protein intake, it is not affected by your muscle mass. or the volume status. So that is one attractive way to calculate your GFR. So I think I'll stop here. I have kind of briefly touched upon all the various physiological functions of the nephron, and I'm happy to take any questions. Thank you so much for patiently listening to me. Any questions, students, faculties? Okay then, thank you. Enjoy your conference.
Thank you, Dr. Ravindra. It was an interesting session. So moving on to the next, now I would like to call Dr. Akshay Chalani, who is also one of the course organizers for this event. Dr. Akshay Chalani is DN General Medicine, FNB, FPS Medicine, FICP, Consultant Physician, Intensivist, Medical Advisor and Critical Care Specialist, Apollo Hospital, Navi Mumbai. He is also the Chairman for Indian Society of Critical Care Medicine, Mumbai, Executive Committee Member, West Zone, Indian Society of Critical Care Medicine, Mumbai. So today's topic is renal function and its implication in renal replacement therapy. Over to you, sir.
Thank you, Ipshita and Dr. Tapas and Dr. Gunadhar for giving me this opportunity to talk. What just now the previous speaker has spoken, Dr. Ravindra, about what is happening in the native kidney. The same thing I'll just talk, but what happens in the dialysis machine, or what happens when there is a filter actually. Basically, the topic which is given is to me the most of the physiology. What is diffusion, what is convection, and what is ultrafiltration. So by and large, next 25 minutes, I'll be talking only the physiology, what we read in the first MBBS. But to make the things little clear, what I mean to say, when we talk about the RRT or renal replacement therapy, as an intensivist or as a critical care person, when you work in the ICU, you just need to know, already everybody knows when to put the CVVH, when to put the CVVHD, or when only scuff. But what is the pathophysiology or what is the physiology? When exactly you need to ask why exactly I'm putting on the CVVH or what ultrafiltrate. So I'll just talk about a little bit physiology, so at the end of the day you know when to do what and when not to do what. So when we talk about the renal replacement therapy, basically to just make the things clear, this is a renal artery access line. When you put the patient, from here the blood will come. Renal vein, the blood goes to the patient. Kidney hemofilter, by and large, I'll just talk about what exactly is happening in the hemofilter. When we put the filter, where is the diffusion, where is the convection, and which point of time we need to apply what. The urine comes in the ureter, this is ultrafiltrate, and the bladder is drainage vessel. So basically what I meant to say, when we talk about renal replacement therapy, we replace the native kidney with the artificial kidney. So when we talk about the therapies of renal replacement therapy, what are the things which come to the mind? One is intermittent hemodialysis and other continuous renal replacement therapy. In the continuous renal replacement therapy, we talk about CVVHD, CVVHDF. What exactly is that? What exactly we need to do that? I'll just talk about that. Other is the SLADE and peritoneal dialysis. So CRRT, what exactly we mean that is needed for all mostly critically patients who are not doing well or those hemodynamically unstable. When we ask or when we put the CRRT with the renal dysfunction or fluid volume excess by providing the slow continuous removal of the toxins and the fluids. Please understand it is slow and continuous. As compared to intermittent hemodialysis, the basic difference that we apply to continuous. By removing the fluids continuously over the 24-hour period, CRRT mimics the native kidney. In intermittent hemodialysis, you just give only for 3 to 4 hours, but when we ask for the CRRT, it is continuous. By and large, we try to simulate the native kidney, and it is extracorporeal solute or the fluid removal. I hope you must have seen the CRRT machine, but this is that. It includes, sorry. it includes a hemofilter with the semi-permeable membrane. So now I'm just going to the more physiology. You feel it is more bore and cumbersome, but just try to focus around it 2 or 3 slides which will explain the physiology. So then the life will be easy actually over the period of days, or next 2 days at least. By connecting the hemofilter to the patient's circulation, fluid can be removed from the patient on the basis of hydrostatic pressure gradient across the filter. So just remember the hydrostatic pressure. How exactly we can move from here? So when we ask the renal replacement therapy, by and large, all discussion will be done around diffusion, convection, diffusion plus convection, ultrafiltration and adsorptions. So when we talk about the diffusion, convection and diffusion plus convection, the various modality, when we talk about the renal replacement therapy, these terms will come very frequently. So when we talk about the semi-permeable membrane, please remember the semi-permeable membranes are the basis of all the blood purification therapies that will allow the water and some fluids to pass through the membrane while the cellular components and other fluids remain behind. So when we talk about the filter or semi-permeable membrane, the kidney, what Dr. Ravindra had just now shown, this will allow some fluids to pass, this won't allow some fluids to pass. So ultimately it will work as a filter. So just give this is a basic filter, the blood will come from here, then blood will go from out. The pores which are here inside, in the cross section you can see these hollow fibers. This is the blood in the inside and the outside the dialysate. So the water and the fluids that pass through the membranes are called as ultrafiltrate, and the membrane and its housing are referred as the filter. So 2 things make it clear. One is what is the ultrafiltrate and what is the filter. So this is making, you must have seen this blood from this assay from the patients. The dialysate flowed from this direction, the blood flow on this direction. The smaller fluids and the fluid pass through the membrane, but the membrane blocks the passage of the large substance. So whenever we talk about the dialysis, frequently will come across the smaller molecule and the larger molecules. To make it clear, the smaller molecules, it depends upon what are the size, the Dalton size. Smaller ones are sodium, phosphorus, potassium, urea, phosphate and creatine. The middle ones are vitamin B12 and aluminum dysphosphate complex. And the larger ones are inulin, beta-2 micron, albumin. So when we talk about the dialysis, please remember whenever we solute the small substance, whatever we ask in the intermittent hemodialysis, by and large you take out the small solids. When we talk about the CRRT or very highly convection forces, we talk about the large molecules. How it happens, we'll just come to know. But when we talk about the principle of the dialysis, basically it works on the principle of diffusion of solutes and the ultrafiltration of fluid across the semi-permeable membrane. Just now we have seen that semi-permeable membrane. And the diffusion describes a property of substance in the water, and it will move from the higher concentration to the lower concentration when we talk about the diffusion. So diffusion is the movement of the solute across a membrane via the concentration gradient. For diffusion to occur, another fluid must flow on the opposite side of the membrane. So I'll just show you that. And in the blood purification process, this fluid causes dialysate. So just give in a graphical picture, you can see the blood comes from here, it will from the patient, and it will go to the patient after the process of the filtration happens here. So when we talk about the dialysis, you need to understand what I just now told you. For the blood purification process, the diffusion will across the dialysate, and in the dialysate, the flow will come totally opposite. The blood will flow on this direction, but the dialysate flow will flow on this direction. So during this process, there is the creation of the concentration gradient, which will cause filtration. I think this is clear when we talk about the dialysate, from higher concentration to the lower concentration. The blood flows from one side of the semi-permeable membrane and the dialysate, a special fluid, dialysis fluid, which is on the opposite side. And the semi-permeable membrane is a thin layer of material that contains holes of various size or pores. So when we talk about the dialysate, is a fluid on the opposite side of the filter from the blood during the blood purification. So what exactly the dialysate contains? It contains electrolytes, glucose and buffer. So by and large, whatever the dialysate commercially available, what we see that is near normal physiology. So whatever we have the physiology, like sodium around 135 to 145, glucose and all that, the same things which constitute the dialysate flow. The most common concentration of these solutes are equal to the normal plasma levels. So when the solute diffuses across a membrane, that always shift from an area to the higher concentration to the lower concentration, what we try to see that the concentration of both the sides of the membrane is equal. So ultimately the idea of dialysis or diffusion principle is that the concentration or the osmolarity around both the sides of the semi-permeable membrane should be equal. And how this happens actually, you just need to remember this. When we talk about the diffusion, this is the semi-permeable membrane, dialysate the blood, and this, if you can make it out, it's bicarbonate, potassium, urea, tumor necrosis factor and blood cells. The blood cell won't flow. But when we talk about the dial set, as we saw, the blood will flow suppose on this direction, the dial set will flow on this direction, both the opposite. So the gradient which will create here along that semipermeable membrane, it will drag the smaller substance like potassium, urea and tumor necrosis factor. So this is by and large physiology when we talk about the diffusion or dialysis. Is it clear? Or because by and large every time we will come across these terminologies only. Now the same thing, ultimately we try to make a balance everywhere. The fluid what we are giving, to just give an example, when we talk about the hemodialysis, just now we have said from the patient the blood will come, assume that this is the dial set. Here from the dial set the inflow will come here, and here both the movement, blood and the dial set opposite direction. So what it will have, it will create a concentration gradient. So what we'll do, suppose the patient has a renal failure or patient has a significant uremia, uremic encephalopathy. So what the urea, suppose you consider around 200, 300, the dial set what exactly it want, it will drag the urea and drain it out. But at the same time when the urea comes down to 20, it won't drag. So this is by and large principle of the diffusion technique. So now what is the difference between IHD, intermittent hemodialysis and CRRT? Because of the short treatment time, the HD delivers highly efficient therapy for toxins and the fluid removal. Because HD lasts only for 3 to 4 hours. So to make it clear, suppose you want to do some work which happens in around 24 hours, that machine will do in the 3 to 4 hours. So it will be, obviously and naturally that is highly efficient as compared to CRRT, which is a low efficient. IHD, the intermittent hemodialysis, works on the principle of diffusive therapy, but CRRT works on the principle of the convective therapy. So what exactly is that, we'll just talk. But in contrast, the CRRT is performed mostly as a convective therapy across a high flux membrane and using the industry prepared solution in the back. Now, how this convection works? IHD, intermittent hemodialysis therapy, we know it works on the principle of diffusion, but how this CRRT or how this newer machine works with the principle of the convection therapy? Basically, it is a movement of the solute through a membrane by the force of water. I'll just give an example, but just remember, it's able to move very large molecule if the flow of the water through the membrane is very fast enough. Now, what exactly we want, I'll just show you one slide so it clear actually. So convection is basically the solvent drag. So what happens, the blood will flow on one direction. You want something to flow in another direction which will drag the molecules from that fluid. In the dialysis, we know that the speed is near about same. But when we ask of the convection, what happens is large molecule we need to move from the blood to the outside. So this in-series property is maximized using the replacement fluid. So how exactly you will create that convection drag? So what we want the solute to drag. We want that molecules to drag from the blood to the outside. So how will you create that? You need something to create that convection. And you need something fast or highly speed solution to create that solvent drag. So in that CRRT, when we talk about the convection, it is created by the replacement fluid. And the replacement fluid are the crystalloid fluids administered at a fast rate just before or after the blood enters the filter. And the increase of fluid flow rate across the filter allows the more molecules to be carried through the other side actually. Please remember, I want you to remember that replacement fluid, though the name is replacement fluid, it does not replace anything. That we need to understand, because initially when we start the name itself is a replacement fluid, but it does not replace anything. It is only given to drag the solute. Is it clear? Yeah. Just to give an example, just think of a quiet stream or compared to the raging wire. Just now you assume that there are two places. One, the water is flowing very slowly. It will not drag anything. Just consider another river which is very fast, or you consider that one lake which is just stable, or another river you just consider that river is flowing very fast. So the fast the river moves, it will drag more molecule. The fast the mover moves, it would drag more solutes. The fast the river moves, it will. So suppose you want to move this boulder. So if the water flows slowly, it won't move it. But when the flow is very fast, what we achieve in the replacement fluid, when you put on the CRRT, when you increase the flow of the replacement fluid, it will drag more the molecule. Like if the flow is very slow, it won't drag anything, but if the flow is very high, it will drag this boulder. That is the basic principle of the convection. Is it clear? In the dialysis, you just put one side blood, second opposite side fluid. It will create a pressure gradient. But when we talk about the convection, the fluid which is coming on the opposite replacement fluid, it is so fast that it will drag the molecules, and the more the speed it will drag more higher, larger molecules. That is the idea of convection. Make again thing little clear. This is hemofiltration, this is hemodialysis. In the hemodialysis, this is the blood, this is the dialysate. Concentration gradient across the semipermeable membrane, it will drag the molecules, smaller molecules. This is the hemofiltration, blood filtrate, semipermeable membrane, positive pressure, and this is in the filter there is negative pressure. So obviously from higher pressure the fluid will go to the lower pressure. More the pressure, more is the solid removal and water removal. So ultrafiltration is referred to the passage of water through a membrane under the pressure gradient. Pressure that drives the ultrafiltration can be positive, and then pressure pushes fluid through the filter. So just see this diagram. This is the blood, this is the filtrate actually, the water molecule. When we talk about the ultrafiltration, we want only the water to come out. So if you can see here, this is the positive pressure here. In the blood there is a positive pressure. In the filter there is a negative pressure. These blue marks are the negative pressure. The positive is this one, the red one, positive pressures, negative pressures. So with the pressure gradient from positive to negative, when it drag, it will just drag the water molecules. The blue ones are the water molecules. So this is the idea of ultrafiltration. Is it clear? The more the pressure, more is the, you create ultrafiltrate or you take out the more fluid. But what you need to remember when you create a more pressure and all that, you need to see the patient is hemodynamically stable or unstable. Now the adsorption, just remember the air filter. Suppose there is an air filter in your house. Over the period of time, after 1 month, 2 months or 3 months, that the dust will go and clog the filter. So you just need to check that filter or change the filter frequently. So the same with the principle applied to the adsorption is the removal of the solids from the blood because they cling to the membrane, and as the air passes through it, impurities cling to the filter itself, just now we said. The same is true about the blood purification. High level of adsorption can cause filters to clog and become the ineffective. So the more you use, the adsorption principle applies almost all in the dialysis. So this is just to give an example. When this is the blood, this is the filtrate. Certain plasma proteins in the bloods. So when on the filter, this will won't cross across the semipermeable membrane. It will just stand on there. It will just when we for the OPC poisoning, we do the charcoal. So what the charcoal will do, it won't do anything. It will just absorb the poison. The same thing apply here. When we talk about the adsorption, on the surface molecule, it will just get stick on that. It won't filter anywhere. It won't cross across. So when we talk about now CRRT, actually when in the ICU you do the CRRT techniques, ultimately every principle or every machine or whatever the mode you use, you will come across this only 3 or 4 or 5, SCUF, CVVH, CVVHDF, CVVHD. Now just focus on this slide. When we talk about the CVVHD, there is only hemodialysis. So what the technique is diffusion. So what in diffusion, blood flow on the one direction, the dialysate flow in the another direction, it will create a gradient and it will filter. So here the principle is diffusion, and when we talk about the CVVH, there is only hemofiltration by the convection. When we combine these two, there is a CVHDF. So to go ahead, when you use dialysate plus when you use replacement fluid, this is the CVHDF. If you use only CVHD, there is only dialysate. If you use only CVVHD, there is only replacement fluid. Is it clear? So this is easy to understand, but till you understand that, there is a tough time. So again, I will come back to CVHD. There is a diffusion, there is a dialysate fluid. CVVH, there is no diffusion, there is no dialysate fluid, there is only replacement fluid. That replacement is not to replace the blood what you lost. The replacement is to just create or drag the solvents. So SCUF basically is to perform the patient is placed on the CRRT machine and the blood is run through the filter. There is no dialysate or replacement fluid is used. Please remember that. This primary indication of SCUF is to take out the water. That's all. Slow continuous ultrafiltrate. The SCUF series primarily removes water from the bloodstream. The main mechanism of water transfer is ultrafiltration. When you do the SCUF, the amount of fluid in the effluent bag is only the amount what you take out from the patient. Suppose you put a 500 ml ultrafiltrate. When you do the SCUF in the bag, suppose it's the 500, that 500 come from the patient. That's clear. So 500 patient is negative. 500 ml is patient is negative. Now when we talk about the CVH, please remember there is no dialysis is used. CVH can be extremely effective method of solute removal and is indicated for the UMA or severe pH or electrolyte imbalance with or without the fluid overload. Because CVH removes solute via convection, it can take out large molecule. And we know what is large, small and middle molecules. So again, this is CVH. Please remember this. There is a replacement fluid. There is no dialysate fluid here. When we talk about the CVH, there is only replacement fluid. This is a pump heater. The blood comes from here. This is a semi-permeable membrane. The replacement fluid will do the convection and the waste will come out from here. Two things I want you to remember when you do the CVVH. When you perform the CVVH, the amount of fluid comes in the effluent bag is equal to the amount of fluid removed from the patient plus replacement fluid. Is it clear? Suppose replacement fluid is 2 liter and you took out around 1 liter from the patient. So it is around 3 liter in the effluent bag. One from the patient's body and 2 from that replacement fluid. Here there is a no dialysate fluid. Please remember that. When we talk about the CVVHD, the patient is placed on the CRT machine and the dialysate is run on the opposite side of the filter, but there is no replacement fluid. When we talk about the CVVHD, there is no replacement fluid. There is only dialysate fluid. The solute removal occurs primarily due to diffusion, and the dialysate can be tailored or promote diffusion of specific molecules. So when we put on the CVVHD, when performing the CVVHD, the amount of fluid in the effluent bag is equal to the fluid removed from the patient plus dialysate. Is it clear? So dialysate, suppose you put a 2 liter and you did not take anything from the patient. So ultimately what comes in the effluent bag is a 2 liter from that replacement fluid dialysate bag. Now this CVVHD, you are combining everything. You are combining convection plus diffusion. So you are combining everything. Whatever we know, that CVVH, CVVHD, CVHDF. So the CVHDF combination, the name itself is combination of CVVH plus CVVHDF. It's clear? So basically the patient is placed on the CRT machine with dialysate running on the opposite side of the filter and the replacement fluid either before or after the filter. Suppose you put the before filter, what will happen? You put after the filter, what will happen? So what is the advantage? You put before or after? Anybody has any idea? What is the advantage? Suppose you put that replacement fluid before the filter or after the filter? Yeah, everybody knows that before you put it, then there is a good chance that there is a good dialysis, but you put it after filter, the dialysis is not that may effective, and that issue with the clotting and all that. This is the most flexible of all the therapies and the combines the benefit of diffusion plus convection of the solute removal. Yeah, again this CVVHDF, please remember there is a replacement fluid and there is a dialysate fluid. CVVHD is combination of everything, CVVH plus CVVHD. CVVHDF, the amount of fluid in the effluent bag equals to the what you took out from the patient plus dialysate plus replacement. Is it clear? I think again to make this clear, the diffusion, this combined hemodiafiltration, blood comes from the blood comes from here. This is the dialysate fluid plus replacement fluid. Yeah, I'm finishing. Sorry. So this is basically a combination of CVVHD plus CVVHDF. Again, just 1 minute. Models of CRRT. Please remember when we talk about the SCUF, CVVHD, CVHD, and CVHDF. Look here, CVVH. There is no dialysate. There is no dialysate fluid. In CVVHD, there is no replacement fluid. In CVVHDF, both are combined. So whatever your indication, you can take a call from there. So this is the intermittent hemodialysis. Blood and the replacement fluid flows opposite to each other. This is SLADE actually. When you apply some filtration to the SLADE, it is called as SLADE-F. I think that's all from my side. Any question, I'll be happy to answer. Basically, the goal of RRT is to replace as best as possible the lost function of the native kidney. That's all from my side. I'll be happy to answer the question. Thank you.
Thank you, Dr. Chelani. It was an interesting session. I would now like to call on stage Dr. Valentin Lobo, MD Medicine, DNB Nephrology. He is a consultant nephrologist at KEM Hospital, Pune. His area of interest is management of TTP and thrombotic microangiopathy. His special interest is in hemodialysis and related therapies. He has published more than 100 publications Dr. Lobo will give you an insight on modality selection for renal replacement. Welcome, sir.
Yeah, sure.
Thank you. Thank you, Dr. Tapas and Dr. Gunadhar, both for having me here, and congratulations on this initiative to bring nephrocritical care to the forefront alongside mechanical ventilation and POCUS. So, as in the next 15 minutes, what I'll try to do is to illustrate with the help of some cases the principles that Dr. Akshay just told us and how we apply them when we actually start perform renal replacement therapy for our patients. Of course, if we have to choose a modality, it should be available to us. We would like it to be easy to use. We would like to not have hypotension in our patients. We want to achieve metabolic correction of hyperkalemia, acidosis, etc. We would like to not use an anticoagulant if we could. We want it to be cheap, and we want our patients to improve. So that would be an ideal modality. Let's see how they stack up practically. So this is a case, a 46-year-old man who was admitted to KM Hospital, PLHA. He had cough for 7 days, fever for 3 days, dyspnea, orthopnea, and on evaluation in the emergency department, he had tachycardia, tachypnea, edema, RALS, and a gallop, signs of LVF, and this was 2 years ago. His COVID rapid antigen test was positive. His oxygen saturation on 10 liters of oxygen was 88%, and his chest X-ray showed 4-quadrant opacities. So he was admitted to an isolation ICU where we found that he had anemia, CRP which was raised, a D-dimer which was borderline, blood urea of 98, a creatinine of 7.4, potassium of 5.6, ultrasound showed small echogenic kidneys, and a 2D echo showed a very poor left ventricular function. What would you do? Anyone? What would you put this patient on? Okay. So this was a patient who was in an isolation ICU, no renal replacement therapy facilities easily available, no water connections, no drains. So at the bedside, I inserted a Tinkoff catheter and started peritoneal dialysis. We used acute peritoneal dialysis solutions of 1000 ml with a dwell time of about 45 minutes. And in the first 14 hours, an ultrafiltration of 2.5 liters was obtained, and the patient came off the non-invasive ventilation. And 24 hours later, his RT-PCR was actually negative. So over the next 24 hours, he was already on PD, and we continued. We could get another 3,800 ml of ultrafiltration, and the patient was off oxygen as well. So he was taken to the cath lab. A coronary angiography showed 95% stenosis of the left main artery, underwent a stenting, and with dual antiplatelets started. The Tinkoff was still in, and on day 4, we put him onto a cycler and restarted his peritoneal dialysis. Once again, on the cycler in the daytime with 1000 ml cycles, you get cyclers give 5-liter bags, so 2 bags will give you 10 hours of dialysis and an overnight dwell with icodextrin. By day 7, he had stabilized out with a blood urea of 54 and a creatinine of 4.8, shifted out of the ICU, switched to manual CAPD, and discharged home. 1 year later, he has achieved a CD4 count of 256. His viral copies are undetectable. He's on heart, and he wants a renal transplant. My second patient is a 65-year-old woman, suffers from chronic kidney disease with a baseline creatinine of around 1.7. Following eating out, she had watery loose motions, vomiting for 2 days, fever for 1 day, and came to the emergency department with dyspnea and prostration. In the EMD, she was tachypnic, her BP was unrecordable, her heart rate was 42, she was intubated, given a bolus of 1.5 liter of fluid, at which time the BP was 60 systolic, noradrenaline was started, her ECG showed a complete heart block, her ABG showed a severe metabolic acidosis with a pH of 6.9 and a bicarbonate of 3. The arterial line was secured. She was given antihyperkalemic treatment. Her BP remained around 80 with noradrenaline and adrenaline. So isoprenaline was added on, especially with the complete heart block. And 6 hours later, this patient is anuric, has high doses of noradrenaline, adrenaline, isoprenaline. Her blood pressure is 90/46, and her lab has come back showing us that her creatinine is 6.9, and she has a potassium of 7.2 and severe metabolic acidosis and is on 3 pressors. Anybody want renal replacement therapy for this patient? CVVHD. Okay. What do we want to correct here? Acidosis. So I took this patient, So I took this patient on intermittent hemodialysis. The patient has a potassium of 7.2 and a complete heart block. CVVHDF will take several hours to correct potassium, whereas intermittent hemodialysis will correct it faster. So never mind the fact that this patient is on 3 pressors. What we did was to take her on SLED, blood flow of 150, dialysate flow of 300, urine output, ultrafiltration of 50 ml per hour. And within the space of 2 hours, her blood pressure after correction of potassium, her blood pressure was up to 120. Her heart rate was 102, and from a complete heart block, she was in sinus rhythm after correcting the potassium. So isoprenaline was turned off, the pressors were brought down. 6 hours after starting intermittent hemodialysis, this patient had a diuresis of 150 to 200 ml per hour. All the pressors were off, and we were able to stop dialysis, and she didn't require any further dialysis. She came out of the ICU on day 3 and with a creatinine of 2.2. My third case is one which I saw just 3 weeks ago. This was a 2-year-old girl, weighed 10 kilos, developed high-grade fever for 1 day, breathlessness which rapidly worsened, became unresponsive, and in the pediatric emergency room, her heart rate was 170. They gave her a 300 ml saline push, feeble pulses but no recordable blood pressure. She was intubated, shifted to the ICU on a ventilator for ventilation. They gave her 100 ml per hour of balanced electrolyte solution, put on noradrenaline first, then vasopressin. Her ABG showed us that she had a severe respiratory acidosis here. Carbon dioxide, her PCO2 was 59. They started meropenem and vancomycin for her, and when her hemogram came back, she had bicytopenia, leukopenia, and thrombocytopenia. Her serum creatinine was 0.8, but her LFTs were deranged. Bilirubin was 3.4 and enzymes in thousands. Her dengue, NS1, and IgM both were negative. Procalcitonin was 17. Her chest X-ray showed bilateral evidence of acute lung injury, all 4 quadrants. CSF done under platelet cover, not contributory. CRP of 65, interleukin 6 of 2,800, and USG is now showing B lines, pleural effusions. She has a hypokinetic LV with an ejection fraction of 20%. What does one do? Anyone? How many treat children? Nobody. Okay. So day 2, she has intermittent blood pressure readings of 85 to 90 systolic. By this time, she was on full doses of noradrenaline, adrenaline, and vasopressin. Both adrenaline and noradrenaline at 1 microgram per kg per minute, vasopressin at 4 units per hour. Her bilirubin has gone up to 5. Her ABG is showing worsening CO2. Her bicarbonate is beginning to drop, and the blood culture says there is an early growth, not identifiable as yet, of gram-negative bacilli, so colistin was added on. 12 hours later, she is becoming oliguric. Her urine output is 2 to 3 ml per hour. She was put onto high-frequency oscillator. Her USG shows a full IVC now, B lines in all quadrants, and her fluid overload is 1.7 liters, which for a 10 kg child is about 17%. And we know that when fluid overload increases by 10%, mortality increases. So we put an art line in, and her blood pressure on all these pressors, and now dobutamine has been added, is 72/18. So we started CRRT using the neonatal filter, the HF20 filter, with a blood flow of 50 ml per minute, a dialysate of 500 ml per hour, pre-blood pump replacement fluid at 140 ml per hour, replace post-pump 100 ml per hour, ultrafiltration of 10 ml per hour with heparin. The effluent rate here is 750 ml per hour. So this is pulse high volume hemodiafiltration because the effluent is coming at 75 ml per kg per hour. So this is the septic dose of CRRT and not a renal replacement dose. And the transmembrane pressure was 54 with filter drop pressure of 21. On 12 hours after starting CRRT, she had achieved an ultrafiltration of 85 ml. Her cumulative fluid balance was still 1.8, but her blood pressure on the same supports from 72 has moved to 104 by 43. They started to decrease her pressures at this point of time. Her lactate was 4.3. Transmembrane pressures are going up. The APTT was prolonged, so we stopped the heparin for 2 hours and then restarted. And here we converted her after 12 hours to a renal replacement therapy from a high volume at 35 ml per kg per hour. 24 hours later, we had an ultrafiltration of 236 ml. The patient remained anuric, and at this point of time, probably because of the stopping of heparin temporarily, after about 35 hours of treatment, the filter clotted, by which time 345 ml of ultrafiltration had been achieved. So we have 3 cases, 3 different renal replacement therapies, but our goals of renal replacement therapy remain the same. Correct electrolyte and acid-base abnormalities. If you can remove inflammatory markers very well, good enough. Optimize fluid balance, maintain hemodynamics without hypotension, and avoid complications, and ensure nutrition. So this is what KDIGO says, and it's extremely vague. They say you could use intermittent or RRT or continuous. They are complementary, not competitive. Use CRRT for hemodynamically unstable patients, for those with traumatic brain injury or raised ICP. Our Indian guidelines are a stage better than that. It recommends that all forms of RRT, including SLED, can be used, that both SLED or CRRT may be equivalent for patients who have hypotension or are on pressors. For raised intracranial pressure, CRRT still appears to offer an advantage, and for patients less than 10 kg in weight, PD, or if the expertise is available, CRRT, as in this patient, can be used. Acute brain injury is a particular situation where CRRT appears to be superior to other therapies, and the other situation is if a patient is on any other extracorporeal therapy like ECMO, which is continuous, it makes sense to combine another continuous therapy like CRRT in this situation, as in this case which I had. This was an 8-year-old girl with myocarditis. She's on VA ECMO complete heart-lung bypass, and it makes sense to combine the CRRT into the ECMO circuit, which will be shown. What about peritoneal dialysis, as I showed in the first patient? Peritoneal dialysis is a truly continuous therapy, and it is associated with less hypotension and less perturbation of the intracranial pressure than even CRRT. I call it the Cinderella of renal replacement therapy, and when one reads about the cities in the United States where patients died because of a lack of a CRRT machine, I always wonder during COVID, why did they not use PD? That's what we would have done. It could have saved lives in this situation. You need no infrastructure, no water treatment, no machines. It can be done at any place in any hospital, even in a primary health center where it has been done. What about intermittent hemodialysis and SLED? If you're looking to correct electrolyte abnormalities and metabolic acidosis, there is no better therapy. So, no matter what a patient's blood pressure, if it is being driven, as in the patient I illustrated, where complete heart block is being driven by hyperkalemia, intermittent hemodialysis will pull this patient out faster than any other therapy. So electrolyte imbalances, metabolic acidosis, think intermittent hemodialysis or SLED. Yes, there is a small risk of disequilibrium, and perhaps this therapy would not be suitable for those patients who have hypotension, who are on high pressors, and who may have raised intracranial tension. This is a study that was done by Vincent Wu's group, in which they compared in a randomized crossover fashion patients who had traumatic brain injury to CRRT and SLED, and what they found was there was actually no difference between CRRT and SLED in the change in intracranial pressure or the cerebral perfusion pressure. So one more bastion of CRRT appears to have been breached by SLED. SLED is versatile. Here I have combined it with the cytosorb. Here I have combined it with plasmapheresis. In the 2010 swine flu epidemic, we didn't have CRRT, so I combined SLED with ECMO in those days. CRRT, of course, better hemodynamic stability. As in the patient that I showed you, the HF20 set has just 58 ml of volume in the blood, in the extracorporeal circuit. Now, no intermittent hemodialysis therapies tubings, most of the tubings contain more blood than the filter or the dialyzer. So it's only the HF20 filter set which is meant for neonates, where you can have a really small volume of blood, and this is therefore suitable for patients who have small blood volumes, as in our patient whose total blood volume would have been about 1 liter. So CRRT in this situation, you can keep blood flow rates as low as 10 ml per minute. This is how small the filter is. This is the patient and the filter, and you can adjust the blood flow rates and the replacement fluid rates to very slow rates. This is not a setting, otherwise it would tell you what the filtration fraction is. So, is there anything to choose between in the literature? This is the state of our knowledge as of 2021. There have been 30 randomized controlled trials, and a meta-analysis looked at 2,576 patients for an 8-point comparison. What they found was that intermittent hemodialysis was intermediate, and CVVH is the least effective of all therapies with high or moderate certainty evidence. Relative to CVVHDF, SLED-F is the most effective at reducing mortality, and others are intermediate. CRRT may increase renal recovery compared with intermittent hemodialysis, but low certainty and limited by imprecision. Both CRRT and intermittent hemodialysis are worse for renal recovery compared with SLED and PD. PD is associated with the shortest duration of renal support and length of ICU stay. SLED may be associated with shorter length of hospital stay and days of ventilation, and CRRT and intermittent hemodialysis increase hypotension and bleeding compared with PD. This is what they showed. SLED has a 42%, SLED-F has a 42% reduced risk of mortality compared with CVVHDF, which is significant. None of the others are. And look at PD. Best renal recovery rates, shortest support duration, and shortest lengths of ICU stay. So to summarize, diffusion in intermittent therapies, best small solute clearance. If you want to correct electrolytes and acidosis, that's the way to go. Correct continuous therapies, better fluid balance, lower hypotension risk. Combining the two therapies as in SLED-F, very effective. A unit expertise ultimately may determine which therapy you choose, and hybrid modalities will be the treatment of the future. Thank you. No questions?
Thank you, Dr. Valentine. Now, I would like to request Dr. Kiran Shingote, Unit Head, Apollo Hospital, Navi, Mumbai, to give the mementos to the faculty member. I would like to request Dr. Ravindra Nikhalji, Dr. Tapas Kumar Sahu, and Dr. Gunadhar Padi to come to the stage.
Yeah.
Thank you, Dr. Kiran. I would now like to call on stage Dr. Ravi Shankar, our DMS at Apollo Hospitals, Navi Mumbai, to offer our token of appreciation to Dr. Akshay Chalani, who is an intensivist and medical advisor at Apollo Hospitals, Navi Mumbai, and to Dr. Valentine Lobo, who is a consultant nephrologist at KEM Hospital, Pune.
I would like to call the marketing team and get the lamp. So before we continue with our next session of the day, as we all know, lighting the lamp is a symbol of dispelling ignorance and darkness and replacing it with knowledge, wisdom, and enlightenment. It holds a significant place in our culture and tradition. So with that, I would like to invite our team of intensivists, Dr. Akshay Chalani, Dr. Gunadhar Padhi, Dr. Shovadeep Sen, Dr. Divya, Dr. Swapnil, also Dr. Tapas Sahu, Dr. Amit Kumar. I would also like to invite our nephrologist, Dr. Ravindra Nikhalje, Dr. Ashwati Haridas, and our leadership, Dr. Kiran Shingote, Unit Head, Apollo Hospital, Navi Mumbai, Dr. Ravi Shankar, DMS Apollo Hospital, Navi Mumbai, Dr. Narendra Patil, Deputy DMS and Consultant Microbiologist, Apollo Hospital, Navi Mumbai, Sneha Vaidya Ma'am, Regional Nursing Director, Apollo Hospital, Navi Mumbai, and Avanti Pawar, Unit Marketing Head, Apollo Hospital, Navi Mumbai, for lighting the lamp.
So I would like to call Dr. Kiran. He is our unit head, and he just to address the delegates and participants and to all the faculties. Actually, our regional CEO sir, Mr. Marathe sir, is not He has gone for some emergency meeting. So otherwise you would have also been had there and much more delighted. And with this, all our administrative staff, Ravi Shankar sir, Avanti madam, regional marketing head, Sneha madam, regional nursing director of across the Apollo hospitals, Western Zone. So let's have some few words, and I invite Dr. Kiran, please.
Thank you. Thank you, Dr. Gunadhar. This is a really proud moment for Apollo Hospital, Navi Mumbai. I'm sure everybody knows that we are, 5 years old hospital. Lot of activity we do academically. This is, I think, pinnacle of that. Going forward, our target will be to accommodate such events more frequently. Thanks to entire ICU team led by Dr. Gunadhar, Dr. Akshay, who is trying to arrange such kind of event very frequently. Thanks to all faculty members who was here and who is helping us to create such kind of I'm sure there are international and domestic both faculties who are helping to make this event successful. Thank you all for all of you participants who are there and ensuring this event is more success. And last not least, I'm sure the sponsors are there to help us to make this event more reliable and more frequently. Thank you very much for all of you and have a nice day. Enjoy the session. Thank you.
Now I would like to invite our DMS sir, Dr. Ravi Shankar, to have a few words.
Like Dr. Kiran has mentioned, we are really proud to have such kind of a gathering here in our campus and welcome all the delegates and all the faculty members. And I just want to stress on one fact that this is a different kind of a CME. This is not a CME, this is the course, this is the workshop in which there is a lot of emphasis on hands-on training rather than boring lectures and talks and slide presentations. So one should make the most of it. Let it be an interactive session, clear all your doubts. There are examinee corner, there are hands-on training sessions in which you should clarify all your doubts, and you must go back richer after attending this 3 days event. I wish you all the best. Thank you very much.
So now we'll be doing the inauguration of our Nephro Critical Care Manual, and it is one of the unique manual. It is published by Apollo Hospital in 360-degree critical care, and this is be distributed to all the faculties and delegates. So I would like to request Ipsita to announce the names, and we'll have this ceremony. And after that, we will having the tea and the lecture. Thank you.
So I would like to call Dr. Tapas Kumar Sahu and Dr. Sananta Kumar Das, who's the editor for the book Nephro Critical Care. Also all our intensivists, Dr. Akshay Chalani, Dr. Gunadhar Padi, Dr. Suvadeep Sen, Dr. Divya, Dr. Swapnil. Also, I would like to call our nephrologist, Dr. Ravindra Nikhalje, Dr. Ashwati Haridas, and our leadership, Dr. Kiran Chingote, Dr. Ravi Shankar, Sneha Vaidya ma'am, and Avanti Pawar, Unit Head Marketing, to launch the book.
Please. Narendra. Narendra.
I would also like to call Dr. Amit Kumar to join us. I would also like to call Dr. Narendra Patil, Deputy DMS, to join us. Give a big round of applause for the book launch.
Amazing. Thank you. Not getting us miss or narration. Okay, so please, थोड़ा सा आगे चलो,
So this is the first edition what we have tried to do within a very short time. Hopefully with the newer editions coming, we will be adding more newer articles as well as newer topics that would definitely improve your existing knowledge. Thank you. So now I would request Dr. Akhilesh, please, to felicitate our international faculties, Dr. Sanjay Chaudhary, who has come from Mayo, USA, and we are really privileged to have him here. In short notice, he accepted our invitation. He is a vivid nephrologist come intensivist, and he is practicing at Mayo, and he will be sharing his experience as well as expertise in next 2 days. He is having today also presentation, tomorrow also, and he will be also having hands-on in our 2 days nephrocritical care course. Dr. Sanjay Chaudhary, sir, please.
Next, I would like to invite Dr. Valentine Lobo to felicitate our one of the international faculty. He came from Australia, Dr. Sanat Kumar Das. He is working as a critical care specialist and consultant. So, thank you, Dr. Sanat, for joining us from Queensland, Australia. Thank you. So, Dr. Ramanathan is our next esteemed international faculty from Singapore. So, with all utmost difficulty, with busy schedule, he reached us, and he has committed for 2 days the time to this workshop, both theory and practical. Please come here, sir. And I would like to invite Dr. Nikhalji to felicitate Dr. Ramanathan. So he is the senior most intensivist, ECMO physician, ECMO consultant, transplant physician at Singapore General Hospital, and lot of publication, research, and he is one of the international name in the critical care. So with this, we'll be starting with our next lecture schedule, and I'll tell Dr. Ishita to continue. Thank you.
I would again like to thank the international faculty for joining us here today. Your participation will add a global perspective to our discussions and learning. We will now begin with our lectures. Our next speaker is Dr. Sharmili Sinha, MD Anesthesia, DNB. She also has an European Diploma in Intensive Care and a Diploma in Hospital Management. She is a Senior Consultant, Critical Care Consultant and Intensivist at Apollo Hospitals, Bhubaneswar. She has done an advanced training course in intensive care from Australia. She is an Indian representative at the World Federation of Intensive Critical Care. She is a member of the ICU Liberation Committee USA. She is also an awardee of the President Citation Award and a recipient of Bharat Karma Shri Award.
So just for 2 minutes, actually, we have with us consultant intensivist across the Apollo. So we'll just like to invite before this talk Dr. Sarmili, Dr. Jay Kothari. He is the senior most intensivist consultant from Apollo Ahmedabad, and Dr. Srinivas Samavedam sir. So he is one of the key person in Indian Society of Critical Care Medicine. And just a felicitation, and then we'll followed by the talk. Dr. Sarmili is the consultant intensivist at Apollo Bhubaneswar. So please join us. And Dr. Jay Kothari. So I would like to invite Sneha madam and Avanti madam to please felicitate Dr. Sarmili. Sir, please come up to the stage. Dr. Sarmili, please. So Dr. Jay Kothari, he is from Apollo Ahmedabad. So please. So I request Neha madam to felicitate Dr. Jay. And there are a lot of intensivists from Gujarat actually in this group. So I am sure they must be delighted to have Jay here. So. Thank you. And Srinivas sir, please. I request Dr. Kiran, please. Dr. Kiran, please felicitate Dr. Srinivas. So Dr. Srinivas Samavedam is from Hyderabad. Now he is one of the key person in Indian Society of Critical Care Medicine. He has his own YouTube channels. So my 20 years of journey is an intensivist, so I request all of you to please go through the channel. There are a lot of parts. So it will be definitely eye-opener for all the intensive care practitioners here. Thank you. So with this, I request Dr. Sarmili to present the talk. Thank you.
Thank you all. Thank you. Please continue the prayer. Thank you.
The screen needs to be on. Screen on. Good afternoon, and I would like to thank immensely Dr. Gunadhar Padi, Dr. Tapas Sav, and the organizing team of Apollo for this kind invitee. It's really a pleasure to be here in this kind of first ever nephrocritical care in the country. And we have heard the eminent speakers ahead of me in this since morning, and I'm glad that I have been given a very specific topic, that is to talk about the perfusion pressures or optimum perfusion pressures to prevent onset of acute kidney injury, and how do we go about the pre-dilution or post-dilution mode of CRRT. So you have heard about, obviously it's been covered regarding the staging of AKI, CRRT, indications, the best modality. You heard Dr. Loba talking about it. So what is the best possible way to prevent the onset of AKI? Now, as you know, AKI itself is a spectrum. It's a diverse, it's a condition which is multiplied or accentuated by multiple diverse factors, and perfusion pressure is definitely is one of the important part of it. Perfusion pressure, as it is important for the GI tract, is for the cerebrum, for the brain, as similarly it is important for the kidneys as well. Now kidneys, if you see, it occupies size-wise less than probably 5% of the total body size, and yet it receives around 25% of the body's cardiac output. Now a very common scenario in ICU, when you receive a patient with sepsis, that's the commonest kind of admissions we get to our ICUs. Patient either comes with sepsis and either comes with septic shock or gradually develops septic shock during the stay in ICU. Now how do you go about optimizing their cardiac output? Because that's what is going to determine your organ perfusion. And when we say organ perfusion, it is from tip to toe, starting from brain to the skin and to the kidneys, GI tract, everything is covered under that. What are the common modalities to treat increase cardiac output in such situations? It is mostly by fluid resuscitations, and after a certain period of time, we we adhere to institution of vasopressors and inotropes in some of the situations. But how much fluid we give, this continues to remain a topic of debate, and you would have heard many speakers in the last 2-3 decades talking about how to optimize fluid resuscitations and how to go about the vasopressors. But what is your target? Is it a particular number of the mean arterial pressure or the perfusion pressure, or it is the kind of assessment, clinical assessment, or it's a combined judgment that we need to exert to optimize these patients? So what MAP is adequate? MAP, we are all of you are very well versed with this term, mean arterial pressure. But what is it and how much of it is adequate for these patients? Now there's a slight printing mistake here. It is 65 to 70. So it's a multi-center randomized controlled trial which has looked at a map of say 65 to 70 millimeter of mercury versus 80 to 85 millimeters of mercury in patients who had septic shock and who had some kind degree of AKI, to see their progression of AKI or onset of AKI. And they found no difference in mortality nor in the renal endpoints, that is the AKI stage 2 or the patient reaching on to require the renal replacement therapy. So there was no benefit, it was thought of, to have or target a higher mean arterial pressure in these patients. Why so? Because it's a common tendency whenever a patient either comes to the emergency department or to intensive care unit and there's a shock stage. We all are well versed, and it's good that we are well versed with the process of starting with the process of fluid management. But if the blood pressure is not improving, obviously you start giving vasopressor, which is commonly the noradrenaline. But you cannot keep on pushing fluids or noradrenaline to a very supra high doses just to build up a pressure head of say 80-85, because you think a higher pressure will get converted to a higher renal perfusion, and thereby your urine output will be better, or your prevention, or you can prevent the progression of AKI, because it does not really, numbers do not translate into the physiological benefits at that point. And in the process, you would have actually harmed the patient by pumping in more fluid, and obviously less of or more of these vasopressors are also not good, because we have GI tract also which might go into mesenteric necrosis, mesenteric ischemia. It is arrhythmogenic, it's also. So that is why we need to be careful about aiming a particular map of around 65 to 70. And this applies more to patients who are not known to be chronic hypertensives. Of course, we'll talk about the chronic hypertensive which have been on higher doses of say multiple antihypertensives. The target would tend to little bit differ there, because there are some literature exists which aim at a potential benefit of aiming a slightly higher MAP targets in those patients who have been chronic hypertensives and have been on multiple antihypertensive therapies. Now what about, we are talking about MAP, what about systolic blood pressure itself? There have been a couple of studies also which have compared the systolic blood pressure targets of say 110 to 139 versus a little higher blood pressure of 140 to 179 millimeters of mercury. This is the context of chronic hypertensive that we have been talking about. And they found that in the patients who have been chronic hypertensives, if you are going for a lower targets, that is the first group, it was associated with more adverse renal outcomes. So obviously there is a body autoregulation, as we call it for cerebral, similarly for renal autoregulation also. Body gets used to a higher perfusion level because systolic head. And if you are trying to lower and accepting low systolic head blood pressure for them, that tends to be more adverse renal outcomes in these patients. Noradrenaline remains, as a consensus, remains the first agent of choice for septic shock in all ICU patients, followed by vasopressin. Now, vasopressin has been lately found to have a slight edge over noradrenaline as a vasopressor because of two reasons. One is that it causes, for the kidney point of view, it causes preferential post-glomerular vasoconstriction. So there is an efferent arteriole and there is an efferent arteriole. So it causes more selective constriction of the efferent arteriole, thereby increasing the blood flow content within the glomerulus and thus increases the glomerular filtration. So it is thought to have a second slight edge over the noradrenaline, as well as vasopressin also for patients who have got GI tract of sepsis. Also it seems to have a better beneficial effect compared to noradrenaline. Now this is a diagram. I am not going to explain it further because I am sure it will be covered or would have been covered during the course. So apart from mean arterial pressure or systolic pressure heads, there is some other heading also called diastolic pressure. Because if you see a pressure of a septic shock patients with an arterial line or without an arterial line, you will get various permutation and combination. There will be both systolic and diastolic low. There will be systolic high and diastolic very low. So the map will be different, and you will be having, both systolic will be high and diastolic will be fluctuating really, and map will be maintained. So these are the various kind of permutation and combinations, and especially if you put an arterial line and if you have properly calibrated the lines, then you see these values actually tend to vary. But why I am saying this is because even if you are getting a good map but your diastolic is very low, that also indicates that your perfusion is not adequate. So low diastolic pressure in itself is an indicator, because we had a patient who was lately admitted with us. He had a good blood pressure of say 150 and diastolic was used to remain say 55, 70, and his map was maintained. Even his urine output was maintained. But we are not happy with a lower isolated diastolic low blood pressure, because that's also an indicator that your perfusion is going to be affected at the renal level. And the glomerular capillaries, these are just anatomy and physiology. They are mostly formed through the glomerular capillaries, which come through the afferent arterioles, and there is a tubular network of vascular plexus which surrounds the tubules as well. And these are the ones, the tubules and the glomerulars together, they recite the autoregulation at the renal level, and they decide the balance between the renal blood flow and the glomerular filtration rate. If you see, the major seat of pre-glomerular resistance is at the afferent and the cortical radial arteries, and this is regulated by two responses, mainly the myogenic response and this tubular glomerular feedback at the level of the macula densa. Now this myogenic response is an earlier one, which is decided by an afferent arterial change in the afferent arterial tone in response to change in the intraluminal pressure. Intraluminal pressure means it is either your perfusion pressure or the systolic, diastolic, or the mean arterial pressure, whatever you want to choose at that point of time. But what is this TGF? That is tubular glomerular response. This is a more delayed response, and it is activated by electrolyte delivery and the reabsorptions. So there is a vascular component and there is a tubular component. So they are acting in very close synergy with each other to decide the feedback and generate the autoregulation. Thereby the cerebral perfusion is decided in the process. And in the vicinity also you have dictators or like local mediators like angiotensin 2 and this arachidonic metabolites nitric oxide. This we have already discussed. So what about this perfusion pressure? We talked about this three pressures like mean arterial pressures, systolic pressure and diastolic pressure. Now there has been some studies which has looked at the perfusion pressure deficits. When you call this mean perfusion pressure deficits, it is, or perfusion pressure is decided by some of the patients where they looked at around all these parameters, and also they measured the central venous pressure through a echo. And this was decided as like mean perfusion pressure was decided as MAP minus CVP, diastolic perfusion pressure was diastolic arterial pressure minus CVP, and the perfusion deficit was calculated as difference between this pre-morbid and ICU pressures. Now the patients who were admitted before that, if they had some readings of blood pressure at least 2 or 3, that was taken into account, and also post admission to ICU it was taken into account. Why it is important? Because it is in the context of those chronic hypertension that we have been talking about. If you have a 25-year-old lady who has come with say puerperal sepsis, she is normotensive. You go by the standard 65 or say 65 to 70 of MAP by Goletol, etc. Those therapy fine. But if you have a 50-year-old man who has come with urosepsis, has been on hypertensives, on 3 antihypertensive drugs, would you like to aim for 65 or 70? Probably the answer is no. I tend to maintain a little higher blood pressure map for these patients, around 80 to 85, at least for first 48 hours. But of course, you have to take into account other comorbid factors, but there is a difference. They are not the same that you would like to treat them as. And they found that this AKI progression, patients who progress to AKI, they had a greater deficit of this diastolic perfusion pressure, mean perfusion pressure deficits compared to those who without AKI progression. So there was a greater difference in the pre-morbid and ICU admission blood pressure in these patients. So that is why it is important to know what has been their pre-existing blood pressure and if they have been on the drugs, etc. or not. Now I think this comes to the second part of the discussion. It's about pre and post dilution mode for CRRT. Largely I think it has been discussed during the day and then we'll have some clinical stations also in the second half. Regarding, I'll just touch upon this major differences between these modalities. In the post-dilution method, you have this replacement fluids after the filter. And in the pre-dilution mode, you have the replacement bag fluid before the filter. Now what happens, there are advantages, and there is a new modality also called mixed dilutions. I have never used this mixed dilution method. Probably the nephrologists would have some idea about that, would invite their comments on that later on. So in the post-dilution method, you see the advantages is it is effective in solute clearance and removal. Mostly the low and the middle molecular weight toxins and the molecules are removed better in the post-dilution method, and it also decreases the consumption of the replacement solution. So solute clearance is better and requirement of fluid is also less. But what are the disadvantages? Because you are not diluting, the blood is coming and going through the filter and then you are exposing to the replacement fluid, there is an increased hemoconcentration. So there is chances of increased blood clot formation and protein sticking deposition in the filter is more. So filter life can be compromised, and it also requires very high blood flow rate so that it does not allow the blood to stick in there and try to prevent clot formation and protein depositions, and also increases the membrane stress. So TMP pressure, that is transmembrane pressure, might be increased, and if your pressure is increased, what is the risk? Risk is about losing the albumin. Because as such, most of these patients are deficient in nutrition and chances of protein loss is very high. As such, during this extracorporeal therapy and the nutrition status is always perennially compromised, whatever said and done. So that is a big loss or the risk in these patients. Now what about pre-dilutions? As you would normally imagine, if you are putting it before the filter, the blood is getting diluted. But and it reduces obviously the risk of clot formation and protein depositions in the filter. And it can be conducted thus in the low blood flow rate and reduces membrane stress. But this is at the cost of reduced solute clearance in these cases, because suppose you are talking about urea, creatinine, etc. They will be diluted. So your solute clearance, convective solute clearance will be less in these patients, and there is increased consumptions of replacement fluid in these patients. Of course, when limited setups, CRRT is cost more than SLED and other modalities of replacement therapy, so it will add to the cost as well. Now, between these two, there is a new entity called mixed dilutions. There is a good paper published in 2021, and they say about you can also combine these pre and post dilution methods, and for that you actually need 2 pumps. And there is an automated system which can sense your pre and post filter pressures, and accordingly they can decide the infusion of the fluids both in the pre and the post dilution positions. And thus by all the disadvantages of both can be taken care of. So as I said, it is the replacement fluid is placed both upstream and downstream of the filter position is there, and it combines beneficial effects of both as well as the disadvantages of both the techniques are also taken care of. And that is a TMP control mode. This is the mode I was talking about. It automatically adjusts and controls the infusion ratio between this pre-dilution and post-dilution and the total infusion volume. Thereby your total volume of the fluid infused is controlled and can be reduced. And of course, there will be better solute clearance with good control of transmembrane pressure, which will reduce the risk of albumin leak or protein leak in these cases. And this is the formula. You can read it from this reference. And if you have to talk about how you decide the fluid volume, this is the formula. And this you can read from this paper. We are just trying to touch the practical points. Convection volume is one aspect. I think why we are talking about this pre-dilution, post-dilution, etc. This is all in the context of convection volume, because it is seen that if you are giving a high convection volume, mortality is better, because solid clearance is better, patients, everything, all other aspects are better. There are a couple of studies in this Japanese one which had shown that it is related to improved survival compared to the conventional hemodialysis and improved cardiovascular outcomes as well. And it's also good for maintaining the serum albumin levels, because the patient where they use these higher convection volumes and patients who had low convection volumes, less than say 30 liters, they had almost similar albumin levels. So protein loss was not a concern in these cases. How this high volume hemodiafiltration is important? Because this volumes, the benefits are multiple you see. They have better cardiovascular outcomes, better intradialytic hemodynamic stability, because this phenomenon of IDH, intradialytic hypotension, is also, if it's happening recurrently, it is also more damaging to the kidney and compromises the existing kidney functions, which might have a probable chance of recovery or preservations in the future. And it is also less inflammation related, dialysis related complications are rare. Improved derangement in the calcium phosphate hemostasis, which is a very frequent complication in patients, especially who are has been on CKD, and vascular calcification rates are also less. Post dilutions we already have discussed, but in the context of, I would say, I'd like to point out, in the context of Caucasians and Asian populations, for this post dilution hemodiafiltration, actually you need a higher flow rate, and for this actually you need a reliable vascular access, and adequate anticoagulation throughout the procedure is needed. In Caucasians, maybe because of our geneticity or genetics or body texture, the size of this the blood flow rate in the fistulas is less. It is less than around 400 mils per minute. And in this context, actually the pre-dilution could be a better choice in these cases. Nevertheless, it cannot be generalized for all patients, and at the end of the day, we have to exercise a personalized approach for each patient depending on their body kinetics and the disease pathophysiology and stage. So the key points I would like to say that perfusion pressure of around 65 to 70 is good enough to prevent progression of AK. However, do exercise caution in patients who are mostly chronic hypertensives, and if they have been on multiple antihypertensive drugs at home. Because a patient who comes with preserved blood pressure with sepsis in the unit, you need not continue the antihypertensives, because within 48 hours the patient might likely progress to shock, which has got a high chance, and then you go into a precipitous hypotension or refractory shock. So do hold your blood pressures. It should not be chatted, because these are old medications. You should not be just chatted, as it applies for anti-diabetic pressures also. Post and pre-dilution methods have their own advantages and disadvantages, so a personalized approach has to be exercised for those cases. And monitor remains key, because any patient who comes, nevertheless, even if you think I want to prevent hypotension, it is not that easy. And patients, suppose many times when they have a preserved blood pressure, we just tend to leave them with a non-invasive blood pressure. But you have to train your staff and team to be very accurate and vigilant about the progression of the blood pressure, because it may be the diastolic pressure might start falling, or it may be your MAP starts falling, or it may be your systolic blood pressure starts falling. So these three components of a blood pressure, like systolic, diastolic and the MAP, all three have to look at together, because any abnormality of this can happen depending on the vascular tone, because of the autonomic intactness of a patient, and these all are early predictors of compromised perfusion in these patients. So not a single value is important, it's a serial value, and also three components of the blood pressure are important. Nevertheless, it's a multifactorial thing, along with also you have to take care of other nephrotoxic parameters in the patient. So stick to basics. Prevention is, I would say, definitely better than cure, and not just be guided by evidence, because it's your bedside experience, clinical experience at the bedside, which should stand superior to everything. Thank you all for your patient listening. Any questions or anything? Any questions, or I think we conclude? Okay, thank you. Yes. See, suppose you have a patient of blood pressure of 140/50. So definitely your diastolic, this is also vasoplasia. This also indicates vasoplasia. Patient is already in a vasodilated state, profound vasodilated state, I would say. And imagine this for a patient who has been a chronic hypertensive. Usually their diastolics are in the ranges of 90 and 100s, and you are giving drugs to control that blood pressure. So if he has come to a stage of 50, definitely his vasoplasia is profound. So you should be treating these patients. What I suggest is put an arterial line early for these patients. You have to regulate it well, like you have to calibrate it well and monitor it. And you can start a little of vasopresses early for these patients to maintain a normal at least diastolic blood pressure of close to say 70 or 80. But 50 diastolic blood pressure definitely it's a prelude that your patient has a significant stage of shock, and precipitously they drop blood pressure. And after that you start noradrenaline, it goes, the dose keeps on increasing, and then you add the second vasopressor, which is usually vasopressin. And this patient, I would say, actually have a low threshold to start vasopressin early. These things you cannot find in literature, but if you see these patients at the bedside, because vasopressin will have a profound vasopressin effect in these patients who have a profound diastolic vasoplasia and reflecting as disproportionately low diastolic pressure compared to systolic pressure. And these are the actually subgroup of patients we tend to miss. Because if you have a say 90 by 40 blood pressure, it immediately catches your attention and the nurse will come and tell you, or your junior doctor come and tell you. But if you have a 140 by 50, because your map will be somewhere hitting around say 70, 80 plus, you will have a false assurance that this patient is doing well. This map thing came from this EDT, this EGDT, early goal directed therapy trial of 2000, which has been prevailing and it has generated very good practice. We should stick to that, but however, we should be also cognizant of the variants of vasoplasia, which is a reflection of this low diastolic blood pressure, and also we are talking about this perfusion pressure deficits. And this applies more to these patients who have chronically dysregulated autonomic systems, bad diabetics, bad hypertensives, and even bad CKDs also. Thank you.
Thank you, Dr. Emily. It was an interesting session. Moving on to our next speaker, Dr. Rushi Deshpande, Director Nephrology, Jaslok Hospital and Research Center, Mumbai, and Director Critical Care Nephrology at Sir H.N. Reliance Foundation Hospital, Mumbai. He is an honorary nephrologist to Tata Hospital, Saifi Hospital and Bhatia Hospital, Mumbai. He has been awarded by the President of India Gold Medal in DNV Nephrology. He has also been awarded by Dr. APJ Abdul Kalam. His area of interest lies between kidney transplantation, resistant or difficult management of hypertension. Today, he is here to talk about myths and evidence in nephrocritical care, all modalities of RRT, dialysis, dosing and timing, and other preventive treatment for contrast nephropathy. Over to you, sir.
Thanks. This is slide change.
Okay. Thanks. Good afternoon. I think it's still good morning. Yeah. Good morning, everybody. First of all, a big thanks to Dr. Ravindra Nikalje and Dr. Gunadhar for the kind invite. It's a pleasure to be amongst all of you here. Budding physicians, intensivists and nephrologists who have come to attend this critical care nephrology meet. So as we all know, critical care nephrology is an expanding branch in both intensive care as well as in nephrology. And all of us are quite interested in learning this particular specialty in more detail. So the talk of the day given to me today was this. So these topics I am supposed to cover in the next 15-20 minutes. Modalities of renal replacement therapy, dialysis dosing and timing, hemodialysis and other preventive treatment for contrast-induced nephropathy. Now, to be honest, I could speak here for a couple of hours on these talks. Okay, but I'm not going to do that. Okay, so we'll try and see what messages I can give in terms of these three topics that I'm supposed to cover in the next 15-20 minutes. So what are the different modalities of renal replacement therapy? For now, we'll just concentrate on that. So you are in the ICU, you are with your patient with a kidney injury, and what are the different modalities, and how will you decide what to do? So these are the different modalities at your disposal, right? Intermittent hemodialysis, or you could also use, just isolated ultrafiltration, what we call as SCUF, or, in our patients. The other modality is a SLED, or a sustained low efficiency dialysis, or you could actually add an amount of filtration or convective clearance to this. So, it's the age of hybrid therapies. So every therapy that is being hybridized. And when you look at continuous renal replacement therapy, just look at the number of terminologies there. Whether we are doing, so basically why is all this confusion of terminologies coming up? Why have so many words and nomenclatures for therapies that we are doing? So this is a simple way to kind of remember this. What is it that you are looking at? So in intermittent IHD or intermittent therapies, SLED and continuous therapies. So when you look at dialysis, you are talking only diffusive clearance. Okay? When you are talking filtration, you are talking only convective clearance. And when you combine the two, you have diafiltration. So whenever you see, say, CVVHDF, or then you are talking, that is what you are doing in your ICUs most of the time. Okay, you are combining diffusive clearance with convective clearance. And that is where this, so can you add a convective clearance on the regular dialysis machine? Actually, we don't do it so much, but you can. And you can actually call it as a SLED F, where you are adding a filtration component to your SLED. Is the dialyzer very different for CRRT and for SLED? Is it a very different dialyzer? Actually, no. It is not very different from each other. You could do similar treatments with both the dialyzers. Okay. So I think somewhere we have to kind of see through these terms, make ourselves very familiar with them, and try and use what is most important for our patient at that point in time. Okay. So what other difference is there is the duration. Intermittent hemodialysis by tradition is 4 hours 3 times a week. SLED is around 8 hours of standard cycles. CRRT is a usual cycle running over 24 hours. Right? Now, how do you choose which treatment to use in which setting? Now, all of you know this. The same machine does your intermittent hemodialysis as well as the SLED. Correct? The dialyzer is not very different. So what is different? It's only the time duration, the blood flows, the dialysate flows, which were at your disposal, right? When you wanted to change them. So how do you decide which dialysis to go with? So suppose I give you a case scenario. Patient has a potassium of 7.2. Do you want to do CRRT or SLED or IHD? IHD. Very good. So basically, when you look at efficacy, the efficacy is maximum with IHD or SLED. Why? Because the dialysate flows are very different in this therapy. Now just imagine what is the amount of dialysate that your patient goes through in 1 hour of SLED therapy. What is your dialysate? 300 to 500 mils, right? So take 500 in per minute. So in 60 minutes it is 30 liters of dialysate. What is your dialysate on CRRT? There you go. Which is going to be more efficacious? Okay. So what is the rate limiting factor when you do dialysis? Is it the blood flow? Yes, it is important. And the other is the dialysate flow. And are you running it co-current, counter-current? These are the basically things at your disposal when you want to increase the efficiency of a particular therapy. So when you have a patient with severe acidosis or hyperkalemia, you want to choose something that works fast. Whereas when you have something like fluid removal is your goal. Now what do you want? Do you want to remove 1 liter per hour in a patient who needs 6 liters of removal? He is going to crash. Because for the blood, for the fluid to come out of the third space into the intravascular compartment, remember one thing, whenever you do dialysis, you are only dialyzing the blood compartment. You cannot do control any other compartment of the body. So the fluid has to equilibrate, and that takes time, right? I mean, the guidance has changed. The cell membrane is looked at differently now. It's no longer the glycocalyx model that we studied as students. Okay? So we have to understand that physiology, our understanding of physiology is improving. And we need to understand that third space fluid takes time to come into the intravascular compartment. So when fluid removal is the goal, choose a therapy which is over a prolonged duration of time. Right? So that's where CRRT will score an edge. Now if you say, doc, I don't want to spend so much money, can I run a SLED as CRRT for 24 hours? Why not? If your goal is achieved, which was fluid removal, you can run SLED as CRRT for 24 hours. But when you do SLED, what is it that you are missing? You are missing the convective clearance. So where is convective clearance playing a bigger role? Sepsis. So that's where you would want something like a CRRT going. When you need more cytokine removals, when you need more of filtrations. So if you look at CRRT, the data comes basically from the filtration component, not so much from the dialysate component. Okay? So this is a simple thing for you to understand which therapy to choose how. Okay. So this is a graphical representation of the same, where basically it is showing you that patients who need more hemodynamic stability or intracranial pressure stability choose a therapy which is a continuous therapy like CRRT. We have mentioned PD here. How many of you have used PD in ICUs? Good, wonderful. Valentine, you are always there. So this is still a good therapy. We should not forget that we have another dialysis and not just the blood dialysis at our disposal. The risk of infections and immobilizations, is the downside. When you need something fast, rapid fluid removal, rapid acid-base correction, rapid correction of acidosis, you have dialysis at your disposal. So PD, just a couple of words on that. It's a very effective therapy. Particularly we use it in our chronic renal failure patients. It's a home-based therapy. It is also very valuable in pediatrics. So, your cardiac surgeons who are operating on pediatric patients, a lot of times they just come with a PD catheter out of the OTs, right? And that's how effective it is. It requires surgery to put the PD catheter. We can also do it percutaneously, equally well. It is not a very rapid therapy, it's a very slow therapy. So whenever you need something rapidly to be done, like correction of hyperkalemia, you will never choose PD. Okay? And we can't get into the details for lack of time, but this is just slides to tell you what I have just spoken about, how to choose between the different therapies. Okay? So I'll skip this in the interest of time. Now the second thing is the dialysis timing. Right? When should you start dialysis? Right? So when should you start dialysis? Do you want to wait for something like this to happen to your patient? Patient is in refractory acidosis, unmanageable hyperkalemias, pulmonary edema before you are starting dialysis, or would you like to start RRT beforehand? Right? So I think none of us now actually would wait for, I don't know when was the last time I saw a patient of uremic pericarditis coming to me. Because none of us would like to wait for this kind of a complication to happen. So absolute indications for initiating dialysis, I think, should be history. And we should look at softer indications and start earlier. Now when I say that, is that my bell? Okay, because then we are way behind time. Sorry about that, Ravi. So basically, look at what is the right time to start dialysis. The data that you have comes from Elaine trial, which was a positive trial for starting dialysis early. Akiki trial, which was unequivocal. They said, okay, you can start early or late, but maybe starting late is better. Then the other studies came up, ideal ICU and start AKI trial. But most of them did not show that there is a benefit to starting dialysis early. That being said, ask the nephrologist or the intensivist in the group how many of them would wait to start dialysis in their patients who are having worsening AKI. So I think something in the design that we are still not able to get, that is, so these things are not matching our own clinical practice versus our own available data. Why is there, something is missing between the two, which is difficult to explain. Maybe the study design, maybe the ability to do a trial in such an acute care setting is where the issue is. What is the dose? How much dialysis should you give to a patient? 4 hours, 6 hours, 24 hours, 7 days? How do you decide? So it's not the dialysis that decides the dose, but the indication. So again, which type of dialysis? Filtration, diffusion or convection? Again, the thing is, what is the indication? The indication will decide the modality of dialysis, the duration of dialysis, and the logistics involved. Now, when you look at this, I will come to the third part now, which is a contrast-induced nephritis. So contrast nephritis, for all of you in the audience, is a very common phenomena. We see it a lot. It's a reversible form of acute kidney injury, usually, that happens seen after administration of the radio contrast. The rates are as high as 50% based on what is the baseline. So patients with underlying CKD or, and if you go by very strict criteria, an elevation of above 0.5 milligrams per deciliter over 48 hours is contrast nephritis. It's usually a self-limiting condition which peaks between 3 to 5 days with a subsequent gradual return to baseline between 7 to 10 days. How do you know the predictors? So basically the data shows us that, sorry, I think we went back. So how does it cause the renal injury? Both by direct as well as indirect mechanisms. So direct nephrotoxicity, indirect by alteration in the hemodynamics. It's things that we can't see, generation of reactive oxygen species and endothelial injury ultimately leads to renal impairment. You can score it. Who are the patients likely to get contrast nephritis? The age is important. Presence or absence of anemia, presence or absence of IABP. What is your starting eGFR? Is it 40, more than 40, less than 40, or less than 20? You can give points to each of these, and a risk score of less than 6 means a very small risk of getting a contrast nephritis. A risk score of more than 16 means very high risk. In practice, I'll tell you, diabetics, elderlies, obstructive jaundice, and pre-existing CKDs. These are the ones at maximum risk of contrast nephritis. Okay? Remember the 4 things. So these are the patients you will frequently land. So I'll repeat that who have not heard. So basically age, obstructive jaundice, proteinuric patients, pre-existing CKDs. Okay, they are the ones who are maximally likely to get a contrast nephritis. So what can you do to prevent it? The ones that everybody agree about is pre-procedural hydration. There's enough data that it's very helpful. You should start 1 mg per kg per hour for 6 to 12 hours before and continue after the procedure. Alkalinizing, yes, it's important because the tubular injury from the free radicals is reduced when you alkalinize the urine. It is reasonable to pre-treat the patient with a high intensity statin before contrast use. There is a meta-analysis that shows that the risk after giving a single dose of rosuvastatin 40 mg significantly reduces for contrast nephritis. Phenylketopropan we don't use, it is there in date, it's not unequivocal. Obviously you must discuss with your radiologist or the cardiologist who is doing the procedure to minimize the dose of contrast, use more kidney friendly contrast, do the contrast procedure only if it's unavoidable. Otherwise in patients at a higher score of getting contrast nephritis, avoid it if you can. Outcomes, the PRESERVE trial all of you know about, bicarb and N-acetylcysteine, and it was again a positive trial. Clinical evidence when you use iodinated contrast, why there is an injury, let's not get into that for interest of time. Risk stratification we have spoken about, we should hydrate the patient and alkalinize the urine for sure. What happens to the patients, all of these complications can set in, acute renal failure, acute on chronic, hypersensitivity, volume overload. So there is one data that I have not shown you here which actually talks about using dialysis to prevent contrast nephritis. And that is still not unequivocally accepted even within the nephrology community. This is like doing dialysis to prevent long-term dialysis. And if we are, but it was a positive trial, it was in New England Journal of Medicine, and they spoke about filtration to remove contrast. Because remember, contrast is not a small molecule, it is a middle-sized molecule. So you are going to require convection if you are going to try to remove contrast. So if we are practicing, then we should practice in patients with a eGFR of less than 30 to start with, who are having a high score, very high risk of landing in a prolonged contrast nephropathy with possibility of recovery or no recovery. That is the segment where you can consider doing dialysis. Which dialysis? Like I said, you need convective clearance. So you should preferably use a high flux dialyzer, something that allows you to do a convective clearance. And also a pore size should be more, that the diffusion of the higher sized molecules is more. That's why a high flux dialyzer, and add a degree of convective clearance to it to minimize the injury to the kidney. So sorry for the rush talk today, but take home messages for you. So there are different modalities of RRT available. The choice depends on the indication for the dialysis, the availability of the resources, the hemodynamic stability of the patient. You have a wide basket to choose from. When to start? According to me, even today I believe that if the patient has, look at the patient, see whether his acute kidney injury is more likely to get better or get worse over the next 12 hours. That is what will tell you whether you need to start dialysis or you should wait. It is not the number of creatinine. Of course, those are all important parameters, but the one single parameter, if I had to choose, it will be my own prediction based on the clinical variables. Is my patient likely to recover or not recover over the next 24 hours, 12 hours? Dose of RRT, again, it is not the dose depends on the indication, right? Like I said, the modality depends on the indication, so does the dose. And contrast nephropathy, remember that it's usually a preventable thing by using conservative treatment, and high flux hemodialysis should be used in a selected group of patients for preventing contrast nephropathy when there's no other choices available. I thank you all for a very patient hearing. Thanks. Sure. Okay. So I don't know whether we can take questions or not, but later. If somebody has something, you can correct me directly. I think we are running late. Thanks.
Thank you, Dr. Rishi. It was an interesting session. Now, I'd like to call Dr. Amit Kumar, founder and president of Nephro Critical Care Society, to give the memento to Dr. Rishi. If anyone wants to have tea or coffee, it's right outside the auditorium. So, moving on to the next session for the day, I would like to invite Dr. Jay Kothari, MD Anesthesia, FNB Critical Care Medicine, Director and Consultant Critical Care Department, Apollo Hospitals, Ahmedabad. He is an Advisor Critical Care Department for Star SVMS Hospital. He is also the Director for the Spectrum Medical Education, Director Spectrum Critical Care and Pulmonary Associates. Today, Sir is here to talk about myths and evidence in nephrocritical care 2, citrate versus heparin anticoagulation in CRRT, high volume CRRT in sepsis. Over to you, sir.
एक मिनट.
Good noon, everybody, and without wasting much time, let's directly speak about the topic. I'm going to speak about the citrate and heparin comparison in anticoagulation for CRRT and high volume hemofiltration for CRRT in various patient groups. So, we all understand that anticoagulation is an integral and important part of CRRT treatment. And without anticoagulation, filter gets clogged. If the filter gets clogged, there are
significant deleterious side effects like loss of blood volume, like decreased efficacy of the dialysis therapy, and the cost involved in Indian setting. So it's a very significantly deleterious effect. What is achieved with the anticoagulation is we want to prevent filter clotting, as well as we want to decrease the side effects of decrease the risk of bleeding in the patient. What are the ways of doing anticoagulation in CRRT? Systemic anticoagulation by infusing various drugs in the systemic circulation, and regional anticoagulation where the only circuit is anticoagulated. There are patients where no anticoagulation is used. These are the patient with liver failure, and these are the patient who has intrinsic coagulopathy and bleeding disorders. In such patient, no anticoagulation is given. Rather, intermittent normal saline flush is given through the circuit. And this no anticoagulation strategy might reduce the filter life, and we need to change the filter more frequently. For systemic anticoagulation in CRRT, unfractionated heparin is used. It is routine, well-rehearsed modality of therapy. It is reasonably safe, cheap. It can be reversed easily with protamine. But there are disadvantages because of the unpredictable kinetics. It may cause heat. It cannot be used in patients who have bleeding risk. It cannot be used with patient who has heparin resistance. So heparin is, all of us are well versed with the drug. We can use it very comfortably. What is the protocol? You give heparin with saline, prime the circuit, you give bolus 2000 to 5000 units, you give continuous infusion of heparin, and what you target APTT is 34 to 45 or 1.5 to 2 times normal, and APTT is done 4 to 6 hourly. Low molecular weight heparin is not used routinely. Regional anticoagulation with heparin and protamine is not used routinely. What is routinely used and what we are now changing our practice towards is regional anticoagulation with with citrate. Citrate is an anticoagulant and buffer. It chelates calcium, creates regional hypocalcemia in the filter, results inhibition of clotting in the filter. While going into the blood, it is metabolized by liver, muscle, kidney, and releases 3 molecules of bicarbonate. 2 types of citrate solution, hypertonic, isotonic. It functions as a combined anticoagulant and pre-filter replacement fluid. This is the typical diagram. Citrate is infused pre-filter either as a separate solution or along with the pre-filter replacement solution. The calcium-free dialysate comes here. The calcium ionized is monitored post-filter, and the calcium is given systemically through a different intravascular line. Citrate is delivered as fixed ratio to blood flow or titrated as per post-filter ionized calcium level. Target systemic ionized calcium should be 1.12 to 1.25. There are a lot of advantages of regional citrate. It avoids systemic anticoagulation. Circuit survival is better with RCA. It can be used in patient with coagulopathy and patient who has risk of heat. It requires frequent monitoring. There are significant metabolic complications. The dialysate fluid should be calcium free. There is a risk of citrate toxicity, and in hepatic failure, citrate is associated with more problems. These are the metabolic complications which can happen with use of regional citrate anticoagulation: metabolic acidosis, alkalosis, hypocalcemia, hypercalcemia, hypernatremia. These risk factors are increased in patients with fulminant hepatic failure, shock liver, or whenever there are nursing error or prescription error. There are few studies which has compared regional citrate anticoagulation with unfractionated heparin. These 2 studies have shown that use of RCA may prolong filter life, reduce the incidence of bleeding complication during RRT for AKI. The RCT published in JAMA suggested that RCA would result in longer filter half-life than UFH, though there is no mortality difference. RCA was associated with fewer bleeding complications, but the risk of new infection because of the multiple handling would increase with the regional anticoagulation. Regional anticoagulation with RCA is compared with regional heparin anticoagulation, and it concluded that RCA prolongs CRRT circuit life much larger than the regional heparin protamine complex, and it does not affect cytokine levels and is associated with fewer side effects. As it was been apprehensive that the liver failure patient may have higher risk of citrate toxicity, this is the study done, multi-center prospective LKIT study. It was done in the patient with liver failure, and it concluded that RCA can safely be used in patients with liver failure, and it creates excellent filter patency and without much of the side effects. So at last, if the patient has no clotting abnormality and if the center is experienced with the RCA technique, they should use RCA as an anticoagulation in CRRT. If the center's excellence is not there, UFH can be done. If the patient has significant coagulation problems, then either no anticoagulation strategy or RCA is recommended for the CRRT. This is for the anticoagulation citrate versus heparin. I'm going to talk about high volume hemofiltration. Let us first understand the hypothesis. What happens in sepsis? It creates an unregulated systemic immune response, and it produces a large spectrum of inflammatory mediators. All these mediators have middle molecular weight. High volume hemofiltration can provide non-specific removal of this inflammatory mediators because of the very high convection mechanism associated with HVF, and that's how HVF can remove all these molecules. And once you remove the inflammatory mediators, it may downregulate the overactive immune response and may further reduce the organ damage. So it would help preventing in further organ damage and improve the septic shock. There are various hypotheses which is postulated that how HVHF would help removing these inflammatory mediators from the blood, from the tissue level and through the lymphatics. It is called peak concentration hypothesis, threshold immunomodular hypothesis, and mediator delivery hypothesis. So high convection removes a lot of mediators with these three mechanisms. The definition is variable in the literature. What you call high or what you call HVHF is significantly variable and significantly debated. So this is something which for the understanding low volume HF, 20 to 40 ml per kg per hour. This is done to do a renal replacement, so it is called renal ICU dose HF. High volume hemofiltration should start from more than 50 ml per kg per hour of effluent volume, and it is called sepsis ICU dose hemofiltration. Very high volume hemofiltration is more than 100 to 200 ml per kg per hour of effluent exchange. This is one consensus definition where they have used 50 to 70 ml per kg per hour for 24 hours continuous therapy and a pulse therapy of 100 to 120 ml per kg per hour for 4 to 8 hours during the day, and for rest of the day conventional CVVH-DF. What are the disadvantages of this? The center needs to be very excellent. It requires very high blood flow through the CRRT. It creates need for larger vascular access. It creates need for larger filters to prevent the clotting. It requires frequent filter change because of the high volumes. The filter gets clogged easily. There is a lot of fluid exchange, and it creates a lot of electrolyte imbalance, including hypophosphatemia and hypomagnesemia. There are micronutrients, antibiotic, vitamins, essential elements, albumin, everything is dragged out. Everything would come out of this situation, and it requires a lot of attention for such kind of things. One need to do drug monitoring for a lot of drugs if they are being used, and there is significant risk of hypothermia. So what are the studies or evidence regarding the use of HVHF? This is one study which was positive. It was used in the patients with severe burns. When the burn happens, within 3 days of the burns admission, patient is randomized to receive the HVHF treatment, and what they have concluded is early application of HVHF benefits patient with severe burns. Those with a greater burn area decreases the incidence of sepsis and mortality. This effect may be attributed to early clearance of inflammatory mediators and recovery of a patient's immune system. This is systemic review and meta-analysis, 6 trials, 744 patients. There is insufficient evidence to support the therapeutic benefit for routine use of high volume hemofiltration in patients with septic shock. And one more study which compared high volume versus standard volume hemofiltration for septic shock patients with acute injury, and they could not show any mortality benefit. So what was the difference between these studies? The first one, the burns that you show, and the other ones, the first one is without the organ failure, without the severe septic shock, while the patients with burns who may develop inflammatory mediators, these mediators are removed before the organ failure, and that's how probably the patient has lesser CARS response also, anti-inflammatory response also. You have removed the peak of the inflammatory mediators, it would create decrease in the compensatory anti-inflammatory response also. Patient's immune system would be maintained, immune paralysis would be reduced. That's how the incidence of sepsis is reduced. That's how the patients have better mortality. That has been coined, this has been debated, discussed in such manner. But the role of HVF should be early. There are few more studies which is done in septic shock, but there was no great benefit in the cytokine removal or mortality. So overall, HVFS is feasible only in centers who are capable of doing CRRT. We have to understand that other good things also would be removed, and they need to be supplemented and monitored carefully. And despite the early promising results, HVF still remains an experimental tool for the current clinical guidelines. Thank you very much.
Thank you, Dr. Kothari. Our next speaker is Dr. Amit Kumar, MD Medicine, TM Nephrology. He is a nephrologist and renal transplant physician consultant at Medanta Hospital, Ranchi. Dr. Kumar is also the founder and president of Nephrocritical Society. He will talk about the implications of CKD in nephrocritical care. Before he starts with his lecture, I would like to invite on stage Dr. Rishi Deshpande to give him a token of appreciation. Okay, can I then call Dr. Valentin Lobo?
Good noon to all, and it is a privilege to be here. I want to speak something about our initiatives that we taken, and actually that started from the concept started during the COVID time when I and Dr. Tapas in Medanta Ranchi used to meet more frequently that before COVID, because in the COVID time all the critical patients and many of them having problems of acute kidney injuries and going to different kinds of renal replacement therapies, and we used to meet many times in ICUs. and we thought of starting this particular thing. And before the second wave of COVID was, but it was so rampant and was so heavy, then we got late, and after third wave we again attempted, and after third wave, when in January there was also some cases, then huge surge in cases in the China, and that couldn't picked up, and we did our first Nephro-Critical Care conference in January last week. And thank you, Dr. Gunadhar Padi, for supporting, and in this way that even at that time he committed, then we'll do some course on Nephro-Critical Care. So we are here. And today the topic is given to me as implications of chronic kidney disease in Nephro-Critical Care. So there is mixing of acute and chronic illnesses. To introduce, the incidence and prevalence of chronic kidney disease and end-stage renal disease are increasing. As we know, the chronic kidney disease incidence of increase such that in nearly 7 to 10% of general populations, one is having some form of the chronic kidney disease. Okay. So these patients have higher risk for developing critical illnesses and being admitted to ICUs compared to general populations, and the higher prevalence of comorbid disease associated with these conditions put this population as a higher risk for worse short as well as long-term outcomes following ICU admissions compared to general populations. There is remarkable change in patient demographic characteristic that has increased our incidence of diabetes, hypertension, and other chronic illnesses, and availability of long-term renal replacement therapy, even at your district's level, has increased the percentage of the patients with pre-existing renal dysfunctions who develop acute critical illnesses requiring admission in ICUs is progressively increased. So nowadays, management of critically ill CKD patients is a routine clinical challenge for nephrologists and intensivists both. Development of acute kidney injuries alone or acute kidney injuries in persons of chronic kidney disease, and this further worsens the patient's outcome if the CKD patients got frequent episodes of acute kidney injuries. Patients who survived from critically ill AKIs after an acute and chronic episodes, the risk of progression of kidney dysfunction is high, because even one and another illnesses add on some injuries to kidneys, and that proportionately increased, and that progressed to ESRD stage early. Along with this, immunological and infective problems related to kidney transplant patients lead to peculiar clinical settings that we got in our ICUs. AKI incidence, nearly 7% of the hospitalized patient is having a form of acute kidney injuries, and nearly 36 to 60%, 67% of critically ill patients, depending on definitions, and 5 to 6% of the ICU patients with AKI requiring renal replacement therapy. Regarding epidemiology of chronic kidney disease and ESRD in ICUs, there is limited data available on the prevalence of chronic kidney disease among all critically ill patients supported in ICU settings. The most studies has focused on the subset of dialysis-dependent patients with end-stage renal disease. Available data will suggest the proportion of the patients admitted to ICU with ESRD ranges 1 to 9%. But the report's variability in ESRD admissions across studies is likely accounted for differences in practice pattern, availability of ICU resource, and patient case mix and study design. ESRD patients has consistently been shown have estimated 25 to 30-fold higher annual likelihood of admission in ICUs when compared with the non-ESRD general populations. these ESRD patients got admitted in ICUs by several noticeable differences in baseline characteristics when compared to non-ESRD patients. And these are generally younger, have more comorbid conditions like diabetes, cardiovascular problems, and more likely medical and have higher illness severity score compared with non-ESRD patients. However, these observations may be susceptible to selection bias. Available epidemiology survey of ESRD patients admitted to ICUs are limited by not accounting for those patients referred or refused ICU admissions. So the proper registry and is important, because how much the magnitude that we face is actually more than that we know. Precipitants of critical care illnesses in chronic kidney disease patient and end-stage renal disease. The most common precipitants of critical care illness prompting ICU admissions are sepsis, septic shock, and decompensated cardiovascular disease, including cardiogenic shock, MI, arrhythmia complications, and heart failure. So, coming to pathophysiology, acute and chronic kidney dysfunctions might be caused due to several mechanisms, including failure of autoregulation, abnormal vasodilation, and adverse effects related to diuretics, antihypertensive agents, and or use of nephrotoxins. And these causes reduction of renal functional reserve, and it increases the susceptibility of CKD patients to develop acute kidney injuries as well as organ crosstalk feedback, in which the development of non-renal organ dysfunctions due to or associated with CKD might lead to acute kidney injuries. So this is a basic pathology of chronic kidney disease. When there is any injury, causes decrease in nephron numbers. There is adaptive hyperfiltration at glomerulus level that causes increased glomerular permeability, increased renin, angiotensin aldosterone system activation. And this increased RAS causes increased single nephron GFR, and that further increase the hyperfiltration at glomerulus. And when there is increased glomerular permeability, there is increased filtration of proteins and macromolecules that usually do not occur, but when the permeability increased, the increased number of proteins and macromolecules that is exposed to the your tubules. When there is nephrotoxic inflammation and remodeling, there is tubulointerstitial fibrosis and secondary FSGS occurs, and then this becomes irreversible thing that further decreases the GFR, decreases urine output, and causes various systemic complications in form of volume overload, uremic symptoms, etc. And as mortality or patients of acute kidney injury is going to ICU or CKD patient going to ICU, the most common causes of mortality and is cardiovascular. The concept of in any patient of chronic kidney disease, when there is decrease in GFR, it has been seen that there is high level of FGF23 levels, along with there is clotho deficiencies, and that leads to atherosclerosis. Along with CKDs, in CKDs when we got hyperphosphatemia, that also causes increase in calcification in your vessels and leads to endothelial dysfunctions and atherosclerosis and valvular diseases. When there is high FGF23, it has been seen that in myocytes there is increased in FGF23 levels, and that causes left ventricular hypertrophy, congestive cardiac failure, and cardiovascular events. Few slides over chronic kidney disease. What is chronic kidney disease? It is a condition in which kidneys are damaged and cannot filter blood as well as they should. Because of this, excess fluid and waste from the blood remains in the body and may cause other health problems such as heart problems and strokes. 40% of the patients with severely reduced kidney functions are not aware of CKD. So this is the irony. That's why the most patients came to nephrologist are at stage 4 or stage 5 state, or patients who require dialysis immediately. If kidney disease get worse, waste can build to high level in your blood and make you feel sick and having various uremic symptoms like nausea, vomiting, volume overload, exhaustion, etc. Complications may develop with high blood pressure, anemia, weak bones, poor nutritional health, and nerve damage. This slide shows there is etiology of chronic kidney disease in India. A large proportion of the patient is having unknown etiology. To known etiology, diabetes is most common, 20%, followed by your hypertensive your glomerular disease, then hypertensive nephrosclerosis, and then AKI progresses to chronic kidney disease. So basic definition and stages of chronic kidney disease depending upon GFR. These are various consequences of chronic kidney disease that causes sodium and water imbalance, potassium imbalance leading to hyperkalemias, needs urgent correction. Decreased elimination of nitrogenous waste that causes increased BUN level, causes uremic symptoms. Decreased erythropoietin production because these erythropoietin are present in peritubular fibroblast, and when there is fibrosis, the erythropoietin production decreases. That causes a significant number of anemia in various stages of chronic kidney disease. Acid-base balance that leads to acidosis and various symptoms of respiratory distress. And activation of vitamin D, decreased activation of vitamin D and decreased phosphate elimination leads to hyperphosphatemias and certain bone problems. Here are the complications of chronic kidney disease. So, what is the outcome for chronic kidney disease and end-stage patients landing in ICUs? Surprisingly, the early mortality for critically ill ESRD patients is lower than for those with acute kidney injuries, suggesting that the progression is driven largely by the acute illnesses severity than the baseline comorbidities. However, ESRD patients have consistently higher short-term mortality rate, 9 to 44%, when compared to non-acute kidney injuries critically ill patients and age and sex-based general population. Factors that has been shown to associated with ICU mortality in ESRD patients are older age, higher illness severity scores that can be assessed by Apache 2, SPAS 2, burden on non-renal organ dysfunction, medical and non-surgical admission type, and provision and duration of life-sustaining technologies. Studies reported long-term survival among end-stage patients show a trend for an increased mortality rate within the first 6 months after the ICU discharge, with a relatively stable but increased risk for mortality thereafter. So proper follow-up is required in these patients. At 2 years after ICU admissions, survival is generally poor, and observation studies estimate only 1/3 of the end-stage patients admitted in ICU were still alive. Although long-term mortality in end-stage renal disease patient is several times higher when compared to general population, the presence of ESRD does not appear to be independent predictor of long-term mortality, suggesting short-term prognosis is more related to acute illnesses severity rather than CKD or dialysis dependence. Around 50% of the patients who survive an episode of acute kidney injuries requiring renal replacement therapy show a significant loss of GFR resulting in dialysis dependence after hospital discharge in approximately 10% of the patients. So most important risk factor for incident ESRD and dialysis dependence among survivor of critical illnesses is previous history of chronic kidney disease. This would suggest continued surveillance of kidney function among survivors of the critical illnesses is vital, because a large proportion of these patients again land up in the classification of chronic kidney disease, and they develop CKD and later on end-stage renal disease. CKD, in particularly ESRD patients, consume more health resources in association with admission in ICUs compared with non-CKD patients. And these patients have longer duration of ICU stay, longer duration of hospitalization, and higher rate of short-term rehospitalization. Moreover, These patients often remain critically ill following ICU discharge due to issues related to cardiovascular comorbidities, malnutrition, and deconditioning. These likely reflect diminished physiological reserve and increased vulnerability to further adverse events. Prognostic scores used in ICU can be challenging among patients with end-stage renal disease because it is not individualized to ESRD patients. Most score systems have not been specifically validated for ESRD patients, and their performance routinely overestimate the risk of death. Because these patients are very sick at admissions, and within 24 to 48 hours of hospitalization and proper care, they got out of ICUs. Chronic kidney disease in COVID. Underlying CKD is a risk factor for severe disease and mortality in patients in COVID-19, and it was related, mortality was higher in dialysis and transplant recipient than in general population. AKI is an important complication of severe COVID-19 critically ill patients in the ICUs, particularly those on mechanical ventilation, and are more likely than patients with milder disease to require dialysis, which is associated with higher mortality. Most patients who survive the COVID-19 associated AKI regain kidney function, but nearly 30% remain on dialysis at discharge. Mitigation strategies to reduce the exposure to SARS-CoV virus are vital to protect high-risk CKD patients. Whether COVID-19 will increase the prevalence of CKD in the long term and potentially increase the demand for the maintenance dialysis is unclear and require further investigations. Some of the factors where we got increase in BUN level without having acute kidney injuries, if there is increased production of these, examples are GI bleeding, catabolic states, prolonged ICU state, corticosteroid, use of corticosteroid, and protein loads, and increase in creatinine without acute kidney injuries, inhibition of tubular creatinine secretion by use of simultaneously trimethoprim, cimetidine, or probenecid, interference with creatinine assay in the lab. There is false elevation can be seen when there is acetoacetate presence, ascorbic acid, cefoxitin, flucytosine. So in the last, how to manage end-stage patients in ICUs. We have further scenarios, and we'll took it one by one. Volume status control. Administer isotonic fluid to maintain a normal serum sodium concentration and tonicity. Perform a daily assessment of weight, fluid intake and output. Monitor CBP levels, central venous pressure, oxygen saturation, and perform hemodynamic invasive monitoring if required. For electrolyte control, consider insulin and salbutamol to treat hyperkalemias, and initiate RRT promptly if not corrected. Avoid hypokalemia during RRTs, as well as the patient who is having immediate post-PTCA patients or cardiac patient because of risk of cardiac arrhythmia. Hypotonic hyponatremia, hyperphosphatemias, and hypocalcemia are frequent, and these need to be diagnosed early and treated. Hypercalcemias may be a consequence of excess calcium administration or related to underlying causes of renal failure like multiple myeloma, where this need to be corrected early so that the further dehydration and further increase in AKI can be prevented. Dialysis access and vein preservation. Consider absolute and relative indication for the PD catheter use. Avoid AV fistula and graft for CRRT, but consider it for intermittent hemodialysis or hybrid therapies in ICUs if necessary. Avoid the placing the identification bands or restraint over the fistula on internal jugular line for short term, or if RRT required for more than a week, then tunneled access is recommended. Minimize venipuncture. Limit placement of periphery inserted central catheter, and avoid the use of subclavian venoside because of long-term complication of subclavian vein stenosis. Regarding hemostasis, as my previous speaker already told, bleeding diathesis are frequent because of platelet dysfunction in uremia and extracorporeal therapies. So low molecular weight heparin to maintain patency for extracorporeal drug therapies is of similar efficacy and safety to unfractionated heparin, but with the low molecular heparin we have to monitor factor Xa level. Sodium citrate may be used for regional anticoagulation with systemic anticoagulation when systemic anticoagulation is undesirable. Administration of vasopressin analogs and or conjugated estrogens may complicate the management. So imaging, there is no need to perform hemodialysis immediately after radiocontrast administration. Drug use and adjustment considered reduced GFR, the altered protein binding and variable volume of distribution and the mode of renal replacement therapy the patient is going on to prescribe the drug. That is very important point because it can alter your management of treating your sepsis. The required dose of propofol should be titrated to effect and it is better to avoid continuous infusion of midazolam. Morphine and fentanyl accumulates in renal failure and it should be used with caution. Remifentanil has no toxic effect. These drugs to be avoided over the counters that we know well, NSAIDs, ibuprofen, naproxen, ecosprin, decongestant, pseudoephedrine, and your sodium phosphate products. The continuous infusion of furosemide has a greater effect, but increasing of diuretic use may cause diuretic resistance. So the concurrent use of thiazides sometimes have improved the loop diuretic responsiveness. Avoid undertreatment, adverse effect, but also considered pharmacokinetic and pharmacodynamics and extracorporeal clearance of the prescribed antibiotics. The prognostic implication of further renal function deterioration within 48 hours of interventional cardiology procedure in patients with pre-existing renal insufficiencies concluded that for patients with pre-existing renal insufficiency, renal function deteriorates after coronary intervention is a marker for poor outcome. And this is especially true for patients who require dialysis. So to conclude my topic, the incidence of chronic kidney disease and end-stage renal disease increasing, reflecting an increase in incidence and prevalence of hypertension and type 2 diabetes. Patients with CKD and end-stage renal disease frequently experience episodes of critical illnesses and requires treatment in an ICU settings. So collaboration is of more importance. Management requires a specific consideration of their renal disease status together with their acute illness. Mortality in acute critically ill patients with end-stage renal disease is frequently related to their comorbid conditions rather than their end-stage status. Illness severity score allocates high point for renal variables and tend to overestimate actual mortality. So sometimes we need to use 2 or more scoring systems simultaneously. Patients with end-stage renal disease and CKD requiring ICU admissions has a better ICU and in-hospital survival than patients with de novo AKI requiring renal replacement therapy. Because AKI is very challenging because in this particular AKI there is your biomarker, acute inflammation, and inflammatory markers change, shift of your electrolytes are very much. Compared to this, chronic kidney disease patients are a little bit settled. Appropriately selected patients benefit from ICU admissions, and full consideration for ICU care should be given to these patients if required, despite their renal disease status. Cardiovascular disease and sepsis account for the majority of the ICU admissions in this population, and the etiology of these conditions differ from that in patients without kidney disease. Optimal critical care management for patients with end-stage renal disease and chronic kidney disease requires that these differences are recognized. Thank you so much for your patient hearing. If any questions, please Okay, thank you.
Thank you, Dr. Amit. It was an interesting session. Moving on to our next speaker, Dr. K. Ramanathan, Adjunct Associate Professor, Director of ICU Fellowship Program at National University Hospital, Singapore. He is also an adult cardiac intensivist at Cardiothoracic Intensive Care Unit, Singapore, at National University of Heart Center. He had his specialty training in cardiac anesthesiology from India and is trained in intensive care medicine from Brisbane, Australia. He has done his diploma in echocardiography, master's in clinical ultrasound from University of Melbourne. He is also an awardee for the Honorary Fellowship FCCP by the American College of Chest Physicians for his contribution to critical care. Dr. Ramanathan is closely associated with the National ECMO Standing Committee at the Ministry of Health, Singapore. He currently leads the course workshop at the ECMO Education Committee and Extracorporeal Life Support Organization, ELSO, USA. So he is also the co-chair for Scientific Oversight Committee and Data Review Committee at ELSO, USA. Dr. Ramanathan is here to speak about the topic on CRRT on ECMO. Over to you.
Good afternoon, everyone. At the outset, let me thank the organizers for inviting me to Mumbai. It's good to be back here after a long time. Clearly, I should say that there is a revolution happening here. One of the budding specialities, such as nephro critical care, is clearly blossoming in India, and it's good to see so much enthusiastic a crowd sitting here, listening to some of the lectures and going to be participating in some of the hands-on sessions this afternoon. Well, all said and done, of course, I'm here to talk about a specific niche of patients who need more than one extracorporeal circuit. So essentially, we're just going to, the next 20 minutes or so, I'm going to talk on some of the sickest patients you would get to see in critical care who would need multi-modality organ support, and I'll take you through how we combine extracorporeal circuits when they are used as life-saving devices. Right. At the outset, look, I'm not here to talk about what ECMO is. I'm sure all of you know what it is, where it is used, and clearly, the kind of patients with severe cardiopulmonary failure who benefit out of ECMO, where ECMO is used more as a salvage procedure. So I'm not going into the details of the indications, contraindications, and how you run an ECMO program. I'll just zoom into the topic which I've been asked to talk on, essentially, why do you need renal replacement therapy on ECMO? So, if you look at the indications for renal replacement therapy on ECMO, I would broadly classify them as 3 major indications. So you get to see these sickest patients in critical care developing acute kidney injury at some point or the other. So they clearly, a cohort of these patients end up being on renal replacement therapy. Then, time and again, every intensivist, every nephrologist would face the situation of that patient who's extremely fluid overloaded and you want to offload fluid. So in that context, again, you end up talking about ECMO and CRRT. And then there are the other indications. The other indications, mainly, I would think toxicology is an important indication. You guys are more familiar with aluminum phosphide than I am. So clearly, where it's helpful. And sometimes it becomes pertinent and important that you stabilize patients to initiate RRT. So you know that RRT works in a particular situation, but you are unable to save that patient because you are unable to stabilize him hemodynamically. And it's in that context, sometimes ECMO helps as a bridge to start RRT. Right? So these broad 3 indications I've just outlined. We'll just zoom in on each of them and figure out how ECMO and RRT go together in each of these indications. Now let me start with ECMO and AKI. And of course, ECMO and AKI does not translate to ECMO and CRRT always. So clearly there are some subtle differences between ECMO and AKI and ECMO and CRRT. Now in terms of the patient load or the patient cohort who end up getting AKI on ECMO, you would find that, about 60 to 65% of patients who need ECMO support would get AKI at some stage during their journey. And about 50% of these patients who are on ECMO would need RRT for various indications. Not just that, you have 2 types of ECMO. One type where you support you do cardiac support predominantly using veno-arterial ECMO, and you would find that the number of patients who need RRT support is more in those who need veno-arterial support. So when you have patients with cardiac issues needing ECMO, their need for RRT as well as their incidence of AKI is much more higher than in patients who need it for respiratory support. Clearly, one thing that's common to these sick patients is they tend to stay longer. Clearly, they add on to your costs. And when you have an RRT machine hooked on, in addition to your ECMO support, clearly the ICU length of stay as well as the duration of ECMO has been found to be quite prolonged. Not just that, if you look at the mortality per se, it's quite variable. It's quite high too that way. Of the patients who get AKI, and I'm talking about the sickest cohort of patients, about 62% die. And again, the same thing, irrespective of what you use RRT on ECMO for, the mortality still remains high. Now, I'll tell you about one of the papers which we recently published. I'll talk about it in the next subsequent slides, and I'll show you how the mortality has come down in the recent years. But before I go there, a few more things to add. You got to understand that ECMO patients are unique in different ways, and their propensity to get acute kidney injury in this setting is high because of various reasons. Now you got to understand that there are patient-related reasons. Clearly, they are being ventilated in a way which affects the right heart function. And then you have 2 extracorporeal circuits, or you have an extracorporeal circuit of the ECMO already, which in itself causes damage in many ways. So, you have hemolysis happening as a part of running these patients on ECMO. A lot of these patients get thrombus in their oxygenators, which causes further hemolysis. So goes on to say that circuit per se can contribute to acute kidney injury in these patients. And of course, the disease process for which they go on ECMO is so severe that, their underlying cardiac dysfunction or their respiratory dysfunction per se can stimulate a cascade of inflammatory mediators which leads to worsening of kidney injury. And of course, the hemodynamic part, I think, has been well highlighted by the speakers before me. Patients in critical care, if they are on inotropes, you can clearly see how much important it becomes when it comes to stabilizing their hemodynamics. So, to give you a gist of what acute kidney injury and RRT on ECMO eventually translates to, there are a few things which are known and there are a few unknown still. I mean, of course, most of the evidence for RRT on ECMO comes from observational studies. You got to understand that, such things are learned on the ground and shared in literature, that you understand that there are certain things that need to be done differently. Now, as I said, up to 78% of the patients who go on ECMO end up with some degree of renal failure. And this is more common in patients who are post-cardiotomy. Not just that, amongst the patients who get renal replacement therapy on ECMO, continuous renal replacement therapy is the most preferred mode. Now, you also need to understand that ECMO, while you are on ECMO, you get fluid overloaded for various reasons. You have electrolyte imbalances for various reasons, and RRT helps in this context. But clearly, one thing which is not that very clearly defined in literature is the dose of RRT and the timing of RRT on ECMO. So, you know that patients do get acute kidney injury, you know that they need RRT, but there are a certain list of variables which are still unknown and we are still searching for answers. So the next important indication, as amongst the three of the ones which I highlighted early, is fluid overload and the need for RRT on ECMO to control fluid overload. Now, by virtue of being on ECMO, you end up having fluid overload for many reasons, So essentially, you have these patients on arterial lines, central lines, which always is hooked on to some kind of normal saline or heparinized saline. So they get unintentional fluid therapy, which goes unmeasured sometimes. Then, as part of their management and as part of their ongoing bleeding, you end up giving them a lot of blood and blood products so that the ECMO flows are maintained. So essentially, you fluid load them again. And not just that, even the underlying disease process is so bad that you end up, say, in a septic patient who has a bad pneumonia, you might end up fluid resuscitating them with liters of fluid in the first 2 to 3 days before they start turning the corner. So essentially, you do fluid overload them for many reasons. Now again, just as how I said RRT has a lot of unknowns when it comes to treatment of AKI, the same thing applies to RRT on ECMO and fluid overload. There is no guidance on optimal fluid and electrolyte management. Again, nobody knows what's the amount of permissible fluid resuscitation. You have a patient with sepsis, we all target a map of 65, and make sure that the patient makes urine. The moment urine output stops, and your urea creatinine starts going up, you start pondering over, okay, what do I do next? Shall I start dialysis? Should I give more fluids? Is it good? We don't have really straight-cut answers to such questions. And when you start removing fluids from these patients, how much do you take out and what is the total amount you should look at, or what is the cumulative fluid balance you should aim for? Again, all these data come mainly from observational studies. Now, if I were to summarize the literature that's available on ECMO and fluid balance using RRT, there are only a few studies that have been published so far, of which, you would look at it and essentially you would find that, most of the time, fluid balance has been correlated with mortality on ECMO. So like any other critically ill patient, where fluid balance correlates well with mortality, even on ECMO, you get to see that fluid balance correlates with mortality. And two important studies which I'd like to, zoom in are the last two ones. The one from South Korea, which is actually Southeast Asia. They have the largest number of participants in a study that commented on fluid overload on ECMO. And the other study from Australia, which, even though it was published 10 years back, it had laid down some of the basic tenets of understanding about what badness fluid overload can do to patients on ECMO. Coming to the study from Korea, essentially, as I said, it had some of the highest numbers, more than 700 patients, and they looked at the 90-day mortality with reference to cumulative fluid balance. Clearly, what they found was the cumulative fluid balance was higher in the patients who had respiratory failure and ECMO as compared to cardiac failure and ECMO. Now, it's reason I think it's a no-brainer in this situation, because when you have cardiac failure, you tend to restrict fluids, so you don't give them too much fluid, and still, you'd find that the mortality is increased even if you load them with little amount of fluid. Now, what Matthew Schmidt showed in his study was the impact of fluid balance on mortality. They had an important finding, and I think, this finding is being reproduced or essentially replicated in a lot of subsequent studies that have come up. So what he showed was, even though their numbers were small, he showed that patients who have a positive fluid balance after day 3, so up to day 3, fluid resuscitation is still permissible on ECMO. You have a positive fluid balance, you consider it as a part of fluid resuscitation on ECMO. But beyond day 3, if you are unable to get these patients negative, fluid negative, balance negative, if their fluid balance cannot be negative, then your mortality goes up. An important finding which was later echoed in subsequent studies, this is a study from Maryland published last year, and they looked at the various permutation combination of fluid balance and AKI. Now, in short, positive fluid balance had lower survival rates. Again, not surprising, and their finding was quite similar to Matthew's paper in intensive care medicine, where they showed that, for the first, starting from day 4 to 6, if you are unable to get a negative fluid balance on these patients who go on ECMO, the day 7 fluid balance becomes a marker of clear-cut high mortality. They also, as I said, combined AKI and fluid balance together on ECMO and looked at the various permutation combination as well as their survival. Clearly, survival was lowest for those who had positive fluid balance as well as acute kidney injury. And it was best for those who had negative fluid balance and no acute kidney injury. Not surprising, but the point I'm trying to make here is fluid balance, like in any critically ill patient, has similar impacts in ECMO patient. It's just that some of these observational studies give us some insights into when and where we should move on from resuscitation to removal of fluid. The next important indication for CRRT and ECMO is in toxicology. As I said earlier, a lot of these patients present with hemodynamic instability. So this was one of the patients who had amlodipine poisoning. We knew that, if we could stabilize him, we could then figure out how to remove amlodipine. And what we essentially did for this patient was we connected him to an RRT circuit, and he needed, on top of it, a plasmapheresis to take out amlodipine. So if you look into this picture, deep in that corner, you'd get to see the plasmapheresis machine, and the plasmapheresis machine can be attached to the ECMO circuit or the ECMO CRRT integrated circuit as well. There are other indications clearly, which you are all well aware of. For postgraduate students who would like to have a mnemonic as to figure out what dialysable toxins are available, I usually use AIs tumble. So essentially, aluminum phosphide, isopropranolol, salicylates, theophylline, all these things can be removed on ECMO. Very likely that these patients, you might be able to dialyze them straight away when they come to critical air. A group of these patients, if they are hemodynamically unstable, you might need to initiate ECMO while you start dialysis. Now, let's come to the practical side of things. What happens on the ground? And this is something which we are going to cover in the afternoon. So I might rush here a bit. But having said that, you need to understand that all modes of RRT is still feasible on ECMO. Each one has its own pros and cons. Especially, CRRT as well as SLED can be integrated into the ECMO circuit, and it can be made possible. But, there are other things that come as a package. You don't get the pros alone. It comes with pros and cons. So you need to understand that, these are patients who would otherwise be stable would be unstable without ECMO. So even on ECMO, they can become unstable when you connect them to a machine. Now, as much as the technical aspects, how do you adapt the circuit to the ECMO circuit? There are different possible configurations. You need to understand that, I'll go through a few of them in the next few slides, but the short and sweet of it is you can have various ways of connecting the ECMO machine to the CRRT machine to the ECMO circuit. The problem here is, when you have so many options, you end up essentially evaluating which is the best so that you can select the best and give it to your patient. So how do you do that? And for that, you need to know what the pros and cons of each different kind of configuration is about. Now, the first and foremost configuration that is possible is just connecting the hemofilter directly to the ECMO circuit. Now, it comes what we call as the inline hemofilter. So it comes with a lot of advantages. The biggest disadvantage is you don't have a precise ultrafiltration out of it. So you don't monitor pressures, so you have limited solute clearance. So that's not the most preferred way. The most preferred way nowadays is to have an integrated system of RRT and ECMO. So there are different ways of connecting it to the ECMO circuit. You can get blood before the pump and give it back before the pump. So the ECMO circuit has a pump and an oxygenator, of which you can use this part of the circuit to access and return. The problem with this kind of approach is the negative pressure, which can cause problems. So essentially, you'll have air entering the circuit. You can have your ECMO circuit getting embolized with air in this whole process. So it is far less than ideal. The other option is to use a system where you take blood post-pump and return it pre-pump. Now, the problem with this approach is essentially the high pressures that happens in the circuit post-pump. So a lot of CRRT circuits would go alarming to the point that you may not be able to run it. So again, not the best, but still possible. You can still use, you can still access it post-pump and give it post-pump before the oxygenator. Comes with the same set of problems which I said. A more practical way of approaching this would rather be looking at connecting it or taking the access line post-oxygenator and giving it back before the oxygenator. Now, the reason being essentially that there will be a drop in pressure across the oxygenator, so you may not have access problems that way, and your alarm systems and the dialysis machine will not go off. And when you return blood pre-oxygenator, essentially even if you have clots, even if you have bubbles, it gets absorbed into the oxygenator. So one realistic way of approaching this particular circuit adaptation is by doing it this way. And of course, you always have an alternate way of handling this by having a VAS cath that is exclusively for dialysis and the ECMO circuit is run separately. So that's an equally good way of doing it. The only issue is you will have to insert a VAS cath in a fully anticoagulated patient, which comes with a set of its own complications. Now, as much as the RRT dose on ECMO goes, clearly, most of the times we run these patients when we connect the RRT circuit, the blood flow is maintained somewhere between 100 to 250 mils per minute. The optimal dose of RRT is clearly not known, and we have just extrapolated it from critical care literature. So we just follow what critical care otherwise tells us in critically ill patients what we do. So essentially same thing gets followed in ECMO too. There are other aspects of technical aspects of RRT and ECMO as well. When it comes to anticoagulation, when you have your filter clogging off very often and you need to change your RRT circuits, is it cost effective? Well, people have tried a lot of things out of the box. They have even used regional citrate for RRT filter maintenance. This was a group from Hong Kong which published it in a few years back. So what I'm trying to say is even regional citrate anticoagulation is feasible. Drug dosing takes an important consideration in these critically ill patients. Most of them, they need antibiotics. And when you have two extracorporeal circuits, already, we all know CRRT and drug dosing has its own sets of rules. When it comes to ECMO, CRRT and drug dosing, clearly, evidence is slowly we're slowly starting to get those evidences as to how we run these antibiotics. So we just combined and collated all these, whatever I was talking so far, into a guideline from the Extracorporeal Life Support Organization. This was published last year. It's available freely online. I'm not going to the details of it. So what about outcomes? Essentially overall outcomes, and then you have specific outcomes. So overall outcomes, we all agree that people who have ECMO and RRT have a higher risk of death. Clearly, the mortality rates differ from single-center studies and registry data. We're not sure why that is, but then, there's clearly a high degree of mortality for sure. Specific outcomes, of course, when your patient gets RRT for a short ECMO run, the chances of the patient dying is higher. And this is essentially, the reason I'm saying that is possibly because patients who have shorter ECMO runs might be more sicker and they may die out of other causes. So essentially that, they get RRT as a package of it. But clearly, when you get RRT for more than 7 days, the results were more or less comparable. So essentially going on to say that even though these people have a higher risk of end-stage renal disease and readmission rates, when you run it, you still find that there is no big difference in survival rates when the ECMO runs are longer. This was the SRMA, the meta-analysis which I was telling you about. Most of the things I've already highlighted. The only thing that I would like to highlight here is the mortality from using RRT on ECMO has come down drastically by about 20% in the last 5 years or so. So which again goes on to say that we are learning a lot. Technical considerations are being changed to suit our needs, and clearly, patient selection has been either early or more prudent. So to summarize, essentially, you need to know that the indications for ECMO and RRT, 3 major ones: fluid overload, AKI, probably toxicology. The dose and circuit, clearly dose still not clear, but we just follow what is being followed in critical care literature. Circuit-wise, multiple configurations possible, but we choose the best. And outcomes, we understand that the long-term sequelae and mortality is high, but then that cannot be attributed to the run of ECMO. It's probably the disease process that is contributory here. The reassuring bit is that the mortality has come down by about 20% in the last 5 years. I'll stop here. Thank you. Any questions? Absolute silence. Either you have understood everything or you have understood nothing. I'll take the former. Thank you. Yes, thanks. Yeah, I think, it needs to be taken with a pinch of salt that day 3 is that day where, it's a matter of life and death day. No, it's not. It doesn't work like that. It's again, you need to individualize your patients as to how they receive fluid therapy. Some patients, especially the septic ones, need a bit more of fluid resuscitation. The way I work around it is I start the decongestion process on day 3, so that at least from my perspective, I'm looking at loading them on one side but slowly removing fluid at a regular pace, so that I'm doing that diligently. At least by day 7, I make sure that, they are moving on towards the negative fluid balance trend. Now, the point I'm trying to make here is, if for a critically ill patient who needs fluid for 7 days, you can imagine the amount of capillary leak he has. Clearly, even if you run 3 ECMO circuits, you're not going to save him. So essentially, it eventually boils down to the underlying sickness. Most of the patients who need a higher amount of fluid, they settle down by day 3, day 4, and that's more of experience-based medicine than evidence-based medicine. A part of these get reflected in these observational studies when they say that. So clearly, it's one area where evidence is catching up with experience, I believe.
Thank you for the wonderful talk. Of course, it was very illuminating to learn from you. Now, considering that we're talking about AKI and CRT and all, do you go for proactive initiation of CRT in some of these ECMO patients? Because the managing fluid in these patients is challenging all along the way. Your conventional indication of starting dialysis is not applicable for the most part. Most of the times you're not, I think, for promoting overload as opposed to elevation in the UN or hypertension and those kind of things. So what is your approach?
Again, it's a tough question to answer for many reasons, because there are no principles. This was exactly the problems we faced when we wrote the guidelines too. There were a lot of ifs and buts, and there were a lot of questions on why certain things were being suggested as part of the guidelines. And this was one of the problems we have rightly highlighted. If you ask what I do, essentially, I don't do early CRRT in these patients. I wait for the indications to happen. The reason being, it's an additional extracorporeal circuit, and it comes with its baggage of complications. Even though, I told you how it can be connected, it takes a lot of training, and it clearly, eventually impacts on how you run the ECMO eventually. So a clear-cut answer I may not be able to give, but clearly, the textbook indications for, say, CRRT in AKI, I usually follow that for my ECMO patients. For fluid overload, I try diuretics first. I start them by day 3, day 4, so I start something there. And in the event that my goals are not met by, say, day 4, day 5, I start contemplating on CRRT to remove fluid. So it's a tough question. I don't have a straightforward answer. It's just what you do, and it's probably anecdotal.
One query, what could be the most practical troubleshooting, at the bedside, because it's a hybrid, dual extracorporeal therapy,
True.
compared to the previous one.
Yeah.
The patient would have been in the ECMO or CRRT,
yeah.
and now on 2.
Yeah.
So what would be the extra, because of troubleshooting we face
Yeah.
at the bedside?
Oh, that's a great question, Tapas. Of course, you need to understand that running ECMO with RRT in itself is a challenge. And when you run it with a plasmapheresis machine, it becomes a headache. So it's not that easy. But the answer to your question, the most common bedside problem that we face when we connect, and I think this clears with experience as well, is RRT machine alarms. You find that some of your dialysis machines are so sensitive, hypersensitive, that they go on alarming the moment you connect them to an ECMO circuit. And this is the most common complaint I get to hear when I attend conferences and give such kind of talks. My machine always does this. I don't know how to overcome this. So we've stopped doing the integrated circuit. We put in a VASCAT, 2 separate circuits, and we do it. So if you were to ask me what is the most common thing, it's connecting or overcoming those ECMO alarms. A lot of these new machines, they set their alarm limit a bit more higher so that you'll be able to run even with these positive pressures. And the configuration which I was talking to you about, where you take blood post-oxygenator, where you expect some more pressure drop compared to post-pump, also works in most of the instances. But what I find is most of the institutions that run ECMO and RRT, they go through a learning curve and they find their own solutions as they go along the way. It can be, innovative. Sometimes you'll be surprised that they are able to achieve such a thing. At times, they just use or tweak here and there and get it done. All right, thank you.
Thank you, Dr. Ramanathan. It was really an interactive session. So before moving on to the next, I would like to call Dr. Srinivasan Sambedam to give the memento to Dr. Amit Kumar. Also, I would like to call Dr. Swarin Panja to give the memento to Dr. Ramanathan. Okay. So I would like to call Dr. Gunadhar Padhi. Okay. Moving on to the next session, I would like to call Dr. Tukaram Jamale, MD General Medicine, DM Nephrology, KEM Hospital, Mumbai. He is a professor and head at SAIT GSMC and KEM Hospital, Mumbai. He is also the member secretary for Regional Organ and Tissue Transplant Organization, Western India. He is also the creator for educational blog reviewing latest nephrology research called The Last Month of Nephrology. He is here to talk about IV fluids in ICU, which is the right choice.
Okay. Next 15 minutes, I will be taking you through the basics of fluid therapy in intensive and emergency units. We won't go into the details of individual studies and research articles, but the crux of fluid therapy in ICU. So these 5 R's define the goals of or purpose of fluid therapy. We do it for resuscitation or replacing the losses. In the instances of redistribution, we want to replace. But the last 2 are probably the most important, and the mistakes probably are likely to happen most often in this area. That is the routine maintenance and lack of reassessment of the initial decisions that are taken. So maintenance is what is the rationale that is often offered for why we administer the fluid. The purpose here to prevent hypovolemia when patient has limited or no oral intake, to provide enough calories and to prevent electrolyte disturbances. For all practical purposes, most adults won't require 1.5 liter or more of the maintenance fluid. But as you can observe in most of your medical floors, surgical floors, patient will receive fluids way higher than this amount. This is the typical prescription one can consider, that is dextrose normal saline with glucose added and potassium. About 2 to 3 pints of this should be enough if there are no ongoing losses and there are nothing to replace that is lost. Coming to the resuscitation, principle here is to replace what is lost, blood for blood, and I will introduce the idea of pH guided fluid resuscitation that is probably physiologically most suited to the needs of the patient. In the instances of redistribution, when there are no apparent external losses, we require to replace resuscitated patients. These are the instances. So how much fluid we give? Now, when I was in training in MD General Medicine in early 2000, that was the era of early goal-directed therapy. Everybody was so impressed with the idea that this was one of the key recommendations of surviving sepsis, some campaign guidelines at that time. And only to realize later that early goal-directed therapy is not to be offered for most of the patients that we see today. And this was refuted by multiple trials later. I won't go into the detail of that, but massive fluid resuscitation is obsolete and possibly dangerous. Most hospitalized adults are not in the window of this therapy, and there is clear and consistent relationship between positive fluid balance and adverse outcomes. Whether it is children, whether it is post-surgical patients or patients in the intensive care units, in all of these populations, excess fluid is clearly and consistently related to the organ dysfunction and death. And there is a possible physiological rationale, that is the endothelial injury because of resuscitation, the endothelial glycocalyx. It's possibly mediated by atrial natriuretic peptide, but several other enzymes in the process are implicated. So we need to be cautious when you are resuscitating patients. Frequent reassessments are necessary. Your initial judgments may go wrong. We can reflect upon them and revise our decisions. So there is a lot of scope for reassessments here. Now this was a madness way back in 1860. People used to do bloodletting for each and every ailment that they knew about. And this probably is the madness of 2022. We need to be really cautious when we are giving lots of fluid to your patients. So why do we give fluids? When do we say patient is fluid responsive? Whether it is when fluid bolus increases blood pressure or central venous pressure or increases cardiac index. Now this was a very interesting study, randomized controlled trial, which demonstrated that it is not the volume of fluid, but rather the temperature of fluid after fluid bolus that led to the increased blood pressure. So it was not the bolus fluid volume, but the fluid administered at the body temperature, that is colder than the room temperature. Now what do we expect when we give a fluid bolus? We expect that it will lead to increase in the cardiac output when patient is in septic shock. That will be measured by cardiac index. We expect that this cardiac output should translate into increased oxygen delivery to the tissue, and this should also translate into increased oxygen utilization at the level of tissue. So one or more of these assumptions often are wrong when we give fluids to the patients. And this was also very elegantly demonstrated by this very small but interesting study by a group of anesthetics, wherein they studied about 70 patients and measured each of these indices, and they say what happens after fluid bolus. Let us see. Now, talking about the arterial oxygen delivery, it's a function of cardiac output and arterial oxygen content, which in turn is a function of hemoglobin and oxygen saturation. And cardiac output, of course, is a function of stroke volume and heart rate. Now, what happens after fluid bolus? So, in about 71 patients who were given fluid bolus, did it increase cardiac output? Only in 27 of 71 patients, it led to increase in the cardiac output. What about oxygen delivery? further lower. Only 21 of 71 there was any increase in the oxygen delivery to the tissue. And what about oxygen utilization? Because sepsis is a state of cellular machinery dysfunction. So oxygen utilization also may be at fault. So whatever improvement you judge by mean arterial pressure or by cardiac output, whether it is sustained, because that is also another important assumption or premise of fluid therapy. In many of these situations, fluid bolus does not offer a sustained benefit and can potentially add to the fluid overload and be harmful. So after having discussed the amount of fluid, which probably restrictive strategy will be a default strategy in most units now, which fluid should we be using? Now we have options that are available, but largely my talk will be focused on the hot topic today, whether we should be abandoning the use of 0.9% saline, because there are several physiological and pathophysiological abnormalities that are associated with 0.9% saline use. As early as early 80s, this was first demonstrated by Christopher Wilcox, that hyperchloremic acidosis induced by saline lead to decreased GFR. And this was specific to renal vessels. It was not seen in any other vasculature. And this was related to the tubular chloride response, reabsorption and tubuloglomerular feedback. Subsequently, a group of surgeons with rather aberrant research interest performed a randomized controlled trial of 0.9% saline versus plasma light and showed they diligently measured the renal perfusions, various indices of renal perfusion by using MRI and techniques, and they demonstrated that renal vasoconstriction is associated with 0.9% saline. Decreased renal perfusion was indeed documented with the use of 0.9% saline. But the real controversy was sparked by this study in 2012. This was a pre and post kind of cohort study by an Australian group, which demonstrated that there is significant decrease in the risk of acute kidney injury and dialysis need if you follow a strategy of chloride restrictive fluid administration in the ICUs. But this study, I'm very skeptical for various reasons, because they demonstrated about 50% decrease in the need of dialysis, but no change in the mortality. This was not a randomized controlled trial, so it's possible that there were other factors playing rather than the actual benefit of chloride restriction. This was the first well-conducted trial, SPLIT, which evaluated the two strategies, saline versus balanced buffered crystalloid solutions, and it failed to demonstrate any difference in the renal adverse event if you use either of the solutions. Now these were two large trials, SALT, ED and SMART. They were called as pragmatic trials because they were conducted in thousands of patients. Each of these trials enrolled over 10,000 patients. And SMART was the one in the critically ill patients. We'll look at it closer. So primary outcome of the SMART, as you can see here, was major adverse kidney events, and it was considered to be statistically significantly lower in patients who were given balanced crystalloids, p-value of 0.04. Again, we have to interpret these results with caution because these are essentially surrogate outcomes. And if you can see here, if you see that individual component of the primary outcome, none of it is statistically significant. Although they together appear to be statistically significant. Event rate was low for a trial involving thousands of patients, and when we enroll very large number of participants, chance of finding a difference that is statistically significant but not clinically meaningful is high. That's why these results should be interpreted with caution. And indeed, two very good trials, that is BASICS and PLUS, they were published in 2021 and 22, demonstrated that chloride restriction does not offer any benefit in terms of the kidney injury, dialysis requirement or mortality. So what would be my ideal crystalloid? Now having said that, what would be my ideal crystalloid? It would have the composition of electrolytes, osmolality as close to the plasma as possible. It should not be costly, it should be it should not have any products of metabolism that are toxic to the tissues. So a lot of expectations. So there is no such ideal fluid, but the fluids that resemble closely to the plasma concentration are probably the lactated ringer and plasma lights. So common misconception about lactated ringer is that it produces hyperkalemia, but probably this is a myth and not based upon the evidence and facts, because if you see plasma, this concentration of potassium in lactated ringer is about 4 MEq per liter. So if you consider a patient with hyperkalemia about 6 MEq per liter, this fluid will pull potassium in and not offer potassium. Potassium is a cation that is largely maintained in the intracellular fluid. So adding, so volume of distribution of potassium is very much higher than the ECF. So even if you add a fluid of 8 MEq per liter in a hyperkalemic patients with potassium 6, possible increase in the potassium is probably 0.1 milliequivalent and not more than that. That is when you consider that potassium will be in the ECF. But then again, as I said, potassium is largely the ICF component. So such increase is probably further going to be lower. Again, the determinant of potassium in the ECF, major determinant is acid base. So if you produce hyperchloremic acidosis by giving sodium chloride, chance of getting potassium out of the ICF into the ECF as an effect of nagma is high. So this effect probably may be more pronounced that possible addition of potassium to the ECF by ringer lactate. So RL for practical purposes, and this is supported by the evidence, there are trials, I am not going to go into details of that, but RL does not produce hyperkalemia. So what should we be doing? Given the evidence till date, should we stop using 0.9% saline? So in my opinion, this is not sufficient evidence to discard saline altogether. But when one is contemplating large volume resuscitation, when we are going to use fluid probably more than 2.5-3 liters or more, in such situations, hyperchloremic acidosis can set in and can have some untoward physiological effects, especially the renal perfusion. However, the impact of these effects on clinically meaningful outcomes, if at all, is probably minor. So what do we do? This is final takeaway from my talk. Patient needing fluid resuscitation, you assess the acid base. If patient has nagma or acute kidney injury, you alkalinize and use isotonic bicarbonate. How do we make isotonic bicarbonate? We have bicarbonate that is 7.5% concentration available. So we typically dissolve about 150 ml of bicarbonate into a liter of dextrose 5%. That makes isotonic bicarbonate. If patient has alkalosis, you can choose 0.9% saline. If patient has no acid base abnormality, you can maintain with RL or plasma light. So we have come long way from giving blood transfusion, hetastats, which are now called as poisons. Then there was an era of normal saline, and then there was a fashion of balanced crystalloids. But probably time is for the pH-guided fluid resuscitation, wherein one can choose according to the individual needs of the patient type of fluid that should be administered. I haven't covered albumin and starches. Starches, I can say one line that they are poison. Albumin, there is still a dilemma. We are trying to find out its role. Definite role of albumin is probably in the setting of SBP, where you can use albumin to prevent acute kidney injury, and possibly a subgroup of patient with sepsis where albumin may have a role, but this still needs to be proven in well-conducted trials. Thank you. So no questions? Thank you.
Thank you, Dr. Tukaram. Moving on to our next speaker, I would like to invite Dr. Srinivas Samveda, MD Internal Medicine, DNB FRCP, FNB Critical Care Medicine, EDIC FICCM, Diploma in Medical Law and Ethics, MBA Healthcare Administration. He is a Chief of Critical Care Ramdev Hospital, Hyderabad. He is also the Director for E-Access Critical Care Medicine and Tele-ICU Services, Hyderabad. He is also the former Vice President and General Secretary for Indian Society of Critical Care Medicine. He was the scientific co-chair for the Critic Care at the year 2010 and 20. He was the Chairman Guidelines Committee for Indian Society of Critical Care Medicine for the year 2015 to 18. He is an Associate Editor for Indian Journal for Critical Care Medicine. He has received 9 gold medal in MBBS and gold medal in MD Internal Medicine. His area of interest lies between neurocritical care and stimulation-based training in ICU. Apart from that, his other interest is dairy farming, dog breeding, and painting. So today he is here to talk about AKI tools to define, predict, and risk stratification. We welcome you, sir.
Good afternoon. It's an honor and privilege to be here as part of the first Nephro Critic Care initiative by this group here. And I'm grateful to Tapas, Gunadhar and Akhilesh and the rest of the team for having me here for this program. The next 15 minutes or so, that's been the time given to me to speak about risk stratification in critical care, in acute kidney injury. Since morning, there's a lot of debate and a lot of discussions happening in terms of how bad acute kidney injury is, how do you treat these patients, whether you use hybrid forms of renal replacement therapy, what fluids are good, what fluids are bad, what machines can be connected, and what problems you face. So we understand the magnitude of acute kidney injury. Let's look at 4 patients whom I had the opportunity of managing in the last 2 weeks, and I'll put the index cases in the perspective of risk stratification and identification of progress of patients with acute kidney injury. So we had a 21-year-old hostler lady who presented with acute gastroenteritis and hypotension. She was anuric on admission with a creatinine of 0.8. She was fluid resuscitated with 5 to 6 liters of crystalloid, and her urine output improved after 12 hours. And the creatinine increased after the urine output improved. The creatinine increased to 1.3 on the next day. The hydration was continued till recovery with the creatinine normalizing on day 4. So this individual, this lady, we will call her the young hostler. We had a 65-year-old diabetic who fell from 10 feet from a construction site with spine and traumatic brain injury. He had diffuse axonal, therefore had recurrent seizures. He was tracheostomized, anticipating a slow vein. He developed healthcare-associated infective complication with Acinetobacter and therefore was started on colistin. He was noted to be edematous and therefore was started on a diuretic infusion. You look at his creatinine trends, 0.8 on day 0, progressing to 1.1 on day 5, jumping to 2.8 when the colistin was added, and further increase when the diuretic was added. We call him the fall guy, right? A 34-year-old ethanolic smoker admitted with pancreatitis. He received NSAIDs for his pain elsewhere. A contrast-enhanced CT was done on day 4 for persistent fever. He developed hypotension needing fluid resuscitation and therefore developed intra-abdominal hypertension. A repeat contrast CT was done which showed that the necrosis had worsened and we were unable to wean his vasopressors. You look at his creatinine trend, it's 1.2 when he came to us, 2.6 on day 3 and 4.8 on day 5 when the renal replacement therapy was initiated, and we call him the shock guy, right? We had a 48-year-old farmer bitten by a snake with neuromuscular failure, ventilated for 8 days, with significant neuromuscular weakness, therefore was tracheostomized. In the rehab unit, he had a cardiac arrest and developed cardiogenic shock, and he had persistent hypotension because of the cardiogenic shock with poor LV function. His creatinine trend says 0.6 on day 0, 0.9 on day 4, 1.0 on the day of cardiac arrest, 2.6 on day 15 with persistent hypotension, and 3.4 on day 17 when he was initiated on a continuous form of renal replacement therapy. A potentially treated problem ending up with this disaster, therefore we call him the heartbreak. Right? Now if you look at these 4 case scenarios, you have the young hostler, you have the fall guy, you have the shock guy, and you have the heartbreak patient. what is common to all these patients is that they have this syndrome called acute kidney injury. Now, the questions we need to ask and therefore find tangible and acceptable answers to these questions are they all the same? These 4 patients have a common syndrome. Are they all the same? Obviously not. Do they behave the same in future? Probably not. Can we diagnose them earlier? Can we pick up the hostler who developed a creatinine of 1.2? Can we predict that she will develop that 1.2 before she actually reaches there? And will all of them have the same outcome, short term, intermediate, and long term? This is the answers we need to find when we talk about definition, risk stratification, and prognostication of patients with acute kidney injury. The reason is acute kidney injury is not a simple disease. It's a multi-system disease with long-term connotations for what we can predict for the patient. So the rapid reversal is the one which we are talking about in terms of early identification, which is reversible AKI. But what happens in the interim is that there are the triggering factors like the damage and pathogen-associated molecular patterns. There are baseline risk factors, which I will show you. There is definite risk factors in developing countries, and there are definite risk factors in the developed world. You have nephrotoxins. We saw quite a few nephrotoxins, the NSAIDs, the contrast, and not to forget the diuretics, which are enough nephrotoxic agents. And then you have hypoperfusion, the low cardiac output, and the patient with intra-abdominal hypertension probably had venous congestion. All of them will trigger your acute kidney injury progression, and you either have fibrosis, which doesn't resolve and ends up with end-stage kidney disease, or you have the favorable situation of a full recovery with resolution. So the entire spectrum of acute kidney injury is something that migrates very heterogeneously between the different ends of this spectrum. So if you look at the natural history of acute kidney injury, if you take each of these patients, the young patient who did not have risk factors, to the farmer who had a snake bite and probably was in a good physiological state, to the diabetic who developed pancreatitis, they all behave in a specific pattern. The insult happens at the same time in all of them. Some of them, maybe 30% of them, have a dip in their function, but they reach full recovery. Some of them end up with AKI to ESRD very rapidly, but the match is played here. These patients who migrate or progress to acute to chronic kidney disease and acute on chronic kidney disease, which adds to the burden of renal disease in this country, already worsened by diabetic and other problems. So these patients are increasingly at risk of several diseases, CKD being one of them, and of course have higher risk factors for developing coronary artery disease as well. So the first definition which we were told to memorize way back in 2002, 2003 when we were training and appearing for our critical care exit exams was this, at that time, well-validated rifle criteria, which spoke about an increased creatinine or a decrease in GFR matched or with urine output less than 0.5 mils per kg per hour for 6 hours, which was supposed to have a good high specificity and sensitivity all the way progressing from risk, injury, failure, loss to end-stage kidney disease. But in critically ill patients, like a trauma patient, for example, or a toxin-related kidney damage, for example, we were not able to replicate or extrapolate the tight classification of the rifle criteria for some cohorts of patients. So that triggered the next set of definitions which the Acute Kidney Injury Network proposed, and that is the AKIN definition of acute kidney injury, which also looked at, rather than a fixed amount of urine output or an increase in creatinine, we said serum creatinine increase of 0.3 milligrams per deciliter or a percentage from baseline came into the picture, which was able to identify at what stage the patient probably needed RRT. But this was again a very simplistic way of looking at the definition of acute kidney injury, and further work, further discussions, and further representation of different types of patients who come into the critical care unit spawned the currently accepted probably the most well followed definition for acute kidney injury, and that's the KDIGO guideline. So you look at quantifying the baseline creatinine, right? That's more important for us because we see a lot of pregnant AKIs in this country, right? For pregnancy, a creatinine of 0.8 is simply too high. So if you have a pregnant lady who comes to you with a creatinine of 1, would you ignore her or would you put her into the watch list for acute kidney injury is what it means. So you look at an absolute increase of 0.3 milligrams per deciliter, or you look at 1.5 to 1.9 times the baseline in a week's time to define acute kidney injury. Now this brings a lot of those 4 patients who I discussed into the radar of the alert systems which some hospitals have incorporated into their electronic medical records for AKI alerts. So that's when you start picking up these patients and probably be more careful in what you do with them in terms of their medication, their hemodynamic optimization, and sometimes their oxygen management as well. So the reason why this is the length of time each of these patients spend in the hospital is very different. If you have no AKI and you spend less time in the hospital with the survival, those who have stage 3 stay longer and tend to die more in the intensive care unit, and I'll come to that towards the end of my talk again. But we have all been talking about the urine output and the serum creatinine. But the serum creatinine as a functional marker of functional derangement has its own drawbacks. And if you assume that the normal GFR is about 120 mils per minute, and you look at the graph there, your creatinine starts rising to that level when most of us start looking at supplementing or supporting the kidneys, that is around 2. It starts rising and rather precipitously upwards when the GFR touches about 60 mils per minute. That means half your kidney function is already down when your traditional trustworthy marker of kidney function has started showing signs of distress. So that's probably too late from an intensive care perspective, especially if you understand that acute kidney injury is a marker or a precursor for chronic kidney disease in future. So if you look at the entire spectrum of no kidney injury and hemodynamic acute kidney injury, if you look at the serum creatinine based definitions, you will probably miss the subclinical acute kidney injury, and that's because of renal reserve. That's an interesting concept. The kinetics of serum creatinine and the general muscle mass of some of these patients who just simply cannot generate that creatinine. So you won't have the creatinine rise despite there being an AKI, and that's what the subclinical AKI would mean. So I will draw an analogy with what happens with acute coronary syndromes and myocardial infarction here. You have a patient who comes to you with an ST elevation MI or a non-ST elevation MI into your emergency room. You do a troponin I, the patient develops heart failure, you do a BNP, and then you look at his echocardiogram and you will find that his ejection fraction is 35%. Now you put that scenario into acute kidney injury. Somebody comes with acute kidney injury. You don't have a troponin, or you should have a troponin which will tell you that this is going to result in a higher BNP or a lower ejection fraction. If you extrapolate the BNP to creatinine and the ejection fraction to your urine output, you can get the picture. So researchers in the field of acute kidney injury have always felt to find that something that is similar to cardiac troponin, and that is where the biomarkers, which we'll hear in the next talk, come into the picture. So some of these biomarkers have been studied and have been incorporated into some of the revised definitions for acute kidney injury. And so you have AKI stage 1S, where the serum creatinine is normal but the biomarkers are positive. The serum creatinine is normal and there is no decrease in urine output, is still a biomarker positive AKI stage 1S. So similarly you have 1A and 1B basically based on whether one of these parameters is abnormal but there is a positive biomarker, which is an indicator that structural injury has happened at the glomerular level. So if you look at the functional criteria, You will have 1S where only the biomarkers are positive, and the other groups where there is one of those definitions of KDIGO with or without the biomarkers being positive. You will have the 1A, 1B, 2A, 2B, and 3A, 3B. So you can categorize your patients, subcategorize the 1, 2, 3 into the categories. So if you reassess these patients, those patients who are BM negative, that is biomarker negative, and also have normal creatinine with no decrease in urine output will probably resolve, whereas those who have biomarker positive with increase in creatinine or a decrease in urine output will definitely progress into one of the spectrum of diseases which I presented in my earlier graph. So if you look at the risk factors, I said about the risk factors for kidney disease in developing countries and the developed world. We have several processes like water quality, for example, sanitation, for example, tropical infections, for example, right? Access to healthcare, for example. So many issues, and the overuse of antibiotics and NSAIDs in this part of the world, right? So, and the three common problems, diabetes, hypertension, liver disease, being more common in this part of the world than in the western part of the world, make our population at a higher risk for developing kidney disease for the insults, and therefore we need to pick them up very early, much before the serum creatinine actually starts rising. So you will have to have surveillance for patients who are at high risk, because acute kidney injury can be community acquired, and as we saw in the snake bite patient, it can be hospital acquired acute kidney injury as well. So this is the reason why you should categorize your stage 1, 2, and 3 and subdivide them into 1A or 1B, because the mortality exponentially rises as you progress from no AKI to the stage 3. So subcategorizing them could probably help you to stratify your patient selection and therefore your therapeutic approach in a more scientific manner. Because the days from ICU admission to death, as you can see, the survival function from each of these groups is significantly different, with the last group performing especially bad. So some of these patients also have a persistent acute renal injury, and you need to quantify that, and that happens with the use of your creatinine score multiplied by the comorbidities. So if you have a delta creatinine and the rise of creatinine, you give a score, and you have either a hyperbilirubinemia, presence of sepsis, or the requirement for either a vasopressor or a ventilator, you give a score, and you multiply these two, you will get the persistent acute risk index. Now, if you combine your biomarker-based KDIGO algorithm with the PARI index, you can reasonably predict which patient of yours is going to develop AKI on CKD in future as well. And this PARI score on the ROC curve seems to perform equally well, or probably a little better than either the urine output or the serum creatinine. So a comprehensive assessment of the patient's underlying comorbid conditions, the need for organ supports, plus the delta creatinine should make us understand how bad your patient is going to be in the next 30 days, 90 days, and 180 days. In the end, it's not that there's only one type of AKI. There are several phenotypes of AKI, and artificial intelligence is now good enough to identify several phenotypes of these acute kidney injuries. So you will have the first kind of patient who had hypovolemia and transient hypotension, the quick recovery person. Contrast, and our pancreatitis patient, for example, contrast-associated acute kidney injury will take a big curve, spike the creatinine on day 7, and then come back to baseline. You will have the HRS, persistent shock, like our cardiac arrest patient, who probably will remain an AKI on CKD, or maybe even a CKD, and the last one, the hospital-acquired AKI, will spike sometime later and present to you during a follow-up with derangement of kidney function. So each of these phenotypes of AKI have to be recognized, stratified, and you have to develop your treatment strategies accordingly. So this is what it all means, summarized. So if you look at the susceptibility, you can't change it. But if you can use your functional markers of AKI like creatinine and urine output and combine with them the structural markers like AKI, the biomarkers, you will be able to pick up a good number of patients with subclinical AKI, and you will be able to improve the outcomes of these patients in the intensive care unit. To summarize, AKI is a multifactorial syndrome and has long-term implications. Therefore, early identification is the key. Serum creatinine-based algorithms have some shortcomings and need to be supplemented by biomarker-based algorithms, which may add to the diagnostic and decision-making therapeutic ability of the practitioners. As we grow in the future, seems to be that AI-based platforms will play a major role in identification and risk stratification of patients with acute kidney injury in the intensive care unit. Thank you very much. Have a good day. Any comments or questions? I think I may be able to answer. I'll try, but there are much more informed and worthy people, so I am safe. I can bounce the questions off to them. Valentine Lobo is there, so I think I am safe here. So if any comments, questions are there, I'm happy to answer. And Tapas is just walking in, so I'm even safer. Okay, thank you. If you want to ask me something, I'm available till this evening, so please, thank you.
Thank you, Dr. Srinivas. Moving on to the next session, I would like to call Dr. Ashwati Haridas to give the memento to Dr. Tukaram Jamali. Moving on to our next session, I would like to invite Dr. Sanjay Chaudhary, MD Internal Medicine, FCCM. He has also done his fellowship in nephrology and hypertension, RST Critical Care Medicine. He is a Senior Associate Consultant, Department of Critical Care Medicine at Mayo Clinic, Florida, USA. CVTX, Department of Transplantation, Mayo Clinic, Florida, USA. Senior Associate Department of Internal Medicine, USA. He is also an Assistant Professor of Medicine, Mayo Clinic, College of Medicine and Science. So Dr. Sanjay talk is on biomarkers in AKI, acute kidney injury. Over to you, sir.
Hello, good afternoon, everybody. Is everybody awake? Not hungry yet?
This is your
yes.
Done.
Okay. All right. Okay, so we are going to. Okay. Thank you, Dr. Sahu and the organizing team for having me here. And first of all, putting up this wonderful conference where you have two specialties coming together to work on something that is very common in the ICU. Now, if I can ask for a show of hands, how many of you are practicing nephrologists? Okay. Looks like nephrologists are in minority here. So do I take it that all of you are intensivists? And how many of you are still in training? Okay. Good to see you all, and believe me, there is light at the end of the tunnel. So, achhe din aayenge, as they say. The training must be really busy, but there are better days ahead. So, we are going to talk about biomarkers. So when Dr. Sahu gave me the topic of biomarkers, I was thinking, oh no, not again. Because biomarkers have been in talks and lectures for almost 20 years. And still, I don't think that they have made it to clinical practice. So thus, it was driven by the desire to see a troponin that would diagnose acute kidney injury. So how far have we gotten? So I don't have any disclosures. Didn't want to introduce you to Latin here, 2,000-year-old language, but quo vadis means where are we going? So it's been 20 years since we started looking for a biomarker. We haven't yet made it to clinical practice, at least not universally. And so we are going to see what all has been done so far. So this is the outline of the talk. And the prior talk by Dr. Srinivas has made things really easy for me because he touched on multiple topics that we'll be talking about during this talk. So for a long time, the diagnosis of AKI, or what is the definition of AKI, was not very clear. And until we came up with the Rifle criteria, that's around the same time we came up with the terminology acute kidney injury. And since then, we have been looking for a biomarker that would make the diagnosis of acute kidney injury sooner and the management more nuanced and improved. However, as was shown earlier, we have stuck with your creatinine, serum creatinine, and urine output for the most part, in spite of the evolution of definitions of acute kidney injury and delineation of the severity. So the reliance on serum creatinine and the urine output has been an ongoing challenge for more than 20 years since we started looking for an alternative biomarker. So what are biomarkers? There is a set definition that has been proposed by the FDA, and it's available for anyone who wants to look up a little more on that. But the gist of it is that it is not a surrogate, and it is not an assessment. It should not be an assessment of the clinical outcome. And there can be different subtypes of biomarkers. And all of this is, of course, driven by the cardiologist's troponin. We, in the nephrology world, wanted something that would be as good as troponin in diagnosing acute kidney injury, where we would fix the thing that precipitated acute kidney injury, kind of similar to what the cardiologist had with a blockade of a coronary artery. You open the artery with a stent, and your patient gets better. But as was seen in the previous talk, acute kidney injury is not like myocardial infarction. It is quite a heterogeneous disease, and the pathogenesis is quite complex as opposed to blockade of a coronary artery. And much of the progression of acute kidney injury and the manifestations depend on the underlying illness or the precipitating factor. And it resembles some of the other syndromic diagnoses we encounter in the ICU in terms of pathogenesis as well as the management, rather than a simple blockade of the coronary artery. Now, any talk about biomarker would not be complete without bashing serum creatinine as the biomarker that we have had for many years. So here you go. Creatinine, of course, has been universally accepted, but has not been trusted. There are multiple problems with serum creatinine, as has been shown in the previous talk. It takes 50% of loss of function. It takes 2 or 3 days since the onset of insult. It is affected by the patient's age, muscle mass, and a lot of other problems. Does not help you with the management in terms of numbers, does not prognosticate, and does not differentiate acute versus chronic. What about the urine output? Now, we have had urine output as one of the diagnostic criteria for acute kidney injury, and so there are a lot of proponents of using urine output as the diagnostic criteria for acute kidney injury. Now, is it something that we can rely on? When I was traveling from the United States and was sitting in the 14-hour flight, I was meeting the criteria for acute kidney injury by urine output criteria. So is this something that can be applied to clinical practice? Has been on the back of the minds of all the physicians who have looked at this criteria. Now, the advocates of using this criteria would tell you that we're not talking about healthy adults to apply this criteria. We're talking about critically ill patients who you're giving 2 liters of fluids and the patient is not making urine. That being said, of course, it's not very clear on the definition front. Nevertheless, this was a study that came out in 2015. They looked at more than 30,000 of patients who were admitted over 8 years in a tertiary care hospital and developed acute kidney injury. And they looked at both the serum creatinine and the urine output. And what they found was that a lot of patients could be diagnosed as stage 3 AKI based on the urine output criteria and with normal serum creatinine. And these were the patients who had pretty high mortality. And similarly, there would be patients who were stage 3 AKI based on the serum creatinine, but the urine output would classify them as no AKI. Again, they also had high mortality, but the patients who were classified as stage 3 AKI based on the urine output criteria with normal serum creatinine had higher mortality than the patients who had classified stage 3 AKI based on the serum creatinine. So very interesting data there. That being said, on the other hand, this was a study that came out of Britain where they looked at urine output criteria. This was a very interesting They looked at the urine output of the treating physicians, and for the control, they had the patients who they were managing, and they looked at how the urine output criteria applied there. And in this study, doctors were found to be more oliguric than their patients. And interestingly, of course, the mortality among doctors was astonishingly low at 0%. So, so even though all of you physicians in the ICU, even though your urine output may be low, you are not likely to die, so keep working 24 hours, 48-hour shifts. So the search for ideal biomarker has been on. These are some of the characteristics that the initial researchers were looking for in an ideal biomarker. And of course, there have been a lot of candidate biomarkers, and this is just showing different sites of origin of these biomarkers pointing towards acute kidney injury. Have we found an ideal marker? No. But we have, the search has been on, and this has been driven by the fact that AKI, if you have acute kidney injury in the ICU, you are more likely to die. Now that has been seen repeatedly, as Dr. Srinivas just showed you earlier, and this was another one of those studies where they looked at the epidemiology of AKI in critically ill patients. This was across all the continents except Antarctica. and these were all ICU patients. They clearly showed that the mortality went up with the severity of acute kidney injury, and it was similar across the world. The rate of kidney replacement therapy was almost similar across all the continents, and if you had a stage 3 AKI, you are likely to die 60% of the times. So another ongoing topic is the evolution of AKI into CKD or evolution into ESRD. This was a meta-analysis, looked at multiple studies brought together, and clearly there was higher incidence of CKD as well as ESRD, and you can find similar kind of studies which have been published time and again. So it was logical to think that is the growth of acute kidney injury, is it really happening, or is it because of the diagnostic criteria, or we have been, because of the rifle, akin, KDIGO, all of those, are they leading to more diagnosis of AKI? But it turns out it is a combination of multiple things. Physicians now are more aware of acute kidney injury. They are looking for it. Over the years, the burden of chronic illnesses and comorbidities has gone up, and there is more liberal use of the kidney replacement therapy. Now, so if you were a nephrologist and you were looking at the world from a nephrologist point of view, what do you think? So anybody in the audience, what do you think I'm showing on the screen here? So this was the earlier depiction of the solar system about 2,000 years ago, 2,300 years ago. And this was called geocentric depiction of the universe, where Earth was the center of the universe, and sun revolved around the Earth, the moon revolved around the Earth in its orbit. And Ptolemy and Aristotle were of the opinion that this is how the universe was. And it took another 15 years before we found that the Earth revolved around the sun, not otherwise. So from nephrologist's point of view, kidney are the center of all the burdens of the diseases. And so if there is any problem in the kidneys, there will be problems elsewhere in the body. So we looked for the where the problems could be. And subclinical AKI we talked about in the prior talk, so I will just show that this was one of the initial studies where they looked at critically ill patients. This was predominantly cardiorenal patients, and they found that when the urinary NGAL was elevated, there was higher likelihood of getting renal replacement therapy or dying in the hospital compared to the patients who had non-elevated NGAL with normal creatinine. So this led to the concept of subclinical AKI, where most of the times the patients who are being diagnosed with AKI, they are pretty late, and there's a lot of patients who are not being picked up based on creatinine alone. Then the other thought was that if these patients get repeated insults or acute kidney injuries, then they have continuous decline in their kidney function over time, and they evolve into CKD, which led to the idea of renal function reserve. And this has been looked at by Dr. Ranco's group in Italy, Vicenza, where a lot of AKI studies are done. And the renal function reserve basically provides an assessment of individual patients' risk of developing acute kidney injury. And there's a test where a patient is fed a protein-rich meal, and they assess the patient's kidney's capacity to increase GFR under a state of physiological stress. And they looked at cardiac surgery patients before they had the surgery, and they looked at renal function reserve, and what they found was that the frequency of AKI, according to the preoperative renal function reserve, was clearly correlated on this test. And the AUROC for this test came out pretty good at 0.83. And what they also found was that patients with preoperative renal function reserve of less than 15 were almost 12 times more likely to develop AKI of any severity compared to the patients who had higher renal function reserve. Now, clearly, if the existence of entities of subclinical AKI as well as renal function reserve gives us the background to talk about the stress and damage biomarkers as opposed to the functional biomarkers. Now, these are the definitions of stress and damage biomarkers as opposed to functional markers. Now, urine output as well as serum creatinine are basically functional markers, and they manifest pretty late, whereas stress marker is the first thing to go up, which indicates cell stress, and that is followed by the damage marker, which there has been now structural damage, but yet the functionally patient has not manifested any change in the clinical parameters. So these are some of the biomarker, this is the more recent biomarker classification as opposed to the older classification where we looked at the sites of origin. And so these are the candidate marker biomarkers which have been studied in multiple different small studies, a lot of molecules, but again, none of them have clearly made it to clinical practice. We talked already about the biomarker positive acute kidney injury in the previous talk, so I will not spend a lot of time on this, but yes, this is another thing to talk about, and this has been proposed by the ADKI group for a few years now. I'll say that this has not been accepted in clinical practice as much because the biomarker test is not available for most of the clinicians. Another concept is the continuum of acute kidney injury to the CKD. The acute kidney injury, the duration is from the time of insult to 7th day. CKD starts at 3 months of chronic illness. So during that period, the interval between AKI and CKD, there's a period of acute kidney disease there. Now, there may be patients who may not have satisfied the criteria for acute kidney injury, but then over a longer period, they may have elevation in serum creatinine, which gives rise to the entity called acute kidney disease. Now, in an ideal world, this is how it would be. That if there is any acute insult on a normal kidney, you would have elevation in stress and damage biomarkers, which could persistently be present as the kidney injury evolves. And there could be times where these biomarkers would go down and would reflect improvement in kidney function, and we may also have recovery biomarkers. Now, that is what has been the argument from the ADKI group, where they are proposing these biomarkers to guide the clinical management of all these acute kidney injury patients. But what is the evidence for all of this? So when I looked up the interest in biomarkers and publications that have come out on biomarkers since 2006, so there have been more than 4,000 articles that have been published. So, but then the subheading is that of these more than 4,000 articles, there are only less than 200 of them have been actually clinical trials. So although the interest has been tremendous in terms of finding a biomarker to guide acute kidney injury, we haven't yet found something that is clinically applicable. Similarly, in the ideal world, the biomarker would help you diagnose, prognosticate, and manage all of this. But this has not been manifest yet. This is what has been proposed by the ADKey group, and so far it still seems early for us to practice in this manner. This has been on the basis of NGAL was the initial biomarker that came out in, this was 2005. This was quite promising. In this study, they looked at the occurrence of AKI based on the elevation in urinary NGAL, and what they found was that there were 71 children who were undergoing cardiopulmonary bypass, and the NGAL rose within 2 hours of the patient going on cardiopulmonary bypass, whereas the serum creatinine lagged for 2 to 3 days. And it was quite remarkable that the urinary NGAL went up in that manner, and the creatinine followed so much later. But then the subsequent studies did not prove that to be the case, and since then the ROC curve on the subsequent studies was quite low, neither sensitive nor specific. And since then, the enthusiasm around NGAL has waned. This is another group, the Tribe AKI Consortium, led by Dr. Chirag Parikh and the group now at Hopkins. They have looked at multiple biomarkers here, urinary IL-18, NGAL, plasma NGAL in this initial study. They also found elevation in these biomarkers, but all of these had very poor diagnostic performance if you look at their sensitivity, specificity, and all. So, but then they found that what they did was elevated levels of, on these subsequent studies, they found that the urinary kidney injury biomarkers, when elevated, were associated with as bad an outcome as the AKI of lower severity, meaning that the urinary NGAL elevated to the highest tertile, those patients had similar mortality to the stage 1 AKI in these patients. So again, it is probably has been the basis of the subclinical AKI being similar to the AKI stage 1A according to this study. So AKI stage 1S had similar outcome to AKI stage 1A. Now, since then, we have had the cell cycle arrest biomarkers. This was led by Dr. Kashani. He's one of my teachers at Mayo Clinic, and in this study, we had a lot of patients recruited from Mayo. And cell cycle arrest biomarkers, the IGF binding protein 7 and TIM2, they are damage biomarkers and markers of G1 cell cycle arrest during injury, which is kind of a protective response by the kidney tubular epithelial cells, which goes into G1 cell cycle arrest, and to protect and stops the cells from dividing when the kidney tubular epithelial cells are under stress. And they looked at a lot of biomarkers, other biomarkers in this study. And clearly, the IGF binding protein 7 TIM2 outperformed all the other conventional biomarkers that were there at the time, urinary IL-18, NGAL, and the likes. And also, they were able to look at two different levels of cutoff, 0.3 and 2.0. So clearly the combination product of TIM2 IGF-BP7 more than 0.3 and the other level being 0.2. So if you had value less than 0.3, basically it ruled out the possibility of stage 2 or 3 AKI within 12 hours. And if it was more than 2.0, there was an impending AKI stage 2 or 3 within the next 48 hours. This was again seen in multiple other studies, and the meta-analysis showed an AUROC of 0.84. So we have at least one biomarker which is available commercially as a Nephro check and had reasonable performance. And so this, we are all familiar with the KDIGO bundle. The Pravaki group, led by Dr. Zarbach in Germany, went ahead with this study where he put in patients were selected to have kidney bundle implemented based on the results of the Nephro check. If the patients who were supposed to undergo cardiac surgery, if they had Nephro check result more than 0.3 4 hours after cardiac surgery, they were randomized to go under either standard care or be on the intervention group where the kidney bundle was applied. Now, the kidney bundle also, besides the usual components, there was a lot of emphasis on the hemodynamics of the kidney bundle, and they clearly showed that the AKI incidence in the intervention group was lower. However, there was no difference in the kidney replacement therapy, ICU stay, or the MAKE outcomes at 30, 60, or 90 days. A lot of enthusiasm around this result in one of the editorials that if you implement the Nephro check test on the patient, then you could have one case of the number needed to treat to prevent one case of AKI by implementing KDIGO bundle would be reduced to 6 from 33. So this was the conclusion that many people drew, that now that AKI could be prevented based on the use of biomarkers. So that's what came out of this. And the KDIGO bundle compliance, if you're to look how good it is, it turns out most of us are not good at implementing these bundles. And this is one of the studies that looked at 95 patients at 12 hospitals, and all these 6 measures of KDIGO bundle compliance was assessed. And only 5.3% of all the patients had compliance across all 6 components. So another study, this is the question is, of all the components of the kidney bundle, are they all equal? So in this study, the hemodynamic optimization was the most crucial component to the of the KDIGO bundle that made a difference to the AKI outcomes. There have been some studies which looked at kidney recovery, but none of these have actually made it to clinical practice. I think they are still in research stage. So the question is, are we there yet? Are we at a stage where we can use biomarker to manage our AKI patients? This is what has been dreamed of by the ADKey group and the proponents of biomarker utilization, that maybe we would have patients who are in the middle group where they are where the acute kidney injury risk factors are not very high, the kidney function is mild to moderately deranged, where you could use the biomarkers, the stress and damage biomarkers, and redefine your management, maybe use the KDIGO bundle or other kidney protective interventions to help manage the AKI. However, in my opinion, we have not reached a point where we have evidence to utilize biomarkers at bedside. That being said, we have come a long way from a time where you just had to pray for kidney recovery and urine output to a stage where we can think of implementing different measures, the possibility of biomarkers to guide kidney management. Some places are already there. This is at Italy, Dr. Ronco's Vicenza Hospital, where they have NephroCheck result kind of flashed to the treating physicians on their cellular devices, and that leads to implementation of what we call a kidney response bundle, and they think that they can make a difference. I haven't seen evidence of this working to prevent acute kidney injury, but it's there, it's possible. So I think this is more of an ICU viewpoint or Copernican viewpoint, where the sun is the center of the solar system and there are planets around. But in this context, I guess with the organ crosstalk, it's a multi-system illness. The heart is as affected by the kidneys as the kidney is affected by the heart and the other organs. And there are sometimes the kidneys may be hit by asteroids or meteors, which could be the nephrotoxins. And so it is a multi-system approach to management that we have to implement. And biomarkers may be helpful, but at this point we are not there. So to conclude, we have some biomarkers out there, though it's limited. The performance is variable. Hopefully we'll have damage biomarkers and stress biomarkers more widely available and may help wider implementation of KDIGO bundle. So these are some of the future directions and challenges to think of. Most importantly, we need to move past serum creatinine, which has not happened, and we'll have to work towards utilizing artificial intelligence and technologies. So with that, I'll end here, and thank you for your attention.
Yeah, thank you, Dr. Sanjay. I think it is a very elaborative talk. I know all of you are hungry. So, but we can't help, because once we disperse from the hall, then we will make the workstation ready. So just for the last lecture of the day, and I would like to invite Dr. Soren Panja. So sir is head of the department, Critical Care and Internal Medicine, Rabindranath Tagore Hospital, Kolkata. And he is basically the main head of critical care services and chairman of ISCCM Kolkata branch, recognized teacher and examiner in DNB, FNB and IDCCM, IFCCM. And he is going to speak to us on a very important topic. I think this is one of the very important topic for all the exam going, basically, principles of antimicrobial prescription in the CRRT and in the ICU patients with AKI. So with this, after this, we'll just move for the lunch, and we'll divide ourselves into 4 groups. We have an ID band. Every band is given in your that kit. So just follow the color of the ID band. Every group is almost 20 students each. So we'll be having 4 stations, and they will rotate. Every station is 30 minutes. Okay. So with this, I'd like to invite Dr. Panja. Please, sir. Yeah. Thanks.
Sir, this is this slide change. Yeah, this is the pointer, and this is the next. This is the pointer. Yeah, this is the straight. Okay.
Good afternoon, everybody. And at the outset, I will thank Dr. Gundar, Dr. Tapos for calling me for this lecture. And I know all of you are hungry, as well as I think a bit jittery also. But I can promise in 15 to 20 minutes I will finish my talk. And though I cannot guarantee that I will fulfill your expectations. So, okay. So conflict none. So basically, topic is like that. Once all of us are using right now the AI, and when I put some of the keywords in the chat GPT, the answers was like that. Basically, there was no clear-cut answer for this particular topic. So it was really a bit challenging, because if you go through all the literatures as well as all the guidelines since 2000 till date, so you will find too many. There are literatures are there as well as recommendations, but nothing is basically prospective data-oriented results is very much lacking, or not. It will not fulfill your expectation. So that's why this is the problem. And till date, there are so many researches going on, but this is one area where there is no key research, or the clear-cut recommendations are not there. So if we go through the defined AKI, so AKI, the medical as well as surgical ICU, you will find almost 30 to 50% patients in our critical care unit is suffering from acute kidney injury, and defined specialty has defined distribution of the AKI. And not only that, if you look at the both sepsis-associated AKI, non-sepsis AKI incidence, both in the area is more or less similar for the sepsis and non-sepsis. But for the other organ damage like lung, cardiovascular, and CNS, coagulation, liver, these organs are also sometimes failing, and multiple organ failure is also common, and that actually gives some of the problem in taking decision about the drug dosing. Because once a patient is having only one organ failure versus a multiple organ failure, that will change the dynamics as pharmacokinetic dynamic model of the any drug for the metabolism as well as the drug level. And I am not going in details, but what we have seen from the 2000 till date, there are three major guidelines for the AKI, basically acute kidney injury classification. That is the rifle to start with. Then there are AKIN and then KDIGO, and then we are right now following the KDIGO guidelines. And once I was going through the details of the defined type of study, the different literature is also being published accordingly, because some of the published data was from they use the rifle criteria, and some other they have used either AKIN. But recently from the 2012-13 onwards, there is an inclination towards this KDIGO guidelines publication. And if we look at the AKI is a syndrome where there are defined type of the problem. So problem is like that it is a dynamic disease. So once we are looking for any particular patient, so what is happening the every day, particularly from day 1 till if you follow the day 7, every time this acute kidney injury dynamics is changing. Accordingly, the creatine clearance or whatever is the renal function, that is also changing. So whatever recommendations or antibiotics prescription we will put, that antibiotics you need to change. And that's why, as already we have gone through that, the creatine clearance, though we are using it, the creatine clearance is actually lagging behind the actual kidney injury is happening. So urine output is one of the markers. There are other biomarkers also. Not only that, there are also the risk associated with that. So that's why it is important that every time we should follow some of the antibiotics prescription, and that should be followed and also evaluate during the later part of the picture. So because of the defined stage of the stage 1 to 3 diseases, the KDIGO guidelines, so antibiotics prescription is also not a very linear one. So according to the stage, maybe in stage 1, you need not to change the antibiotics prescription much. But if you are going in the stage 2 or 3, there is maybe some abrupt change. And not only that, some of the patients may go into your renal replacement therapy. So if the patient is on renal replacement therapy, then again there is another extracorporeal, you have used that, and because of that excretion through that extracorporeal route, the antibiotics, the dynamics will be changed. So that is not only that, the extracorporeal route, whether you are using defined kind of the membrane or the dialysis modalities, that will also change the dose modifications. So about the antimicrobial kinetics in the critical care unit patient, most of our patients are maybe sepsis where we are using antibiotics, and other than that there are trauma patient or sometimes the burn patient also so these patients are also getting an antibiotics. So what are the problem common to these patients are basically kidney and liver are the major route of the elimination for this antimicrobial as well as metabolism. So that should be taken. So along with the kidney, some of the your antibiotics may be excreted through that kidney, and other antibiotics may be partly excreted or metabolized through the liver. So most antimicrobials usually follow the linear first order kinetics, and plasma level for the antimicrobials depend on some of the factors like the dose we are using it, the bioavailability of the antibiotics. In critical care unit, we don't use the oral route or IM route. Most of the time, we use the intravenous route. So its bioavailability is almost 100%. And then there are other factors like volume of distribution. So patient is a very sick patient. We are giving with multiple fluids as well as resuscitation fluid. So that time, and because of the sepsis, or if we consider any acute systemic inflammatory response surge is very high, that time because of the permeability, catabolism as well as the inflammatory mediators, there is sometimes patient is hypovolemic, there is permeability increase, means there is extravasation of the fluid, as well as there is alpha glycoprotein type of substance. They also compete for the antibiotics for the binding with albumin. So these also matter. So volume of distribution as well as protein binding, both are changing, and that should be taken care of, and rate of metabolism. So metabolism, we are talking once the kidney is failing, sometimes patient is having a multiple organ damage. So the metabolism sometimes changes, and the initial part, if we see, that there is sometimes hypermetabolism sometimes. And not only that, there is also hyperperfusion before the actual acute kidney injury settles. So that time your kidney, the creatine clearance for a short time may be higher. So that your antibiotic clearance also may be higher in some cases. And also the drug excretion. So excretion route is also other organs like liver, or sometimes the kidney. There is kidney, the glomerular filtration is one route of metabolism or excretion. Along with that, sometimes there is secretion as well as absorption. That is always happening in the kidney. So that's why it is a very complex situation. And once we are using this, we are putting this patient on the renal replacement therapy, then we have to taken care of the patient-specific factor as well as on the other side, the extracorporeal, this renal replacement therapy. So what are the challenges with this background? So there is lack of the prospective data, heterogeneous patient population, because every patient is unique and there is having a defined kind of stress as well as renal failure. It may be in defined stage as well as the patient is on either renal replacement therapy or without renal replacement therapy. Model-based studies, so there is no clear-cut guidelines with the human studies. There are certain other studies, so like Monte Carlo simulation study or sometimes other pharmacological-based assay. So these studies are basically, they used to give these antibiotics different doses and follow in a regular interval what is the plasma level of this drug. So these are the Monte Carlo simulation tests. So this test is also sometimes is in practice it may be difficult because we are not always monitor the therapeutic drug monitoring system. That facilities is not available, as well as the standardization is another problem. So sometimes we are also AKI patient on medical therapy versus RRT or renal replacement therapy. There will be change in the kinetics, combination of the antibiotics. So if we consider one piperacillin and tazobactam, the kinetics of the piperacillin in the face of acute kidney injury will be little different from the tazobactam. Similarly, right now the available ceftazidime and avibactam. So if you look at the kinetics of these two molecules, once we are using as a single molecule or single dose, but the kinetics changes. So that should be also taken, because in acute kidney injury, their kinetics are little different. Technical challenges regarding the technique, already I have mentioned that the facilities should be available as well as standardization is a real challenge. So as a consequence of increased plasma antimicrobial level, so we know there are different kind of toxicity that may happen, and sometimes the concentration of the antimicrobial may not reach at the EA. So if we are giving one antibiotic, so we are looking at the plasma level. So sometimes when this patient is in say sepsis with the volume of distribution is different, so we should always look for what are the target tissue concentration of that particular antibiotics. So it is not the only plasma level or the blood level. So along with that, what is the tissue level? So that is also important. That can also be changed during this time of in AKI patient. So already we have discussed about this creatine, defined kind of GFR calculation that is there. So GFR calculation, there are defined controversies, but still if we look at why I have put this slide, if we look at the companies' directions of the using antibiotics, these are basically done by the most of the time Cockcroft-Gault formula. So this is the calculated, but the gold standard right now, most of the recommendations are MDRD. But if we look at the oil company or the any guidelines, so it is because of the Cockcroft-Gault. So we have to change our direction. So we should not stick to that particular guidelines. That is very important. So again, the problem with the Cockcroft-Gault is in AKI patient. This was basically meant for the CKD patient. In AKI patient, it may not be applicable, and that too when the patient the kinetics is changing. For that, you can also follow. There are 4 hours creatine clearance that can be followed, or sometimes there is this jellyfish method. So these methods are some methods where you can in a short time you can change what is the kinetics of the creatine that you can apply to your patient. So that is the way to overcome this type of the problem. Regarding the weight, sometimes you may find the patient is underweight, overweight, or sometimes patient is basically ideal weight. So if the patient is overweight or underweight, depending on that, some calculation. So you should just follow. If the patient is underweight, so please follow the ideal body weight that should be applied. And if the patient is more than 25% of the body weight than the ideal, so that time you should calculate the adjusted body weight. So that is important for the calculation of the antibiotics. And about creatine, already there was a discussion about the drawbacks of the creatine clearance. I am not going into that. So now if we look at the what equation we will follow for the dosing. So calculating the antibiotic dose, we should follow this. Some of the starting points should be, so we should first look at the acute kidney injury, stage of the kidney injury, as well as creatine clearance that is there. And along with that, toxicity of the antibiotics. So some of the antibiotics, they have a very high toxic level, or the therapeutic index is very narrow. So that time we should be very cautious. So if we consider the cephalosporin versus the aminoglycoside, the cephalosporin has a broad window. So you can give a higher dose without any much problem. But in aminoglycoside, that may not be true, particularly in the acute kidney injury patient. Clinical condition is very important. If we look at the sepsis, and in the what stage of sepsis, that is important. So in the early phase of sepsis or any early phase of the trauma patient, so or burn patient, this patient in the initial part, as I discussed in the initial 12 to 24 hours, this patient might have a higher creatine clearance. So that time your antibiotics dose should be increased, maybe at the tune of 20 to 30% than the usual dose. But later you have to adjust, or maintenance dose should be calculated later on. So infection, what particular infection you are treating? If you are treating a bloodstream infection versus a cellulitis versus one meningitis, the antibiotic dose changes. So that should also be, you should calculate that dose accordingly. And target organism. Sometimes if you are treating one bad ESBL or sometimes KPC type of organism, always look at the higher doses of the antibiotics, because there is every chance of failure. And once we are right now we are getting too many cases of the multi-drug resistant or even the extended drug resistant organism. So here is the key that we should not underdose this patient. So if we look at the classification of the antibiotics, there are 2 groups of the antibiotics. Some antibiotics are the hydrophilic, some antibiotics are basically hydrophobic or the lipophilic. So what is the difference? The hydrophilic antibiotics, the volume of distribution is basically, they usually stays in the extravascular space, mostly within plasma, or maybe a little bit in the extracellular space. So the total volume of distribution in hydrophilic antibiotics much less. So usually less than 0.6 liter per kg. But if we look at the hydrophobic or the lipophilic antibiotics, their volume of distribution is quite high, usually more than 0.6 to 1 liter per kg of body weight. So why it is important? Because the hydrophilic antibiotics, if these patients you are giving antibiotics, the plasma level will be reached very fast. But once this patient is you are putting in the renal replacement therapy, what will happen? The plasma level will be very fast. Early phase, the plasma level will drop. So that's why there may be need for the after renal replacement therapy 1 bolus dose. But if you look at the hydrophobic side, that change usually does not happen. So that's why you can go through this. These are the antibiotics which is having the hydrophilic. that is the beta-lactam antibiotics, aminoglycoside, glycopeptide, linezolid, colistin. So usually for this group of antibiotics, sometimes you may need to give a bolus dose post-renal replacement therapy. But in the hydrophobic or the lipophilic antibiotics, so here these antibiotics may not be repeated after renal replacement therapy. So about the volume of distribution, as already I have discussed, the hydrophilic antibiotic, the volume of distribution usually within 0.3 to 0.6 liter per kg of body weight. But if it is on the other side, the hydrophobic volume of distribution usually more than 1 liter per kg of body weight. So if we look at the antibiotics pharmacokinetics or dynamics, I think most of you know this one. Just for a recapitulation, and on the basis we can also decide which type of antibiotics should we actually repeat the dose, or how we can modify during the time of renal replacement therapy. So there are 3 types of kinetics. Usually this is if any antibiotics is having one MIC or minimum inhibitory concentration. So there are antibiotics who are the antibiotics killing or the antibacterial property depends on the time it is above the MICs. We call it as time-dependent killing. Usually cephalosporin, penicillin, carbapenem, these are the time-dependent killing. Usually we prefer that this time of the coverage above MIC should be usually more than 50%. Ideally, if you can keep it more than 100% time, it is the best, but that may not be practical. So that time we usually try to find out if there is at least 50% time it should be above MIC. And there is another, the dose-dependent killing. So some of the antibiotics like your aminoglycoside and sometimes the fluoroquinolone also is having a maximum concentration in the plasma, actually gives you basically better killing property or the inhibitory property. So this is the MIC divided by this MIC, and if we consider the Cmax, so it should be ideally 8 to 10 times than the MIC level. And in some antibiotics, they work on the principle of area under the curve. So how much it is above the MIC as well as this curve. Basically, the total area should be above this MIC. So that we express as area under curve divided by MIC. So some like antibiotics like fluoroquinolone, glycopeptide, they actually works on this principle. Not only that, there are certain antibiotics, particularly this fluoroquinolone and colistin, there is one effect, post-antibiotics effect. So once the antibiotics level is low, but still they will continue to inhibit the your bacteria. So that is the way they maintain sustain your bacterial killing as well as inhibitory property. So that way it helps. So along with that, sometimes, so this is the basically a patient. Once we are monitoring what kind of antibiotics and doses, I am not going in details. It is like that some antibiotics you can also monitor, therapeutic drug monitoring. So the peak level as well as trough level you can monitor. Usually peak level should be monitored after giving the dose, 30 minutes to 60 minutes. You can take the patient blood sample for the peak concentration, and the trough is usually 30 minutes to 1 hour before the actually next dose. So that is the trough level. So that way some antibiotics, particularly penicillin, cephalosporin, carbapenem, these may be monitored, and actually monitoring should be what I mentioned, that the 50 to 65% time should be actually above MIC level. So that way the killing happens. But if we look at the colistin and fluoroquinolone, so this actually the therapeutic drug monitoring, particularly the colistin, is not much helpful. But for the other antibiotics, it may be helpful, particularly once the patient is in renal replacement therapy. And if we come to the renal replacement therapy, what are the problem or confounder that can happen in the renal replacement therapy? You will see that the membrane are different, because that depending on the membrane, there is also protein binding. Once the patient, any antibiotics is with albumin, so this membrane interact with this albumin, because the membrane is cationic and albumin with this protein usually anionic, they normally bind. So there is one side, there is basically the ultrafiltrate, diffusion, convection, everything is happening. So that is one part of the excretion. Along with that, there is also binding of the antibiotics in the membrane. So along with that, what will happen, once there will be a steady state concentration will reach after some time. But if you change the membrane, that time that kinetics may change. So that's why that change of the membrane also confounds your antibiotic dosing. So that is important. And if we can, you can see that there is a concentration at this level pre your membrane and post membrane. So difference between this, it can give a rough idea about how much antibiotics you need to give after this dialysis or not. Once some of the antibiotics need are loading dose post dialysis or renal replacement therapy. And not only that, if you are giving any fluid, either pre-membrane or post-membrane, that also changes. Because pre-membrane, if you are giving some fluid, so that time the antibiotics, the excretion will be less. So that time your blood level or the plasma level may be monitored in a higher side. But if you actually give some fluid in the post-membrane, that time the antibiotic doses may be, actually concentration may be low. So that also changes your kinetics. So accordingly, so some of the antibiotics, you can follow this graph. So some antibiotics, particularly teicoplanin, linezolid, ciprofloxacin, ampreloxetine, these antibiotics does not require any dose modification. But if you on the other side, if these are actually this tazobactam, vancomycin, ceftazolime, pucloazole, gentamicin, and amikacin. These antibiotics during the dialysis or during renal replacement therapy, there is excretion. So that time there should be post renal replacement therapy 20 to 30%, or sometimes your another dosing may be required. So usually what is the best one, that your dialysis should be started after, say, once the next dose is there, 4 to 5 hours before the next dose, you can initiate the dialysis, then continue with the dialysis. Post renal replacement therapy, you can give a loading dose. So this is, I will give some examples. So piperacin and tazobactam, the dose varying among defined study. Usually recommended dose is basically 4.5 gram bolus followed by usually 8 hourly or 12 hourly. In the initial 24 to 48 hours, there is no need to change any dose for the piperacin, tazobactam, or any other penicillin, cephalosporin, or monobactams. But later part, after 48 hours, you can change the doses. And usually after the renal replacement therapy, you can replace 50% of the doses. This is also partly true for the ceftazidime, avibactam, and cefepime and tazobactam, or cefepime as a single molecule. Carbapenem, more or less similar type of your model should be followed. So meropenem, you can give 1 to 2 gram bolus, followed by in the 24 to 48 hours, you continue with the same dose. But after 48 hours, you can go with 500 milligram 8 hourly, and 500 milligram dose may be repeated after your renal replacement therapy. Colistin, the dose is very difficult, and that there is no clear-cut recommendations for the colistin. So usually bolus dose is 9 million unit, followed by 1.5 to 3 million unit 8 to 12 hourly. And there is no recommendations, particularly post-renal replacement therapy. Some people believe that the polymyxin B may be given, or a bolus dose may be given after renal replacement therapy. But about colistin, there are differing opinions. So, though there is no recommendation for the therapeutic drug monitoring, and right now we are in the era of multi-drug or extended drug-resistant organism, I think there should be some standard for this colistin also for the therapeutic drug monitoring. So in nutshell, the AKI in ICU needs individualization of the antibiotic doses. PKPD model should be used for optimal results, and prospective data are lacking. So we should use our clinical judgment as well as some of the basic principles of pharmacodynamic and pharmacokinetic model. And therapeutic drug monitoring will be benefited, but as we know, the facilities are not always available, and sometimes you may not get in right time. Most of the antibiotics do not require any dose adjustment during initial 24 to 48 hours. With this, I conclude my talk, and if, I hope all of you must be hungry. If there is any question, that may be discussed later.
Thank you. So just 2 minutes, I'll just take 2 minutes of yours. So before we conclude and go for the lunch, so just be sure that everybody of you got the kit, and inside the kit you have a band. So according to that band, we have divided into 4 groups. So there are 4 groups, one with a CRRT, mechanism of CRRT, second is the CRRT hands-on, third is CRRT with ECMO and plasmapheresis, and the fourth one is like the learning station. So you just divide among the 4 groups, 20 each. And then you come for the wash station. After that, we'll have a live demonstration of Vexus on the stage by the volunteer with Dr. Kedar Toraskar, and with the theory being presented in the PPT format. Okay, and so with this, Ipsita, so I think we'll just disperse for the lunch, just 30 seconds. She will have give some mementos to the speaker.
Thank you, sir. I'd like to call Dr. Ramanathan to give the memento to Dr. Archana Thakur, intensivist, MGM Hospital, Navi Mumbai. Dr. Ramanathan. Okay, Dr. Ramanathan is not with us. I would like to call Dr. Ravindra Nikhalji to give away the memento to Dr. Archana Thakur. Now, I'd like to request Dr. Sanat to give away the memento to Dr. Swarin Panja. Now, I'd like to request Dr. Jay Kothari to give the memento to Dr. Sanjay Chaudhary. I'd like to request Dr. Shantanu to give away the memento to Dr. Sanjay Chaudhary.
So we'll keep the lunch time 45 minutes. So hope we will be gathering again after 45. Please stick to the time.
I want to say I want to start a dialysis. This is the first screen that comes. If I look, so this machine has been disinfected today morning at 4:23. So I know that the machine has gone through a proper disinfection cycle. Then I can start. Now when I want to start, if you heard the lectures in the morning, the machine has to prepare a dialysate fluid which is similar to body composition. So the machine takes water through its water inlet, which is with this red pipe, and it takes in salts from here. So because the dialysate must contain bicarbonate and it must contain calcium. If you mix calcium and bicarbonate and keep them standing, it will form calcium carbonate, which is the chalk. And as you know, chalk is a precipitate. So you will get your dialysate all getting precipitated. So because we do not want that to happen, we get the dialysate, it comes as two separate parts. The acid concentrate, which contains all the salts like sodium chloride, calcium chloride, potassium chloride, a small amount of acetic acid or citric acid, depending on which buffer is being used, which has a low pH. The pH of this solution is around 4. And then you have a bicarbonate, sodium bicarbonate, which is at a much higher pH, and the two are mixed in a definite proportion. So what proportion they are mixed in is seen over here. So here, because they have been using the buyback, the proportion is set at 1+34. If we are using two liquid concentrates, it will say 1+35.83. That means the machine will take 34 parts of water, 1 part of acid concentrate and 1.83 parts of bicarbonate, and mix them together within the machine. It will heat it up to the desired temperature. So we can set the temperature at what we want our dialysate. So 36.5, this machine can go between 35 and 39. It won't go below 35. So your patient will never get hypothermia, and it won't go above 39 because that would be dangerous and you can get hemolysis. So the manufacturers have set a level of between 35 and 39. Usually we keep 36 to 37 degrees as the dialysate temperature. So the concentrates are mixed so that you get a dialysate which is very similar to plasma, except that it has a low potassium. So it will have a very low potassium. The potassium of dialysate is usually around 2. It has a sodium which we can set over here. So it says base sodium, which is what the machine will take if you don't give it any orders, and then prescribed sodium. Now you can prescribe your sodium at anything between 128 to 148. Beyond that it won't go. Even if I press confirm, you'll see what happens. And go back to the menu. It will still go back to 148. Okay, and over here, this is what is known as the conductivity. So conductivity is the ability of a solution to conduct electrical current. So this dialysate, if it has a sodium of 140, it will have a conductivity of 14. Okay, that's here. So if by chance the sodium concentration is not within the physiological range, or the bicarbonate, dialysate has a high bicarbonate, so it is saying here +4. In actual fact, the default value is about 32. When it says +4, it means that we have set a dialysate bicarbonate of 36, very effective for correcting metabolic acidosis. So in this situation, the conductivity of the dialysate is determined by its sodium mainly, and the simple relationship is 10 times the conductivity is equal to the sodium. So if you set 148, the conductivity will come to 148. And the range over here you can see is 12.8 to about 15.5. Beyond 15.5 would mean a sodium of more than 155, which is dangerous. So the machine will go into bypass. It will not give the patient a dangerous sodium level that will put him into dysnatremia. So how does it prepare it? And it will test it. The machine will now do a self-test. So this test button started flashing as soon as I release this. So normally I will remove this and I will put it into this can of A concentrate. And I saw a bag of bicarbonate. I saw a buy bag. Hai buy bag? You have a B bag. Yeah. So this is the sterile bicarbonate. So if you want to do hemodiafiltration, then you will use this sterile bicarbonate. What you do is you open this and you place this here. I'm not going to do it now. And you close the cover. and the machine, you can see there is a tube there. It will inject water into this, it will make a bicarbonate solution, and it will add bicarbonate to the dialysate in that situation. Now it's gone into test mode. So if I press the test button, the machine should do a self-test. In the self-test, the machine tests all its alarm systems and its backup systems. It's saying test bypass. Now this is something you don't want to ever see on your machine, that you can bypass the test. The test has been bypassed. Yeah, water alarm NRS. Oh, मला टाचणी देता का कोणी? एक टाचणी द्या. Give me a टाचणी. Yes, we add some amount of sugar. What? Some dialysate concentrates have already added glucose. In some of them we have to add. That's the switch for bypassing the self-test.
This 5008 what I mentioned is traditional dialysis or only for states?
You can do traditional dialysis on it. Unfortunately, I don't have a plug socket to plug it in and show you the menus.
So only difference is two endotoxin.
Two endotoxin filters and a second pump. So this is the pump which will prepare, from which you deliver your replacement fluid, and this is the replacement fluid port. So you connect a line here, take it to the pump, and then connect it either pre or post filter. So it will deliver your replacement fluid. So you can do hemodiafiltration with this. Yeah, I can't prime it because it's not getting water. The black is the drain. So the dialysate gets prepared, it goes to the dialyzer, then it goes back to the machine where the machine checks that the dialyzer has not ruptured. There is a blood leak detector, and from the blood leak, from there it goes to drain. So if you've said 500 ml per minute, every minute 500 ml of dialysate is going to the machine and then going to drain. Okay, so what we'll do in the meantime, I'll show you the others. Okay, so this is the calibration screen. So if you want to set up or change your parameters of operation, you go to this mode of the machine. Okay, so you can calibrate arterial pressure, you can calibrate, rather than calibration, we'll go to setup menu. Setup dilution. So we saw that it was saying 1 plus 34. It's set at 1 plus 34. In this menu, I can change the setup. Variable setting, 1 plus 44, that's the Belgian concentrate, 1 plus 44C, 1 plus 35.83. I told you. So if it takes one part of A, 1.83 parts of B, and 34 parts of water, then it will use this 1 plus 35.83. 1 plus 35.83 with NaCl 26, which means the B part is not only sodium bicarbonate but contains 26 grams of sodium chloride as well. 1 plus 35.83 with sodium chloride 20 grams. and back to canister 1 plus 34, which is the buyback setting. So you can change the settings in this mode to whatever type of concentrates you are using. Then this is setup menu, miscellaneous, diagnostics. In diagnostics, we can check there are about 173 valves inside the machine. There are 2 flow pumps. There is a float switch. There are various things. So we can check the function of all of these in the diagnostics mode. And last of all, we have the calibration mode. In calibration mode, you can, in calibration mode, you can calibrate arterial pressure, you can calibrate venous pressure, you can calibrate the blood pump rate. So I said that the rate is set, you can calibrate that. You can adjust the ultrafiltration volume. You can calibrate the degassing pressure. You can calibrate the dialysate flow. So this machine has got 3 flows, 300, 500 and 800. 500 and 800. This machine has flow in increments of 100 all the way from 100 to 1000. So you can go to a dialysate flow as low as 100 or as high as 1000. This has got just 3. You can calibrate the temperature. You can calibrate the mixing system. So I said it must take 1 part of acid, 1.83 parts of bicarbonate and 34 parts of water. In this, you can check that it's actually taking that. You put this into a measuring cylinder filled with 100 ml of water and start this and see how much it sucks after so many strokes. Calibrate conductivity. So the conductivity should be within the range. You can calibrate that using an external meter. You can calibrate dialysate pressure, blood leak detector. So I'll show you the blood leak detectors and other things. Failure record, this is not for us for today. So this was the calibration menu. So now on this, what you can see is there are 4 scales here and there are 5 alarms. So the alarms are the air detector alarm. So I showed you this is the air detector and what will happen if an air bubble by chance goes. So supposing we are giving saline pre and the saline bottle got over and the machine sucked air. So the air will not go to the patient. The air detector will trigger alarm. It will clamp the line and it will stop the blood pump in that situation and it will start flashing here. Then you have an arterial pressure. So the pressure in the arterial line is always negative. So you can see that it's 0 is at the center of the scale. So it usually negative. This is pre-pump pressure. So the pump is exerting a negative pressure in order to pull blood from the patient. So it is a negative pressure. And then you have a venous pressure which is positive. So anything immediately it crosses. If you saw that line set when I opened it, don't want to take it out, otherwise they won't be able to. You can see that all these connections are red and there is another tubing on which all the connections are blue. Okay, so the blue line is called the venous line and the red line is the arterial line and then this is the replacement fluid line. Okay, this is known as the safe line or replacement fluid line. So this also has a pump segment which goes in this pump and through which we deliver replacement fluid. So you have an arterial pressure, you have a venous pressure, then you have transmembrane pressure. I think somebody was talking about transmembrane pressure in one of the sessions in the morning. So transmembrane pressure is the third. It's a derived pressure. So arterial and venous pressure are measured directly by the machine from the ports. Transmembrane pressure is calculated by the machine. It is pressure in the blood compartment minus pressure in the dialysate compartment. That means if this is your dialyzer, it is inlet pressure plus the pressure in the blood compartment is inlet pressure plus outlet pressure divided by 2 and dialysate pressure is again the same thing. So inlet pressure plus outlet pressure divided by 2, that's the average pressure in the compartment. Now in his lecture this morning, Dr. Chelani told you that you have blood on one side of the membrane and dialysate on the other. So the pressure across the membrane, that is the difference between the 2 compartments, that is the transmembrane pressure. So blood compartment pressure minus dialysate compartment pressure is the transmembrane pressure. Okay, so that is right. We'll go to the dialysate menu. I'll show you the rest of the thing. So base sodium is factory set. Prescribed sodium we can change. Prescribed bicarbonate we can change. It can go up to plus minus 8. Beyond 8 it won't go, and that is 40, bicarbonate of 40, and it will go to minus 8, that is 24. So this is the range within which you can set the bicarbonate. Okay, temperature, dialysate flow. So I told you this machine has got 3 flows, 800, 500 and 300. Only 3. In this machine, which unfortunately we can't switch it on, it can be switched on now? We'll have to plug it in. You'll have to plug this. Then we can show them a lot more things on that.
TMP, how much is normal?
Normal. Okay, so this dialyzer here, it will tell you. On karun taka. This dialyzer, it has a total transmembrane pressure of 500. If it goes beyond 500, the membrane will rupture and blood and dialysate will mix and the patient can bleed into the Good, thank you. So this has 3 flows, and once this boots, I'll show you the thing on that. Then it says sodium profile. So sometimes we want to do ultrafiltration, but the patient is hemodynamically unstable. So what we can do is we can profile. We can set a different rate of ultrafiltration, and we can keep a high rate of ultrafiltration with a high sodium. So during that time, this morning somebody was talking about in one of the lectures about the plasma refilling, that whatever you are doing, you are tackling the blood compartment. So you want the blood compartment to refill during that time. So for the blood compartment to refill, the osmolality should be high. Now when we do dialysis, we are actually bringing the osmolality down. We are removing urea and other things. So we are bringing the osmolality down. So we would like to maintain the osmolality higher. So we keep a higher sodium. So the plasma sodium goes up. The osmolality remains good. Water comes in and you can do more ultrafiltration. Okay. So dialysate menu here we will go to. So here you have so you have flow over here. So you can see I can choose flows from 100 to 1000. So I can choose any flow I want, say 200, and press OK. Oh, it's been put on auto flow, that's why. So that other option is there, which is in this machine, which is called auto flow. So in auto flow, if your access is not giving you a blood flow, then you are wasting dialysate. So when you set auto flow and you set the factor of 1.2. So if your blood flow is 100, you are not getting more than 100 flow, and you set auto flow 1.2, it will do 120 ml per minute of dialysate. So dialysate won't be wasted. Otherwise, you have set a very high dialysate flow, say 500, but you are wasting. Then temperature is here. So you can set again from in this machine 34 to 39, and then you can see the so in auto flow I'll say no now. So now it is on no. So now with concentrate. So these are the concentrates you can take. Now here this machine has this other advantage. It displays the entire composition of dialysate. So you can see sodium is 136, potassium is 2, calcium is 1.5, magnesium is 0.4, chloride is 106, bicarbonate is 35, and acetate is 3. That is the acid part of the bottle. Okay. So now if I go to flow, now I can set other flows. Okay. So now I can set. Once I remove the auto flow option, then I can set whatever flow I want. Okay. So that is one thing in this. Then options. So I'll show you online instead. So here you have the options of online. So it says HDF pre-dilution. So that means hemodiafiltration pre-dilution.
Only 5 minutes left. Please be faster.
So you have options of plain hemodialysis, HDF pre-dilution, HDF post-dilution, HDF, HF, hemofiltration only pre-dilution, and hemofiltration post-dilution. And here what you set is your substitute goal. So you decide that in Sharmili's lecture she was talking about 23 liters being the optimum. So you decide that you want to do 23 liters of substitution fluid, and you set your time of your dialysis. Replacement. Then Fresenius calls it substitution, Baxter calls it replacement. Same thing. So you set your time and goal, and the machine will calculate the rate. So the rate now is 50 ml per minute. So that's 3 liters per hour the machine is going to do. And here again you have the auto sub option. So you press auto sub. Now if I put auto sub on, then it will go into auto sub flow. And what other? These are the other options. So there is a body temperature monitor. There is a blood pressure monitor. BVM is not loaded on this. On mine it is loaded. BVM is also there. Heparinization. You can set your heparin, how much you want. You can put your heparin syringe over here. Here, this is your syringe pump for heparin. And these are your arterial and venous pressure monitor and ultrafiltration.
So this one where is
This is the best machine for sled. This is a conventional dial, but it doesn't mean, and that is the message I would want to give everyone. Just because you don't have this machine doesn't mean you can't do sled. You can do it with this.
But by definition, sled having dilated flow of like
the lowest possible.
200 ml.
Yeah. So this has a minimum of 300.
300 ml. So
I'm done.
we can use
We can use it, but then the minimum flow we can keep is 300. With this you can go down to 100. And the additional feature, I didn't get to show anybody the UF menus. So in the UF menu here, it won't come, there's no blood in the system. But you can see it on this. So in the UF menu, you set a UF goal. So supposing I want to take out 2 liters, okay. UF time, so I'll set 4 hours. So the rate is 500 ml per hour. Now your patient is hemodynamically unstable, so you want to do sled. So you change this to 10 hours. Your UF rate falls down to 200. You want to do it like a CRRT, you set this as 24. Your UF rate falls down to 84. Yeah.
For diaphragm, there can you do mixing both pre as well?
Not on this. It has only one pump. Mine has 2 pumps, one above and one.
your hybrid.
Yeah.
Hemodialysis to
Not on this machine. My 5008 has 2 pumps. So then I can do it.
So this one we are setting blood flow rates, right? Dialysis
Yeah.
flow rate, how to change it according to blood flow rate?
If you want to change it according to blood flow rate, you use the auto sub function. Auto flow. HDF factor. You set a factor that I want it 1.5 times the blood flow. If the blood flow is set at 200, the dialysate flow will go to 300.
So in this we can't set.
In this you can't do that.
So what we'll do is
In this you have only 3 options: 300, 500, 800. That's it. Mine is 5000. This is 5008S. Mine is only 5008. Yeah. And it's got the pediatric option in mine. Mine has a pediatric option. Yeah. Lower blood flows and all of that is allowed in mine.
10.
Where? Yeah, 10. 10. Huh. Normally in normal hemodialysis. In SLED you go much lower than that.
That machine is an earlier.
No, mine is a later version than this. This is an earlier version. Yeah, because mine has got even these diasafes are in a side compartment. Here they are at the back. And mine has got
CRT with that machine.
with that machine you can do, and that has got wetness detectors which are not there on this. So if there is a leak, it detects a leak by wetness.
It works on the diffusion principle.
It will work on it will give you, but you will have to give by an external pump. You will have to give the replacement. If you want to do convection, you can do it, but you will have to give replacement with an external pump.
Normally they remove some ultrafiltrate or
Yeah. Okay. Good point. When you are normally removing ultrafiltration, you are targeting say 2 liters of ultrafiltration over 8 hours in a sled. So that's 250 ml per hour. There is very little to no convective clearance. If you have a 60 kilo adult, that falls at 4 ml per kg per hour. In order to get a good convective clearance for a CRRT style, you need to have 25 to 30 ml per kg per hour. Now, if you set 25 to 30 ml per kg per hour for a 60 kilo adult, you will have to set an ultrafiltration rate of between 1.5 to 2 liters per hour. Once you set that, in that situation, you have to give replacement, otherwise that patient is going to go into hypotension very quickly. Now, when you do that on this machine, you select hemodiafiltration, the machine automatically will replace whatever replacement substitution you have set. So you decide, I want 2 liters per hour, the machine will take out 2 liters and replace 2 liters. Over 8 hours. Yeah, no, you want 2 liters per hour, you can set it and the machine will give the replacement. In this it will not. You will have to give it with an external pump. Yeah. And then there's no balancing. If your pump stops, the machine will continue. Or your machine stops, your external pump will continue. So there can be fluid imbalances. With this, the same system is delivering both. So if one stops, both will stop.
Do you expect TMP change is if you're trying to do filtration also.
Yes, yes.
And will
So
it support 500
it will. It will support. You use a high flux dialyzer. Ultrafiltration rate is equal to TMP into ultrafiltration coefficient. This dialyzer has an ultrafiltration coefficient of about 15. So at 500 TMP, it will remove 7.5 liters per hour. You take a high flux dialyzer, it has an ultrafiltration coefficient of about 40. So at 500, it will remove 60 liters per hour if it chooses to, without change.
Every pump has a different coefficient.
Every dialyzer has a different ultrafiltration coefficient. So this says F8 HPS. F means Fresenius polysulfone. 8 means it's 1.8 meters squared. HP is high performance and S is steam sterilized.
But sir, technically we can't use it on this because it's not ultra pure water, right?
You can't do hemodiaphragm. No, you can. You give saline or replacement fluid from a pharma company. Pharmacological. You can't use the dialysate from this as replacement, but you can give it from externally with bagged fluid. So you put your bagged fluid, you put an infusion pump, and you use the ultrafiltration system of the machine. So I've done that. When I didn't have a 5008, that's what I used to do.
Thank you, sir.
Okay.
Dosing. How to set up prescription troubleshooting? Yes, sir?
ग्रीन कलर है मैम, टेबल गलत हो गया, आपको वहाँ पे जाना है.
Green table has to go there. Okay, so good evening. This is station 1 of CRRT. So here we will be talking about some of the basic terminology, some basic mechanisms of CRRT. So this has already been covered in your earlier session, but we'll just be doing a revision so you will be able to follow the next station appropriately, okay? So as you know, CRRT is an extracorporeal blood purification system. It's a form of dialysis that is done very slow over an extended period of time. Extended period of time means at least 24 hours we do it, right? So what happens is, in hemodynamically unstable patient who does not tolerate a higher rate of flow, we use this kind of a therapy. So in this, whatever solute or fluid we are removing, it is very slow. And but overall, if you see, if you're continuing the CRRT for a period of 48 hours, the amount of solute that you remove ultimately is going to be more than what you do in your intermittent machines. So there are the different parts of the machine. There is a veno-venous circuit. So you know, there's a dialysis catheter, a circuit, a dialyzer or a hemofilter. So the blood flows from the veno-venous circuit through the dialyzer with the help of an extracorporeal blood pump. The rate of blood flow we can keep 200 to 200 ml per minute. There are various solutions that we use, like your dialysate, replacement and all, to achieve your solute balance or fluid balance and all. This replacement fluid which we can give, that we can give either before the filter or after the filter. So we'll be showing you that in the subsequent slides. So basically there's a microprocessor driven control system through which this ultrafiltration is maintained. So indications for dialysis, any indication for dialysis, why you do dialysis, your acidosis, correction of acidosis, hyperkalemia, removal of toxins, fluid overload, correction of hypothermia or hyperthermia. Plus there are some other indications for which we do dialysis for some patients, example of fulminant liver failure, when you have to remove the ammonia, heart failure, or maybe when there is traumatic brain injury, there is raised ICP. So you don't want a rapid shift in urea. So for many indications we can use CRRT. So we'll talk about the different mechanisms how solute transfer happens, any form of dialysis. Okay, so there are three main forms of substance transfer, like we discussed today earlier also. The first one is diffusion. So diffusion means a solute will move from an area of high concentration to an area of low concentration. So it moves down the concentration gradient. So this movement obviously will depend on the solute characteristics. It will depend on the size, the charge, the protein binding of the solute. It will depend on the membrane, the surface area of the membrane, thickness of the membrane. It will also depend on the rate of delivery of the fluid, how fast it is being delivered. So with this form of diffusion, we are able to remove small molecules. Less than 20 kilodaltons, we will be able to remove effectively with this method. Anything that is higher, larger molecules will not be able to remove very effectively. The damage that happens in any system to platelets and leukocytes, that is minimum in this. So the second mechanism is convection. Like how diffusion uses a concentration gradient, convection there is no concentration gradient. There is a movement of solute, along with solute there is a movement of solvent, which is driven by the transmembrane pressure. So there is effectively a pressure gradient which is driving this. So this mechanism we are able to remove large volumes of water. Fluid removal is more with this. And it is the middle-sized molecules which are removed more effectively by convection. So this pressure gradient, that depends on what is first of all the hydrostatic pressure of the blood. The increased blood flow, increased hydrostatic pressure in the blood will help a better clearance. Also the negative pressure in the dialysate compartment, that creates a gradient of pressure with which we can have a clearance. So more effective method for fluid removal is convection. The third mechanism is adsorption. So adsorption is any particle that gets collected or so any molecule that binds to any substance like charcoal, gel, resins, or it gets bound to a membrane. That is called as adsorption. So you remove that particle by adsorption. So this depends on the particle first of all that you are removing, the molecular dimension, the charge, also on the membrane. What is the charge of the membrane, what is the porosity of the membrane, the surface potential, all this will affect your adsorption. So three mechanisms we saw: diffusion, convection and adsorption.
That's wrongly written on the top, that's convection.
This is wrong here. So what is a dialysate? Dialysate is a fluid which will be having a composition of different things, electrolytes, bicarbonate, all these substances, which you are using for diffusion of solutes across a membrane. So that solution we call dialysate. So when we say hemodialysis, hemodialysis means we are making use of the diffusion mechanism for substance transfer. So primarily solute and water both get transported across a semi-permeable membrane into the dialysate. So this, you can have very fast blood flow rates and large volume of blood can be exchanged with this. So you can achieve a very rapid clearance of low molecular weight substances with hemodialysis. Hemofiltration means you are using convection as a mechanism. So this is a slow method but a continuous process. You can remove large volumes of fluid by this method. The solute removal by filtration or sieving. So we'll come to what is sieving. So you have a highly permeable membrane with a large pore size. Middle-sized molecules you can remove more effectively by this method. So when you are removing a large volume of water, large volume of fluid is removed by convection. So you will need to replace that. So you have to use something known as replacement fluid that is used to maintain your fluid balance. So when we were doing hemodialysis diffusion, we were not using any replacement fluid. When you do filtration, you have to use replacement fluid. Okay? So hemodiafiltration means you make use of both the mechanisms. The solute clearance is more effective because you are using diffusion also. Because of the diffusive component, your solute clearance is more effective. Because of ultrafiltration or convection, you are removing volume of water also. So you need to give some replacement as well. So everybody is clear about these three mechanisms and how they work? You want to add something?
So we'll talk about when we go to the dialysis dose and that.
Okay. Yeah, we'll come to that. So this is whenever you are asked about the dialysis dose, what is the dialysis dose that you are doing on your machine? So if that depends on what modality you are using. If you are using a CVVH, CVVH is continuous veno-venous hemofiltration. So if you are using only hemofiltration, then your dialysis dose is your ultrafiltration rate, which is happening, plus the replacement fluid that you are giving. Whether you are giving pre-filter or post-filter, whatever replacement you are giving and ultrafiltration. When you are doing CVVH-DF, so in that case, your dialysis dose is your ultrafiltration rate, your dialysis rate plus your replacement rate. Okay, all three. Dialysate rate, yes. So pre and post dilution means you're giving your replacement either before the filter or you're giving it after the filter. So coming to your question, this is the there are different kinds of fluids actually which are available, solutions that are available for to be used as a dialysate replacement fluid. This is one of the basic this thing that we have. So this Prismocal is the dialysate fluid. So you can see the electrolyte composition on it. Bicarbonate is around 22, the lactate is 3, sodium is 140. This Hemosol is your replacement fluid. So it has same sodium of 140, the potassium is 0 and bicarbonate is 35. This PBP fluid is your citrate fluid which we use for the regional citrate anticoagulation. Okay, so this is the composition of the replacement and this dialysate fluids. So the transmembrane pressure is a hydrostatic pressure gradient which is there across the membrane. So this is the driving force that causes the ultrafiltration. So the sieving coefficient. So every membrane has got a sieving coefficient. That is the ratio of solute which is there in your ultrafiltrate. So the fluid, you move your solution across the membrane, there is an ultrafiltration which happens, right? So the concentration, the ratio of the solute in the ultrafiltrate in comparison to the concentration in the plasma which is being returned back to the patient. So what it means is how much of the solute you have been able to remove by ultrafiltration. So this is the success of any molecule's removal by CRRT. So if the sieving coefficient is 0, it means that the membrane is completely impermeable. If it is 1, it means that it is completely permeable. So there is a range of values that will be there. So this sieving coefficient is determined by many factors. One is the molecular size of the solute, what is the protein binding, what is the charge on the solute and the filter membrane, and the size and number of pores on the membrane. Filtration fraction, whatever this is, whatever volume of plasma you are ultimately removing from the dialyzed blood by ultrafiltration. Okay, so that is the ultrafiltration flow rate divided by your plasma, total plasma flow rate. So whatever is coming into your machine, how much after doing the dialysis process, how much you are able to remove, what fraction of water you are able to remove. So what happens is, if the filtration, ideally you are supposed to have a filtration fraction of less than 20%. So if the filtration fraction goes increasing, then the filter may get clotted. So it increases the hematocrit of the blood in the dialyzer. So clotting will be more. So ideally you're supposed to maintain this particular value of filtration fraction. So how will you keep your filtration fraction low? What can you do to keep the filtration fraction low? Either you have to keep the ultrafiltration flow rate low, or you have to increase the blood flow rate, or you can use a pre-filter replacement fluid which will cause a dilution and your filtration fraction will come down. So this is a circuit diagram for CVVH. So you can see at this end the blood inflow from the patient. There is a access pressure gauze. There is a filter pressure gauze here. Then the blood is flowing through the hemofilter. And there is a replacement fluid over here you can see. So this replacement fluid you're giving either pre-filter or you can give it post-filter. So from the filter the blood is then ultimately going back to the patient. Here there is a deaeration chamber and a air bubble detector and a return pressure gauze. So what is happening in hemofiltration, so you have this filter, you have a membrane, and then you have a effluent that is being removed. There is no dialysate that is being used here because it is hemofiltration and there is convection. So this is the effluent that is coming out. There is a blood leak detector and a effluent pump. So in CVVHD, because you're using hemodialysis, there is a dialysate that is being used in the circuit. So there is a dialysate which is going, the blood is flowing in this direction, the dialysate flow is moving in the other direction. So there is a hemodialysis component here, and then this effluent is going into the effluent bag, and here the blood is being returned to the patient. There is no replacement fluid that is being used here. So when you combine both the techniques, CVVH-DF, there is a replacement fluid as well as there is a dialysate being used in the circuit. Okay. So coming to the CRRT dose, whenever we say what is the CRRT dose, what we mean is the effluent flow rate. So when you do filtration, CVVH, that time your effluent that is coming out, that is your ultrafiltration volume. Whatever ultrafiltration happens, that is coming into your effluent bag. That is your effluent rate. In CVVH-DF, your effluent is the spent dialysate plus the ultrafiltration volume. So ideally when we start CRRT, we keep a effluent flow rate, we set the effluent flow rate at around 25 ml per kg per hour. So that means when you set a rate of 25 ml per kg per hour, you achieve at least 20 ml per kg per hour in a 24-hour time period. If there is severe acidosis, if the pH is very low, there is hyperkalemia, then you need higher effluent rates. So you can go up to 35 to 60 ml per kg per hour till your acidosis gets corrected. If it starts getting partially corrected, then you have to go down on the dose to 25 ml. In CVVH, yeah, your ultrafiltration, no, whatever ultrafiltration volume you are getting, so that will consist of your yes.
TMP, how much
transmembrane pressure will be there on the monitor. You will get a reading of how much is your transmembrane pressure. So ideally, if it starts going above 300 or so, that means that your filter is about to clot. Yes. You want to add something?
About transmembrane pressure, another question. So convection happens due to the pressure difference, as she was saying, right? So what is the pressure difference from inside to outside? There should be a pressure. So she told about a different type of pressure. It is the membrane pressure, the effluent pressure, and return pressure. So transmembrane pressure is the mean of the membrane pressure and the return pressure, x plus y by 2 minus the effluent pressure. Whatever is there, it's the transmembrane pressure. If it is high, more convection. If it is low, less convection. Last slide. Right. Now, previous group were asking about the dose of dialysis or whatever the 20 ml effluent flow rate, in layman term ultrafiltration rate, whatever is this number. How do you calculate that number? Because that's what the trials are doing. Because you go high dose, how do you calculate imagine the whole dialysis process, 3 chambers. Middle chamber is the filter chamber, the exchange by everything happens. Whatever fluid is going from wherever, combine everything, because that's the exchange happening. That's either going into the patient or coming out of the patient, right? So whatever you put pre-filter goes into the patient. You run the dialysate that participates in the exchange, and in the third chamber, whatever you take out is coming out of the patient. So this whole fluid is getting exchanged. So pre-filter replacement, dialysate, and post-filter replacement, plus the ultrafiltrate as removal. All 4 add up to the exchange of the patient. That's where the number is 20, which is a mixture of pre, post, dialysis, ultrafiltrate, all of it.
So for CVVH, it includes ultrafiltrate and replacement.
Everything, whatever is happening, everything. Yeah, there's no dialysis in HF, So you don't add the dialysate. If there is a dialysate,
It's nothing but effluent rate.
yes, that's the number. That's the number. So that doesn't mean that if you are doing a CVVH DF with a effluent rate of 20 is equal to a CVVH of effluent rate of 20, because you are removing different things in different places. Right? So you have to cater your needs accordingly. Any other questions we have?
On this mode, we can do the diffusion. Right. So CVVH, CVH, DM, whatever. The same diffusion we can use.
Yes, so what we do is with the Prisma, we set it as a CVVH DF, because if you set a CVVH, you cannot change it to a DF, but if you set it CVVH DF, you can always downgrade, or just don't run the dialysate, run 10 ml of dialysate and 20 ml of dialysate. So set it as the common and you can do depending on whatever you need. I think the session 2 they will talk about it.
Can we use same dialysate on that thread machine also? We can use
This same dialysis solution on sled machine, can we use that, sir? This dialysate solution which we use for CRRT?
No.
Different solution for dialysis.
We use different. These are bags, the volumes are different. What we use is a generation. We generate like in the house by it's a your RO. So we need a lot of water for that. So it's not continuous. Yeah, so you have a bag and then so we mix it there and the machine mixes it and the machine prepares the analysis. That's a different process.
even depending upon
Yeah, so we can change the parameters there. Like we can change the bicarbonate level, potassium level, calcium level. Here it comes as a bag. You can't change much.
Sorry? How do you decide? Okay. So replacement, so there are three mechanisms as we are told: convection, filtration, dilution, or diffusion. So what do you want to do? If you are taking out fluid, right? So if you are giving to 2000 and if you are taking out 1500, that means you are not making the patient negative. So depending on what you want, right? So whether you want to do only high volume ultrafiltration, you titrate that part, you don't have to touch the dialysis part. So if you want to make the patient more negative, replace less or take out more out of those two, right? So in that way, if you want to dialyze the patient more, hyperkalemic acidemia, IUREA, those cases, then in that case you have to do the dialysis more. You don't have to replace it. Depending on the need, you will titrate.
The circuit has to be the circuit has to change every day or
No. There is set parameter on the machine. It says this much of hours are left. It will tell you. Or if it clogs or the filter tracks, whatever happens. Right? Depending on unit protocol again, I don't know how much hours we can.
Yeah, so we let it run till the machine starts showing that.
So at certain units where money is not the issue, then there is an expiry time for that. So it usually won't last beyond 72 hours.
since we increase the capacity on intermittent dialysis, we increase blood flow. Like in here, by increasing dialysis, can
So here, only thing that you can increase is the effluent dose. That's the only variable by which you will improve the dose, you will get more efficiency. Anyway, it's continuous and slow. So you have to, you cannot match hemodialysis. Hemodialysis is quick. In 2 hours, you will be, potassium you get reduced to from 7 to 2. Here it's very slow. So the advantage is like a slow and continuous.
So just to improve efficacy, you have to increase the dialysis dose.
So you can, you start with 25 ml per kg per hour and then can go up to like whatever you want. But then there are so many studies showing that it doesn't matter. Whether high dose, low dose, there is no change in the outcome.
Hypercatabolic patients.
Yeah, so there you can dial in with more effluent dose to get, so obviously like all these patients with cardiogenic shock, septic shock, multiple amyloid, they will be acidotic, they will be on lactate side. So still you want to augment the, the clearance of these potassium and only thing the fluid removal is slow, so the tolerability is better. if you can afford it, definitely it's a very good modality for certain sled patients. As somebody was saying in the afternoon, like we can run sled for 24 hours, so we do that.
So I was like CVHD hemodialysis. Can we increase the dialysate rate to increase the effluent rate and by that increasing the dose?
No, these machines you cannot increase it. You go beyond 150 and all. You have to run it at like 100 to 150. Yeah, so that's the effluent dose. The replacement fluid rate is calculated in the effluent.
Yes. By doing that, we can
increase the efficiency.
If you increase the dialysate rate, you have to approximately increase your blood flow because it has to be more than 25 times the dialysate rate, and that will cause your filter pressures to be up.
So mainly 2-3 things you have to take out. What is filtration fraction? What is the dialysis dose? What are the mechanism that is involved? And you take that knowledge to that other station, and they will tell you how it is.
ते record करतात. Okay. Good afternoon all. I am Dr. Dipali Patil. I am consultant in transfusion medicine. So today we will be talking about therapeutic plasma exchange and its clinical implications or the clinical aspects. So therapeutic plasma, excuse me, can anyone give this? So therapeutic plasma exchange, or I would say the any kind of a removal or the bloodletting, it has been happening from the beginning of our 28th century. For many ages, plasma exchange or the any metabolite from the blood removal has been happening manually. Then later the technology has developed so that we can nowadays do it with the automated procedure where the whatever the component we want to remove from the blood, it we can remove and we can replace it with the desired product. Next slide. So today here we will be discussing about the apheresis. As I said, there is a American Society of Apheresis. This is the body which is dedicated to the work of apheresis depending upon the years of research, and it has categorized the disorders where we do apheresis. Not only the plasma exchange by apheresis, any kind of apheresis like exchange of a red blood cell or the plasma. It can these disorder can be categorized in the 4 categories. One is first line therapy where the plasma exchange can be or any kind of apheresis can be done as a treatment or the primary treatment modality or in conjunction with the medical treatment. Second is second line therapy. Third category is role not established or the decision making should be individualized case to case depending upon the patient situation, and there is no evidence of a benefit. There is a 4 category. Yes.
How should put it there actually, CRRT. How then again they will exchange. Then again you will exchange.
Your patient is going to be tied up to that.
Okay. So this one is level of evidences, I would say, depending upon which again the disorders are categorized and we can go ahead with the apheresis as a treatment modality or not is decided. So grade 1A defines as based upon the literature, and there is a very high quality of the evidence that therapeutic apheresis works well in these conditions. Grade 1B defines where the strong recommendation is there but the moderate quality evidence is there, and it goes on till grade 2C. So I would say in grade 1A, 1B and 2A, most commonly these are the category of the disorders where therapeutic apheresis is most commonly being used, whereas in the grade 1C or the 2B, it depends upon the condition or at the discretion of the stakeholders of the team involved. It is decided whether therapeutic apheresis should be done or not. Next. This is a table from the again ASFA journal where it looks how it looks like the categorization of the disorders. The whole chart of the 157 disorder is alphabetically mentioned, and all the modalities are divided depending upon its category and the grade, and their further discussion is there in the journal. So now coming to the therapeutic plasma exchange.
what is a therapeutic plasma exchange? For the treatment of any disorder where we want to remove the harmful material from the patient's plasma, that harmful plasma is been removed and it is replaced by the plasma from healthy donor or some other exchange fluid. So what are the goals of the TPE therapy? Either we want to remove some antibody like in autoantibody, or we want to remove any protein which is harmful like in cases of hyperviscosity or the immune complexes, or if we want to remove non-antibody toxin like LDL, or we want to remove plasma factors as in cases of TTP, or we want to go ahead in for a desensitization like in cases of organ transplant, where we do remove the anti-A, anti-B titer in the patient. So what are the important factors involved in TPE? So yes, what machine or what technique we should go ahead, what are the effects of TPE on the patient's blood constitution, what venous access, anticoagulation, replacement fluid, and what are the patient's clinical and the laboratory parameters. So these are the important factors we have to take into the consideration before going ahead with the procedure. So there are, as I mentioned, manual method, it's obsolete now. Now we have come to the automated procedures where the plasma exchange can be done with the membrane filtration or the centrifugal apheresis. Membrane filtration can work along with the plasma adsorption or the immunoadsorption. In the centrifugal separation, we do the plasma exchange or the double filtration apheresis. These we will explain in detail in the further slides. So from here I will ask Mahesh to take over. He is our application experts from the Fresenius Kabai, where he will explain us the different methods of the plasma separation.
Okay, good afternoon. As mentioned in the slide, there are two type of kits available for centrifugation. Either it is discontinuous or continuous flow. And filtration, of course, it's there. So here you can see in this graph, the patient is there, blood is drawn out. Now this is shown as a blood pump. It goes into the centrifuge. This is plasma is coming out and going into the waste. Simultaneously, when the blood is returning back, replacement fluid which can be balanced as 100%. That means whatever you are removing in the waste, that the same amount you are adding back as a replacement fluid, and that blood goes through the wormer to the patient. Now over here, since the blood should not get clotted, we are using an anticoagulant. It can create some symptoms to the patient, and to minimize those symptoms, we are using calcium. Okay.
So going ahead, so as we explained, this is a plasma exchange circuit. It was as explained in the prior slide. Here you can see double filtration plasma pheresis. So here what is happening, from blood pump is coming into the filter. It is getting separated, the plasma is getting separated, and it is getting added, additional filter is put across that plasma's flow, so that if we want to remove specific metabolite from the plasma, it helps us to remove it with the help of a filter. Next slide. Next. Okay. So here are few examples. I would say there is it's a long list, but here are some commonly used examples where we use the plasma exchange along with the modification of the plasma exchange. So double filtration plasma apheresis, that means we are adding one more filter to the plasma exchange circuit, which is used for these autoimmune disorders or ABO incompatible or the HLA incompatible transplant. There are some columns made of one polymer like PA or the polyclonal immunoglobulin columns. These are used for the disorders like factor 8 inhibitors, factor 9 inhibitors, SLE, AIHA or the dilated cardiomyopathy. Rheopheresis is the procedure where the high molecular weight molecules are being separated. It is used in cases like ARMD, Repsums or the critical limb ischemia. Glycosob is very commonly used column or the adsorption column. It has the specific A antigen substance or B antigen substance. These are the carbohydrate molecules which are covered on these columns, and the plasma flows through these filters, and we can reduce the anti-A, anti-B titer very effectively. Also for LDL apheresis, there are separate filters which are attached in the circuit, and we can use it for the treatment of a familial hypercholesterolemia. Now coming to the clinical consideration, so what all factors we should be looking into the first and foremost is patient's body weight, because it helps us to determine how much is the blood volume of the patient and how much is the plasma volume of the patient, so that we can take the decision the volume to be exchanged. So for that calculation we have these very commonly used formulas. So first one is very simple it's not actually the formula, but it's a very rough indication as per the patient's gender and the build of the body. It gives us the ml per kg blood volume of the patient. Another one is the Nedler's formula, which uses patient's height and weight for calculation of the total blood volume. So here is next is how much fraction we want to remove. So as we have seen in the previous studies or a lot of literature, it says that by the time we exchange 1.5 time of a plasma volume, maximum amount of the metabolite or the toxin or the waste has been removed. So in one session, even if we go for a 1.5 times, it is good enough. Beyond that, the separation component does not rise as in comparison with the plasma we are processing. So the by the time we are processing 1.5 time of a plasma volume, we can very well remove almost 80% of the metabolite. Now, how does it work for the exchange? Many times you all must have seen, if today we have done the plasma exchange, next today after the procedure the values do come down, the desired whatever the, like for example, in hyperbilirubinemia or the liver failure we are doing the plasma exchange, bilirubin comes down, but then the next day again it increases. Obviously it is because your liver is again, your body is generating more of a bilirubin, but again sometimes when I want to remove the immunoglobulins, today the immunoglobulin levels have come down, but tomorrow again it is increasing. Why is it increasing? Because from the extra vascular space, it has shifted into the intravascular space. So for that purpose we need sequential procedures, at least 3 to 5 procedures where we can see the effective removal of the particular immunoglobulin in the autoimmune disorders. Coming to the vascular access, for the therapeutic plasma exchange by apheresis, peripheral access or the central access both can work, but if we have to go ahead with the multiple procedures, central venous access is preferred over the peripheral access, because it is not very much practical or feasible to go ahead with the peripheral one. In the central venous access, most commonly used or preferred is the IJV access. Next. Anticoagulation used in the apheresis is ACD as compared to the heparin, which is used in the membrane filtration or the dialysis procedures you must have seen. So there is some differences between the ACD and the heparin. Many a times what heparin does the systemic anticoagulation. Also it can cause a heparin induced thrombocytopenia. Also to reduce its effect we have to neutralize it at the end of the procedure. As compared to that, the sodium citrate is kind of a safer, because it does not require any kind of a neutralization towards or after the end of the procedure. Also a lot of citrate is very well metabolized by our liver, so its effect is neutralized by itself only. And to counter any side effects of the citrate, we give the calcium infusions throughout the procedure as a prophylactic measure. So there are very few adverse events we see with the sodium citrate. Coming to the blood prime, why do we use blood prime and what is it? This circuit or the kit we use for the plasmapheresis, it has the ECV, that is extracorporeal volume of around 180 ml. So this much is the blood volume which remains outside the body at any given point of a time during the procedure. So if someone is there with a low blood volume or a low body weight, like kids are there or the small built females are there, or sometimes the hemoglobin is too low, their red cell loss we can not tolerate. In those cases we do prime the kit with the Paxil, so that the blood loss will not be there and procedure can be very well tolerated by the patients. In this case, whatever the blood we have used for the priming, at the end of the procedure we can take a decision whether we want to give it back to patient or not. If we are worried about the hypervolemia issues, then we will not give it back to the patient. But also if there is no major issue of the hypervolemia and the patient's hemoglobin is very less or the hematocrit is low, this blood can be reinfused to the patient. Now coming to the replacement fluid. what is the fluid of choice or what should we use for the replacement. So the most commonly used fluids are FFPs, albumin, and sometimes in the combination of that little amount of a saline we use as the replacement fluid. So these all replacement fluid have their, next slide. These all replacement fluids have their own pros and cons, and depending upon the patient's condition also we decide what should we use. So if we talk about FFPs, FFPs do have the benefit of that it replaces all the coagulation factor, it is easily available and it is inexpensive as compared to the albumin. But again it has the risk of infectious disease transmission, it has the risk of a transfusion reaction like allergic reactions, urticaria, fever. Also it can cause the citrate reactions higher, because in the blood also when we collect the blood and separate the plasma there is a acid citrate dextrose which is used as an anticoagulant. So next, coming to the CPP, CPP is cryopoor plasma. This does not have the good amount of a coagulation factor because the factor VIII, fibrinogen, von Willebrand factor we have removed, and the remaining whatever is there CPP. But this is a choice of a fluid for exchange in cases of TTP exclusively. Otherwise CPP is not usually used. Single donor plasma, again it has a similar benefits or the advantage or disadvantage as like of a FFP, but again single donor plasma not easily available and it is expensive. Next. Solvent detergent plasma can rule out the problem of the infectious disorder, but again other issues like the allergic reactions or the citrate reactions do remain with the solvent detergent plasma, and again not easily available and the expensive product. 5% albumin, as I said, yes, it is help us to avoid any viral infections. It will help us to reduce the citrate reactions or any allergic reaction happening because of the plasma, but it does not replace the coagulation factors. So and again also it is expensive as compared to the FFP. Hetastarch, it is very rarely used and it does not help us to give any proteins, give any coagulation factor. So next. So how do we go? Once the patient request for the plasma exchange is received, we do the patient assessment. We do take into the consideration of the patient's physical appearance, weight and the height. What is diagnosis? Lab parameters like CBC, coagulation factor, hematocrit, LDH and the electrolyte is important lab parameters we have to see. Also we have to check whether the indication or the diagnosis for which the plasmapheresis is being done, is it fitting into which category? Is it category 1 or the 2? That way we take a decision, should we go ahead for the plasma exchange or not. So these things we have already discussed: vascular access, peripheral or the central access. Anticoagulant preferred is the citrate. Priming is done with usually with the saline, sometimes with the blood if the ECV is more than 10 to 15% of the blood volume of the patient. Replacement fluid most commonly used is the 5% albumin and the FFPs. Coming to the complications, most commonly seen complications are citrate reactions, hypovolemia, anaphylactoid reactions. These are the most common. The cardiac event or the pulmonary event are the very, very rare. I would say I haven't even seen those in so many years while we have done the plasma exchanges. So the citrate reactions, what are the citrate reactions most commonly seen? Perioral paresthesia, tingling around the mouth, or patient might get the cramps, or else patient might get sometimes the tetany. But these are too rare and these are already tackled by the prophylactic dose of the calcium infusion. For calcium infusion, choice of calcium is the calcium gluconate vial. But sometimes if the patient is in failure, we do use liver failure, we can also use the calcium chloride as the replacement. Next. So there is just few studies quoting the comparison between the centrifugal TPE and the membrane TPE. So you could see that the centrifugal TPE works on the basis of, centrifugal TPE uses the citrate, membrane TPE uses the heparin. It can work with a very low blood flow rate where the membrane filtration requires one particular amount of the blood flow rate for the machine to work fine. We can do the apheresis with the central line or the peripheral line. For the membrane filtration, you need AV fistulas or the central line access. With a low amount of a plasma volume exchange, we can have the greater efficacy or the greater removal of the metabolite in the centrifugal TPE. There are further studies we have quoted which show the better efficacy and the less adverse event as compared to the membrane filtration. Go ahead. So, next class. So yes, TTP can be done for multiple disorders, or rather it is a choice of choice for multiple disorders like autoimmune disorders or the ABO incompatible solid organ transplant, where the efficacy is seen better and we can get the good results as comparable or the better as their counter medical modalities or the treatment modalities. Also, TP has revolutionized the organ sensitization protocol. We can very well break the ABO incompatible barriers for the solid organ transplant nowadays with the help of TPE. And TPE should not be used as a last resort when everything has failed. We should try to use it in a timely manner where we can get its better results and we can use it effectively. Any questions? Most common indications, autoimmune disorders like myasthenia gravis, or the GBS is there, or the chronic and the acute demyelinating syndrome. These are the most common. How many?
Procedures.
Procedures usually 3 to 5. Most commonly, most of the time we have seen the good results by the end of the third procedure. Sometimes it might go to the 4 or 5, but most commonly in the 3 sittings we get the good results. So that's why the subsequent ones. And again it usually is done in the conjunction with the immunosuppression. Many a times what happens, immunosuppression may work till some extent or something. If we use both the modality together, we can see the early results in the patients. Most commonly alternately, sometimes daily can also be done. Depending upon the patient's clinical lab parameters or the patient condition. Usually what happens, we need to see the effect of the procedure and the tolerance of the patient. So both the things, like for example, after one procedure, if the patient is okay, but the effect has not come so much, or the lab parameters have raised again a lot, then we can do it on the subsequent day also. In one sitting, most commonly 1.5. High volume plasma exchanges are most commonly done for the liver failure cases, but otherwise for the autoimmune disorders or for the desensitization or for the ABO incompatible transplant, 1.5 volume or max 2. But 1.5 is a good enough.
In high performance?
Sorry?
In high performance?
3 to 4 volumes. High volume plasma exchanges, 3 to 4 volumes. Sorry? Yes, yes. Effectively. Recently we had a case of a 6-year-old boy he came with a liver failure. On USG it was seen it is having the chronic changes also. So he was diagnosed as a Wilson disease with acute and chronic liver failure. So he was a candidate for the liver transplant. So but till the time the procedure and the pre-preparation of the liver transplant was done, we did the 3 sittings of the therapeutic plasma exchange in this kid, and it gave the very good window for the workup or for the procedure, because patient came in a very critical situation, and then by the time the donor was ready, matching and funding, everything came into the picture. It was a duration of around 5 to 7 days, and in between we did the plasma exchange, and patient survived well with the after with the liver transplant.
How much fluid do we generally exchange depending upon the weight?
It is so basically for earlier batches also I gave the example of, for example, if some individual is there with a 5 liters of a total blood volume, so it's a round figure because I am saying, and is having 40% hematocrit, so 60% is a plasma, so 3 liters of a plasma is a 1 plasma volume. You go for 1.5 plasma volume is a 4.5 liters. So in one session you remove 4.5 liters and replace it with the 4.5. So if at all, if we are worried about the hypervolemia or we do not want to give the fluid overload to the patient, in those cases we can even keep the 10 to 20% as a deficit also. Less, yes. Any questions?
bacterial shocks discontinued?
Yes. Yes, yes, yes. It can be used.
So we have some filter membranes also available in the solution which can remove endotoxins molecules.
Yes.
So it is superior to that.
So see what happens if when you see, one thing is that when you add any particular filter or the adsorption column to both the machines, they might give you the comparable results. But again, the volume you have to process for the similar results, or there may be additional adverse events happening along with that procedure. Though there it makes a difference actually. And again, depending upon the patient's clinical condition, it really helps us to overcome those barriers.
If you are doing a then you use this. If you are using regional cyclone, then you are.
What is the cost of
Procedure? One procedure for us it is around 12 to 13,000, excluding the cost of FFPs or the replacement fluid we are using. Because the kit we are using over here, it is one-time use kit. It cannot be reused. Like today, if we have used one, tomorrow we'll have to install new or the. But again, the one procedure is good enough for the any longer hours which you are using on the different other modality. Yes.
What is the role of the filter?
This filter. So plasma exchange, yes. But when we want to remove any specific molecule, or we have identified, for example, I usually give the example of the glycosop. I want to remove anti-A from the B individual or the O individual where I want to do the organ transplant. So there, if we are having this adsorption column is having this specific receptor for the anti-A. Means it has the A antigen substance like material, the carbohydrates are there. So it will absorb all the anti-A. So it will give us the better efficacy in the one sitting only. So that's why the adsorption columns. So basically adsorption columns are used in conjunction with the exchange procedure to get the better results. Otherwise the plasma exchange, yes, it works. For complications, as I said, most commonly the adverse event whichever are there, either they are related to the hypovolemia or the hypocalcemia, the electrolyte imbalance, but it is being taken care of. Contraindications, as if not, because we can even do it with a very low hematocrit also. Low platelet count, as good as a 20,000 or 30,000, we can go ahead with the plasma exchange procedure.
This station is about learning about two extracorporeal circuits. Okay? One is an ECMO circuit, the other is a CRRT circuit. How many of you have managed patients on ECMO here? Raise your hands. One. Okay, sure. How many of you have seen patients on ECMO? 3, 4, 5. How many of you have not seen a patient on ECMO? 1. No? No. Just one. Okay. So, nothing to worry. I mean, essentially that I'd want to know this so that I explain it better. Okay? So, that's one thing. So, you got to understand one thing, that when you add CRRT and ECMO, you're adding two extracorporeal circuits. Okay? Now, let us forget that ECMO is there as an entity. Let's go back, say, 10 years when there was no ECMO here. Okay? In your critically ill patient, what would be your indications for starting on ECMO? What will be your indications for CRRT? Sorry, not ECMO. You don't have ECMO, right? CRRT? I'm asking you indications for CRRT in your critically ill patient. Sorry. Wait. I think it's getting. You said refractory acidosis. What is your definition of refractory acidosis? Pick a number.
pH less than 7.2, which is causing cardiovascular instability.
Okay, so he's going for a pH less than 7.2 to start CRRT. Any other indication? Refractory hyperkalemia defined as? Fair enough. What is your potassium level? I'm a bedside nurse. So you tell me what levels do you want me to start CRRT? Above 6. So she wants to start CRRT above 6 in a patient who has hyperkalemia, more than 6. Okay, fair enough. Any other indication? Wait a second. Head
injury, liver in which disequilibrium is normal, dialysis will cause increase in the edema and disequilibrium.
No. My question is, when will you start CRRT in any patient in your ICU? Volume overload. What is volume overload? Lot of fluid balance. When would you start that? When it becomes clinically evident. So saturations are going down, oxygen requirements are going up. So you have that endpoint. Any other indication? You have left the most important toxins like? Dialysable toxins. Take aluminium phosphide. Am I right? So those things can be amenable to dialysis. Any other indications? I know you said that. Any other important indication that you have missed?
Hemodynamic instability.
You don't need dialysis for hemodynamic instability. You need inotropes.
Patients with inotropic supports and requiring RRT.
What is the indication? When? That is exactly what I'm asking here. Increase uremia. Fair enough. What is your definition of uremia? Urea more than? Okay. Any cutoff level? 150. Okay. Fair enough. So you all have some institutional criteria whereby you start CRRT. That's the point I'm trying to make. Okay. Now let's say the patient is currently in present and is on ECMO. What would be your indications for CRRT in this patient? Would it be any different from what you told me just now? It's just the same. So that is the first and foremost point you need to learn. Indications for CRRT on ECMO are the same as that in any critically ill patient. Right? By virtue of being on ECMO, he doesn't have two horns or special indication for CRRT. No. Right? So his indications for CRRT are exactly the same medical reasons you would otherwise start CRRT. Okay? Now, let us say you have a patient on ECMO, you're going to start CRRT. What are the things or what are your unique challenges going to be? These are two extracorporeal circuits, right? So what would you be worried about? Anticoagulation. But then you are anyway going to use heparin for your access will be one thing. So there will be technical problems. Okay. Now before we talk about technical problems, any other problems that you anticipate?
Regulate the flow.
Anything else? No, those things are always there. Drugs. Am I right? Drugs is one important thing because let us say your patient goes on ECMO for severe pneumonia. What would the patient need? Antibiotics. What is the usual antibiotic you give for a patient on ECMO who has severe pneumonia? Carbapenems. Sometimes you add azithromycin, vancomycin, whatever, depending upon your local milieu, but carbapenems are usually given, right? Now what happens to carbapenem on two extracorporeal circuits? More than dialysis? Yes, it gets dialyzed. The volume of distribution is more now. And a lot of this meropenem also gets adsorbed onto the circuit. Okay? So what happens? Efficacy, bioavailability is down. So essentially, whatever antibiotic you are giving is subtherapeutic for this patient. Am I right? So it's not achieving your target. That means this patient is not going to get rid of the infection very soon. Right? So that is one important aspect that you would worry about. How do you treat that? Or how would you look into that? Sorry? Frequent dosing. Okay? So the best way to do that would be to do continuous infusion. But if you do continuous infusion, what will happen? So you wouldn't know whether the patient gets toxicity out of it. Am I right? So what you'll have to do a TDM, therapeutic drug monitoring. How many of you monitor meropenem levels in your center? None of you. But you still talk about it, isn't it? So this TDM is good only for conferences. By the bedside? So, I mean, sometimes you monitor. You are lucky, but majority are unlucky. Am I right? Including me. Right? So what happens? By the bedside, we do some kind of jugaad. What do you do? How do you titrate? You need to give them the proper dose, right? Sorry, what was that? TK, but then how do you know your bug is getting killed? So, it will be a bit too late. Okay, right. The only way to answer that question is look at what people who did TDM eventually did to the dose. Right? People who monitored TDM, what did they do with the eventual dose of meropenem? What did they do? They concluded that doing TDM on meropenem on ECMO is best administered as an extended infusion. Okay? Most of the time, you achieve your MIC targets. Okay? So, when you're going to give antibiotics, especially, carbapenems, you don't have TDM, don't worry, give it as an extended infusion. Ideally as a continuous infusion, but then you wouldn't be able to do that. Okay? What is the other important drug that's going to be adsorbed on the circuit and you're going to have problems when the patient is on ECMO and RRT? No, I'm not going to antibiotics. Antibiotics, I wanted to discuss only meropenem. Anything else? Any other class of drugs? Inotropes, no. How often do you give anticonvulsants on ECMO? You don't usually. Sedatives, right? Patient sedatives. Whatever sedatives you give, midazolam, propofol, fentanyl, sufentanil, whatever you're going to give, it's going to get adsorbed onto the circuit. But the advantage of the sedative drug is you can always titrate it to clinical endpoint. As long as the patient is sleepy, groggy, you don't have to worry. The same thing cannot be said about meropenem. Am I right? So you can clearly see the big difference when you're going to combine extracorporeal circuits. Am I right? So that is one major problem you're going to have when you're going to combine extracorporeal circuits. What is the third important problem that you're going to have when you have two extracorporeal circuits? Fantastic. It's going to cause complications. The complication rate from the ECMO circuit plus the complication rate from the dialysis circuit. Most commonly, you would find them getting thrombocytopenic. Once they get thrombocytopenic, they start bleeding from their cannula sites. Then you give blood products to control it, you stop heparin, and that's a vicious cycle. Right? So the decision to add in an extracorporeal circuit is not easy. Even though I said the indications are the same as that of any critically ill patient, you'll have to consider, or at least you should be prepared for such sequelae or complications. Am I right? So now we come to the next problem that you highlighted, the technical issues. How am I going to integrate this big machine into this machine? Right? How will I do that? So I can't hear you. Separate line. She's very safe. She knows. She's smart. So she says, I'll put in a separate dialysis catheter. I'll do dialysis separately. I'll do ECMO separately. Chalo, I think that is a very valid point or very valid way of doing it. Now, I'm telling you, this patient is already anticoagulated. You can't put in a vascat because he's going to bleed. Okay? The patient unfortunately did not have AKI before he went on ECMO. AKI happened after he went on ECMO. Okay? Now, you are unable to put in a separate line. How are you going to integrate this circuit into this circuit? Okay, before I start talking about all these jargons, for people who don't understand ECMO, I'll simplify it so that now you will understand how you integrate the circuit better. Okay? So when you have a patient on ECMO, you have two big cannulas. Okay? One cannula drains blood. Now that drainage cannula has a lot of negative pressure in it. Okay? Now that cannula gets connected to this blue limb of the circuit. This blue limb of the circuit is negative pressure side of the ECMO circuit. Okay? Because that is one thing. If you look at that picture, It's the part of the circuit that is, it's a part of the circuit before the pump. Okay? Now this blood from the patient goes to the pump through a negative pressure line. The pump actually spins it and pushes blood into the oxygenator. So post pump, this is a positive pressure line. Okay? This side of the ECMO circuit, even beyond the oxygenator, is positive pressure. Okay? So this is the simple concept of line pressures in the ECMO circuit. Now, by virtue of its configuration, you can integrate this circuit at various points. Okay? Now let us find out where you're going to do it and how you're going to do it. What is the simplest way of integrating it? One simplest way, when I say that, I mean, this is a big machine. So easiest way of doing it is, just take this filter out, connect it directly to the ECMO circuit. You connect it here and then, run it through the filter back to the patient. Why?
Flow rates and everything we cannot regulate.
That is a problem. You cannot modulate your flow rates, you cannot modulate your solute clearance, and such a configuration is obsolete in a critically ill patient. Even though it is feasible, probably you wouldn't do that. You don't want to do that. Am I right? So then what is your option then? What else can you do? Come, you come over. Come. I'm going to give you the dialysis circuit. I'm going to give you the ECMO circuit. See where you can connect. Come. I'll help you. Come. I'm here to help. So just to explain to you, this is the negative pressure line of the ECMO circuit. Okay? This is the positive pressure line of the ECMO circuit. That is post pump. The red one is the post pump. And this is the access line to the dialysis, return line from the dialysis machine. Now you have to connect this. Where do you want to connect this? Hold it. Yeah. Do you know the circuit there? Where do you think you should connect each line? Go ahead. There is a big circuit. You don't have to worry because any connection is possible here, and there is nothing wrong, nothing right about this. It's just that some things have some disadvantages, which I will highlight when you connect. All right? Now tell me where I'm going to do it. Okay, I'll give you a clue. Okay? So what I'm going to do is, I'm going to help him with a connector. Okay? I'm going to put in a connector onto this blue circuit, blue line, and I'll tell him, okay, chalo, I'll connect this for you. Okay? So blood flow to the dialysis goes from this blue line. Okay? Where do you want to return it?
To the oxygenator.
Before or after?
After.
After the oxygenator. Chalo. So after the oxygenator, you give it. So he's now connected this from before the pump, pre-pump, access, and his return is post oxygenator. Pre-oxygenator या post oxygenator? Pre-oxygenator. ठीक है.
Return to pre-oxygenator and access from post-oxygenator.
This is post-oxygenator. This is pre-oxygenator. No, blue one. Okay, so he's connected it pre-oxygenator. What are you all happy with this connection? He's nodding his head. You're not happy with the connection. Anybody else? No clue? Recirculation will always happen because blood is being taken out of the ECMO circuit.
Otherwise, this is good.
Any specific problem with this particular configuration? So what happens when you connect something to the negative side of the circuit? So what happens is, when you have a crack in this, or let us say you are changing the dialysis circuit and you're removing this, as soon as you remove this, blood will not flow out, it will suck air. Okay? So any connection to this part of the circuit, air will be introduced into the ECMO circuit, which you don't want. Because the more the air that goes into the circuit, it will stop the pump and ECMO will stop. Then there is no point doing dialysis at all. Patient will, you need CPR, right? Before CRRT, right? So essentially, the golden rule or the teaching here is the understanding of the first point you need to learn when you start your technical connections is never ever connect anything to the negative pressure lines of the circuit, right? So that negative pressure line, leave it free. Don't attempt anything. Okay, go back. Thanks. Why don't you come over? So I've already said no to this connection. Now where are you going to connect?
Pre-oxygenation from pump.
So you are going to connect it
Post-pump. Pre-oxygenation.
Post-pump pre-oxygenator. ठीक है.
That will be written. That should be written, and post-oxygenator should be the access.
Chalo. He says, okay, fine. You've given me a configuration. Anybody with a different configuration?
Post-pump pre-oxygenator.
Post-pump pre-oxygenator. Chalo, I will do that first. Okay, you go back. Yeah, thanks. So I'm going to do post-pump and pre-oxygenator. Okay? So I'm going to take blood post-pump, pre-oxygenator, and where do you want to return? Post-oxygenator. Chalo, you're going to return post-oxygenator. Anybody has any concerns about this configuration? Wait a second. We'll go through that. There's nothing wrong with the configuration. So what you have done now is, you have now taking blood from this part, going through the CRRT circuit and giving it part to this part. Okay? Post-oxygenator. Pre-oxygenator, I am taking blood to the dialysis machine. And the return from the dialysis is post-oxygenator. You want to do pre-oxygenator. Chalo. So, where is that? Where's the person? Okay, that's fine. You don't have a port pre-oxygenator. We only have a port post-oxygenator for now. Okay? We'll come to that configuration. But how many of you are comfortable with this, or do you think you're going to have challenges with this configuration?
You already told in your class where to put.
No, I know I have told you where to put, but I'm sure you didn't read my other slides where I showed the disadvantages of each configuration. I mean, you cannot add in another port, na? It's already primed, right? So they want a pre-oxygenator, both post-pump pre-oxygenator, return and access. So, chalo, she has already told the answer. Right now, she cannot do it. Now tell me how we are going to deal with this. What is the problem with this connection? Okay. No, recirculation, it will always happen. Don't worry about the recirculation. It's only a small fraction. Okay? Now, as soon as you do this, this will go alarming, saying high access pressure. High access pressure. Why does it say high access pressure? How will you prevent it? Post-pump positive pressure is there, because I told you that. Okay, so that is why it's showing high positive pressure. So what will you do with your connection? Pre-pump you cannot do, right? That's what I said. You never touch that part. Post-pump, pre-oxygenator, very high pressure, right? Because it's immediately after the pump. Where do you position it now? So he wants to do post-oxygenator. So he wants to reverse this connection. He wants to do post-oxygenator and return it. Why? What's the rationale for that? No, you're always talking about air bubbles first. Clots or air bubbles. But there is an important reason why you should do it this way. Another important reason. I said that in my lecture.
If there are any clots that...
No, that only that thing has gone into the head. The other part hasn't. Chalo. Okay, we'll come back to the basics, okay? This is post-pump, right? This line is totally post-pump. Post-pump is positive pressure. oxygenator has resistance. Okay? It will offer resistance. So what will happen to the positive pressure post-oxygenator? It will come down further, which means you will not have alarms here. So that is one of the important reasons why you take it post-oxygenator and then give it back pre-oxygenator. The other reason why you give it pre-oxygenator is the one which you have all registered, that is no clots, no air emboli. So, or whatever clots, whatever air emboli, they get trapped in the oxygenator. Am I right? So that is why you use that configuration. Am I right? Okay, fine. Let us now talk about, no, before that, any questions so far?
5 minutes more. 5 minutes more.
So it is going to be pre-oxygenator. What will happen? It's directly from the pump. Access pressure will be high. This will keep on alarming. Chalo, we'll talk about anticoagulation because you spoke about it. We'll talk about anticoagulation. Okay. So you said we'll use heparin because it can be common to both circuits. Let's say your patient has HITS, heparin-induced thrombocytopenia. What are you going to do? Sorry, I can't hear you. Loud. No anticoagulation. Chalo, that is one option. You can run both the extracorporeal circuits with no anticoagulation. What is the immediate impact of that? Thrombosis where? More than the ECMO circuit. You will keep changing your ARRT filter quite often. Okay? It may not be cost effective. He's trying to be smart. Okay, so he's trying to say, chalo, this will not clot. I'll leave that. I will do a regional citrate coagulation, anticoagulation here. Is that feasible? It is feasible. Okay. Any other ways of doing it? Let's say you start getting clots in the ECMO circuit also now. Bivalirudin. Okay. So you can give bivalirudin. What's the dose of bivalirudin? And how effective is bivalirudin on ECMO and RRT? It's good that you all know the answer, but you don't know why you should use it, how you should use it. I think that is going to be more important by the bedside. Okay? Evidence for bivalirudin as an alternative? We talk about it, isn't it? So bivalirudin is a good alternative, right? Thanks. Bivalirudin is a good alternative. The only issue with bivalirudin is it's not been validated in a lot of studies. It's good with ECMO, it's better than heparin when you use it on ECMO. Limited studies on RRT to say bivalirudin works good or better or good for filter life. But it's a good alternative. What is that? That also you can use. You can use all your heparin analogs and everything you can use, whatever is available. Bivalirudin is commonly available. The other one they have tried is agarotropin. You can. Fondaparinux, okay, fair enough. The only issue is HITS. It's a heparin analog. It's okay, fine, fair enough. It's been described as an alternative to heparin in HITS. I agree with you because the mechanism of action is slightly different. But overall, you tend to avoid heparin analogs in this. Any other problems that you expect? Or it?
There won't be any ending to the discussion, but there are some information I want to share. Anyone who has missed the setup of ISD and SLADE there, in table number with Dr. Valentin Lobo sir. Anybody who has not attended, please, we should come there. They are waiting there. They should be there only because we are closing and we are going ahead with the Vexus protocol. So this is the last session. Whoever are not attended, go there. Closing for a tea break 10 minutes, then we will be having the Vexus protocol session.
Chalo, that means you have to move. Thank you. Huh? It's the same problem, no? The heparin in AIDS it will be not be.
So how was the workshop? So we require all of your feedback to improve the the quality or anything you want to add for this program. We will share all the scanner code and QR code. You have to just scan it and you have to give your feedback. You have already sent the link? Yeah, so Dr. Sanath has already sent the link in the WhatsApp group. You have to just scan that code and send the feedback to us. Because next time it will help us to improvise our program more and more. So in this session, basically we are going to discuss regarding the vexus. So I request Dr. Kedar Toraskar sir. Sir is working as an intensivist, critical care consultant and physician, chest physician at Oakard Hospital, Mumbai, and nobody can teach better than him regarding the ultrasound of the lung and vexus. So I can say him is one of the pioneer in vexus, and as vexus is the one of the newer modalities which is coming into ICU, just like ultrasound 5 years back or 10 years back. So the newer generation intensivist has to be very, very thorough with the vexus, what is vexus and how to diagnose different conditions with the vexus. So this will be a session where first there will be a lecture followed by the demonstration on a live patient or live subject, I can say. Whatever the doubt or questions we can discuss, and this is the last session we have, or I can say the last session in the workshop. So I welcome Dr. Kedar Toraskar sir.
Thanks, Gunadhar. I would like to thank the entire organizing team and Apollo Hospital for this invitation. And I think all of you are tired after a marathon session of the workstations as well as didactic lectures. And I hope that I will keep you awake for the next 30 minutes or 40 minutes or so. So, Nephro focus is a part of critical care nephrology, and even the nephrologist obviously should know it. So, it is a part of the curriculum for nephrology, critical care, emergency medicine, everything. So, it's not difficult, and most of you who are doing focus for them, it won't be difficult. So when do we do renal imaging? In the ICU or in the ED or in a setup outside the OPDs? So whenever the patient is anuric or oliguric, so any patient who is AKI or AKI on CKD or CKD patients having hematuria, patients having fever, so pyelonephritis, cystitis, urosepsis is one of the commonest causes of fever in the ICU. Unilateral flank pain or low backache or loin to groin pain when you have renal colic or stones, and abdominal aortic aneurysms can frequently present in this manner, similar to renal colic. So these are when you do renal imaging or when you do nephro focus in the ICU. The most important thing for all of us, including the nephrologists, is to determine the volume status. So whether it is lung cardiac IVC focus, which is the conventional method by which you check the upstream markers and in LVF, whereas vexus is the new kid on the block. Okay, validation is required, but we are getting more and more papers. Okay, it started pre-COVID or before that itself, and now it has come into being. Most of you must have listened to Dr. Abhilash Kortala yesterday, who is one of the pioneers of vexus. And those who have not heard him, maybe a few slides here I can just demonstrate more on vexus. Of course, the urinary bladder status, that's very, very important. Many a times it happens that the patient suddenly becomes anuric, we give fluids, we give Lasix, and then finally we realize that the catheter is blocked. So ultrasound again helps to see whether your bladder is full or your Foley's is blocked. Again, you have an indirect evidence of raised IIP and abdominal compartment syndrome leading to AKI, ascites, and hemoperitoneum. That's important. So that's one thing. And obviously, USG-guided hemodialysis catheters and perma catheters. So that's a part of our curriculum. So do not put any lines without USG guidance, which includes hemodialysis catheters. So obviously, the success rates of putting in hemodialysis catheters and perma catheters much more when you use a ultrasound guidance. USG-guided renal biopsy, a domain of nephrologists and the radiologists, but it's open to us also. So you can learn USG-guided renal biopsies, and it's not difficult to do that. And of course, renal arterial Doppler to rule out renal artery stenosis. That's again one more thing which adds to the full curriculum. So that's the renal anatomy. That's the outer area which is the cortical area, and followed by that you have the renal pyramids, which are triangular shaped structures which opens into a papilla and drains the urine into the collecting system. These are the calyces, and this is the renal pelvis followed by the ureter. So that's the schematic diagram here. And in the normal sono appearance, from exterior to interior, you have the hyperechoic renal capsule. So the renal capsule is hyperechoic, that is white, followed by the hypoechoic renal cortex, followed by the hypoechoic medullary pyramid. Pyramids are more hypoechoic as compared to the renal cortex. And the hyperechoic renal pelvis. Renal pelvis is hyperechoic because it contains fat. So fat appears as hyperechoic on the sonoanatomy. Ideally, both the kidneys should be interrogated in both transverse as well as the longitudinal plane, and the asymptomatic side should be scanned first. So that's the dictum. So this is again a USG image in which you see the renal capsule there. That's the longitudinal view. We are using the curvilinear probe here. Okay, you can see this is spanning through the anterior-posterior area in the longitudinal plane. Those are the renal pyramids. Those hypoechoic structures are the renal pyramids. Okay, that is the cortex, which is more hypoechoic as compared to the liver, and that's the renal pelvis. So renal pelvis is again hyperechoic. So this is another diagram here, or an image here. So that's the superior pole, that's the inferior, that's the cortex. The cortex starts from the base of the medulla to the capsule. So that's how you measure the cortical dimensions. Okay, and medullary pyramids, which are hypoechoic here, and that hyperechoic area is a renal sinus here. Okay, so normally you don't see the calyceal system if it is not dilated, or you don't see the ureter if it is not dilated. So the next clinical questions we ask in POCUS, as in any other field in POCUS, is that is hydronephrosis present or absent? If it is present, is it unilateral or bilateral? Is the bladder distended? Is there any urinary retention? And this is the hydronephrosis grading by O'Neill. So grade 1 is pelvic dilatation alone. Grade 2 is pelvic and calyceal dilatation. Here the renal parenchyma, the cortex and the medulla is maintained. Grade 3 is pelvic and calyceal dilatation, but the medulla becomes short and thin. Here the medulla and the cortex both are preserved. And grade 4 is the worst, that is where your pelvic and the calyceal dilatation, there is a total loss of medulla, you can see. The cortex becomes very thin, okay, here. There is no corticomedullary differentiation. And the recess between the calyces also becomes short and slim. So that's the worst grading here. Sorry. So this is a clip which shows you hydronephrosis. So again, you can see a dilated calyx here. This is grade 3 hydronephrosis. The medulla is thinned out. The cortex is maintained. The corticomedullary differentiation is maintained. That's the dilated calyx, and you can see the dilated hydroureter. So whenever you see that, obviously there is an obstruction distal to it. So you assess whether it's mild, moderate, or severe, as I showed you. And you have to see for the compression of cortex. Look for both the kidneys. If bilateral, hunt for a distal obstruction. So if you are lucky, as in this patient, we had a right mid-ureteric calculus here with a hydroureter, but it may not be seen very easily because of the gas shadows. But if you are lucky enough, you can see it. What are the pitfalls here in hydronephrosis? Obviously, you have parapelvic cysts. So you can have parapelvic cysts which are multiloculated here. But the only differentiation is that it doesn't open into the collecting system. So that's how you differentiate between hydronephrosis and parapelvic cysts. The mimics are cortical cyst, okay, which is not uncommon here, and polycystic kidney disease. So in polycystic kidney disease, you have multiple cysts, okay, and they are bilateral. So you have to insonate both the kidneys. Suppose you see something which is polycystic, you insonate both the kidneys. So that's another mimic here. Now, you can also see such a picture, acute pyelonephritis, a flea-bitten kidney, okay, swollen kidney with multiple abscesses, necrotic areas in between. And the bane of all of us is emphysematous pyelonephritis. So in the olden days when we were residents, we used to knock off the kidney. We didn't have fancy facilities for DJ stenting. And that time when you used to see emphysematous pyelonephritis, the detection was pretty late. CT scans were not available. Sonography's POCUS was not heard of because we didn't have a machine in the department itself, forget machines in the ICU. But here now, if you are lucky enough, it's not an ultrasound diagnosis, it's ideally CT diagnosis, but if you are lucky, you can see the specs. So air looks white on the ultrasound. So these hyperechoic shadows are air. And if you see the CT scan image here, that's the air pockets. Those are the air pockets in the kidney. So emphysematous pyelonephritis has to be ruled out because source control is very, very important there. So what are the limitations? Renal stones are rarely directly seen unless and until they are positioned in the proximal or distal ureter because of bowel gas. Hydronephrosis is a surrogate marker for obstructive stones. It's not a direct marker. It may be a non-specific finding that can be secondary to other extrinsic causes like a pelvic mass. And of course, bowel gas is the bane. So the in thing which the new kid on the block is Vexus, and how do we assess volume overload? So that's a big thing. We always think of upstream markers. We always think of the mean blood pressure and the mean blood pressure minus the CVP. So that's the perfusing pressure. But we never take into consideration the back pressure or the venous congestion, which is equally important. And you must have heard a lot of lectures yesterday and today morning, which says that one of the correctable causes of AKI is treating venous congestion. And these concepts of de-resuscitation, and volume tolerance are very, very important. So many a times we give volume, chalo 200 bolus do, 300 bolus do, sister, run 1 pint fast, without realizing that what implications it may have on the kidneys and the other organs, the gut, the liver. So all the other organs in the body can also be affected by over-resuscitation or over-hydration. That's the problem there. And once you do that, de-resuscitation becomes like damage control. So we have to know how it goes. So the conventional thing is the lung, because lung is the end organ. So if you see A lines, A for artifacts, A for air, A for aerated lung. So a normally aerated lung means it's not a wet lung, it's a dry lung. But you have to insonate on all the 6 quadrants in the lung ultrasound to know that it's a dry lung. And obviously if you have this sort of a IVC, which is completely collapsible with a dry lung, that means it might be a dry lung and you still can give fluids if the patient is hypotensive. And if you see this, what is this? Kissing ventricles is written here, and you can actually see the ventricles which are kissing each other. So that's an empty heart. That's an empty heart. So if you have a dry lung, A profile, if you have a collapsible IVC and kissing ventricles, that means, and the patient is hypotensive, that means the patient can be fluid responsive. So this is the conventional method, what we call as lung cardiac IVC ultrasound. Not just lung alone, not just heart alone, not just IVC alone. So many a times we have seen that many of the clinicians say that IVC dekhe fluid do. That's the most fallacious thing to do. That's the most bogus thing to do. Don't do that. Many of the nephrologists also just try to see the IVC and guide fluids according to the IVC. That's absolutely wrong. So this is the B-line pattern. If you have no B-lines and A profile, that's a dry lung. 1 B-line is not significant, it may be just a fissure. 2 B-lines again may not be significant. 3 or more than 3 B-lines in one sector or one intercostal space is significant. And if it increases, it goes to what we call as B7 profile. That means you have 7 millimeters distance between the 2 B-lines. And then it goes to B3 profile, which is 3 millimeters distance between the 2 B-lines. And of course, then you get a full white screen, which is called as a birule or a whiteout lung, which you see on the X-ray as a white lung. So this is the B3 profile, 3 millimeters distance in between those, the consecutive or the successive B lines. So that's the B3 profile. And if it goes further, the interstitial edema increases and goes further, we have coalescing B lines. You have a whiteout pattern. So, and if you have an IVC like this, obviously this is a plethoric IVC, that's the M mode, and it's hardly collapsing. That means, again, this is volume problem, overload, or it's a, and if you see this cardiac profile, that is ultrasonography, you see this is a apical 4 chamber, the heart is hardly beating, very severely compromised LV function. So then obviously you can't give fluids, you have to give diuretics and treat the underlying cause, treat the LVF, so on and so forth. Now one more protocol which Dr. Dickenstein has propagated is falls, which is a very good method to assess volume and to guide fluids, not only assess volume, to guide fluids. Okay, so falls is fluid administration limited by lung ultrasound. So first of all, you have to do the cardiac ultrasound, that is echocardiography. You have to use the blue protocol. So you rule out tamponade, you rule out pulmonary embolism, you rule out pneumothorax. So you rule out obstructive shock causes first. Once you do that, there is no obstructive shock. If there is obstructive shock, obviously you treat the obstructive shock, release the obstruction, treat the underlying cause of the obstructive shock. If there is no obstructive shock and you have a profile, that means a dry lung and the sliding is present. You give fluids to this patient. See the fluid responsiveness. If there is clinical improvement, obviously this is hypovolemic shock. Treat the underlying cause for the hypovolemia. If you don't treat it, just give fluids, it's not going to help, obviously. But there's no clinical improvement, and eventually you start getting B lines where there was a profile. It's a septic shock, and that's your end point. So this is where you don't give more fluids. That's your end point. So lung is the end organ. If you get early interstitial edema, that is the time when you stop giving fluids. That's the take-home message there. So let's come to the in thing, vexus. So what's vexus? Vexus is nothing but solid organ venous condition. And how do you know that? It is by this protocol of vexus. So this is called as venous access ultrasound. You insonate the IVC. If the IVC is plethoric and non-collapsible, what do you mean by plethoric? 2 centimeters. Now the definition in Indian Asian patients may be slightly low. It might be around 1.5, 1.7, 1.8 centimeters. Okay. Not 2 centimeters is not a benchmark, but generally the cutoff is 2 centimeters. But if you feel that it's 1.8 centimeters and the IVC is non-collapsible, you can still do the vexus. Okay. Don't be dogmatic and stop at 2 centimeters there. Okay. So the next thing, so if that is there, then go to the other insonation of the other veins, that is the hepatic vein, portal vein, and the intrarenal vein. If the IVC is not plethoric, vexus is out. Okay, that's the take-home message. That means the RA pressure or the back pressure is not much to warrant insonation of the veins. So what you do is essentially insonate the hepatic vein, portal vein, and the renal parenchymal vein. I'll tell you how to do that. Now this is interesting. It's the pressure at different points in the circulatory system. And if you note, the precapillary arteriolar pressure is substantially lower than the large arterial pressure. So these are the large arterial pressures, LV, the aorta, the large arteries. This is the precapillary arteriolar pressure, and that's the venous pressure. And that pressure differential is actually the organ pressure. Okay, so that's the backsided pressure. What we see is the mean arterial pressure minus your CVP, but that pressure is the most important thing. The pre-arteriolar pressure minus the venous pressure. Okay, so that pressure is very important, and vexus tells you that. So normally when you insonate any vein, if you insonate the artery, you have a systolic pressure, you have a diastolic pressure, there's a blunting of the diastolic pressure, and that's the waveform. But if the arterial pressure goes down because of whatever reasons, okay, hypotension, you get a systolic peak and blunting of the diastolic pressure. The diastolic pressure then comes down almost to zero. And this is what you see in CPP also. So in brain dead patients, you see a similar picture. Now let's come to the hepatic vein. Hepatic vein is in direct connection with the IVC. Okay, so all the hepatic veins, the right hepatic vein, the middle and the left hepatic vein drain into the IVC. And if you can see here, the waveform is not a classical venous waveform. It's not a monophasic waveform because it's a reflection of the venous pressure, the right heart pressures or the right atrial pressure. So that's your CVP, that's the ECG, and that's the hepatic venous pressure. So it starts from the systole. So after the QRS complex, you have the systole. So that's the systolic wave, which is negative because that's a reflection of the back pressure. That's why the systolic wave is negative. So that's the S wave, which is negative. Then the D wave in the diastole, which is negative. You have two positive waves, which is the A wave, which corresponds to the atrial contraction, which corresponds to the A wave on the CVP, and the P wave on the ECG here. And this is the V wave, okay. That again is one small systolic peak here, which corresponds to the end of the systole there. And the S and the D waves correspond to the X descent and the Y descent of the CVP. So that is how you interpret the hepatic vein. So this is one more schematic diagram of how you interpret it. That's the S wave. This is the systolic wave. That's the diastolic wave. That's the V wave. V wave can be positive or can go down the baseline. A wave is a definitely positive wave, which is because of the atrial contraction. So this is the hepatic vein Doppler. How do you do it? You use a phase array probe or a curvilinear probe, cardiac probe, sub-xiphoid view, the same view which you take for the IVC, and the hepatic veins drain into the IVC. Now, in the IVC also the pivots are, you have to measure the IVC 2 centimeters distal to your RE-IVC junction, or 1 centimeter distal to the hepatic vein draining into the IVC. Now again in the IVC, a word of caution is IVC is a 3-dimensional structure, and what we are insonating on the echo or focus is a 2-dimensional image. So you have to check the dimensions of the IVC in both the planes, longitudinal plane and the transversal plane. And if in the transversal plane also it is big, it is rounded, normally it is semi-ovoid. If it becomes rounded, that means IVC is really plethoric. And if your measurements are just more than 1.5 also, but your transverse diameter is rounded, that means you can still do excess further. Now, hepatic veins, okay, they are thin-walled, okay, and they drain into the IVC. That's how you differentiate them from the portal vein. So, the phased array probe has to be used, and this is how it looks. So, that's the S wave, that's your D wave, that's your A wave here. The positive wave is the A wave here. Okay. So that's a normal hepatic vein Doppler. When venous congestion increases, the S wave decreases in amplitude, the D wave increases. This is what happens first. Okay. So the S by D ratio is less than 1. S wave further decreases, the diastolic wave increases further as the venous congestion goes up. And then finally, in severe venous congestion, you have a reversal of the S wave. The S wave becomes positive here, and the diastolic wave increases in size. So this is severe, this is mild, this is normal. So again, a schematic diagram here. You can just see that the S wave has reversed here. Okay, it has become positive. The D wave is still present there, and the D wave amplitude has increased. So this is severe hepatic venous congestion. Now that's how the portal vein looks like. So when you insonate the portal vein, the difference between the portal vein and the hepatic vein is that portal vein has hyperechoic walls because it has fibrocollagenous tissue, whereas hepatic vein doesn't have hyperechoic walls, it's thin wall and it drains into the IVC. Obviously, portal vein doesn't drain into the IVC. Okay, it crosses the IVC there. So you put your color Doppler on the portal vein, you will get a red flow there because the portal vein drains the blood from the splanchnic tissue to the liver. That's why the red flow is towards the probe. It is not red is artery and blue is vein. So it's barred, blue is away and red is towards. So the portal venous flow is red here. Hepatic venous flow will be centripetal, it will be blue. So a normal portal vein is monophasic, looks like this. Okay, but whenever you have increased venous congestion, it will be pulsatile because of the transmitted pulsation. And when the venous congestion increases, it will be to and fro. So normally you measure the pulsatility flow. So that is maximum velocity minus the minimum velocity divided by the maximum velocity. And this is again insonation of the portal vein. You can see that the color flow is towards, and that's the Doppler on. So you see a monophasic waveform, which is positive because the flow is towards the transducer. And if this monophasic waveform becomes in venous congestion, it becomes pulsatile, it's significant. So normal PF is less than 5. Okay. If it increases further, you get a pulsatile flow, which I showed you this way. Okay. So this is what happens when the portal vein, the venous congestion increases in the portal vein. Finally, you get a to and fro pattern here, and the pulsatility is more than 50%. This is how portal vein looks like, hyperechoic borders there, and that's the Doppler, spectral Doppler, which is monophasic here and positive here. Now let's come to the renal arteries. These are intrarenal arteries. So the last veins to be insonated are the intrarenal veins. Now you have the arcuate arteries which supply the kidneys along with the renal, intrarenal veins, and you have to insonate on the intrarenal vein here. Now it becomes difficult, okay, especially in obese patients, or if the patient's respiration, patient is tachypneic, because of the phasic respiration, you cannot put your pulse wave Doppler on this. So sometimes it becomes difficult. So technically, this is the most difficult venous waveform to get. But if you insonate anywhere here, okay, you can get an arterial flow which is positive and a venous flow which is negative. So here you may not use your ECG for timing it. So that's the renal artery which is insonating, and you can see that negative flow there, which is again a monophasic flow similar to the portal vein flow. That's your intrarenal venous flow. So for this I don't have to use the ECG guidance because this is a systole, that's your arterial waveform. So the arcuate artery and the veins are insonated in the same Doppler image because they are very close together. So the renal resistive index is calculated by peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity. This is how it goes. If the RRI is less than 0.7, it's normal. If it is more than 0.74 to 0.8, that means there is a 3 times increased incidence of AKI in these patients. Okay, there are enough studies to validate this. And if it is more than 0.8, it may be more than transient AKI. It may take a longer time to reverse. So that's the implication of RRI. Of course, there are pitfalls of this also. So that's how a renal artery looks. Okay, that's the systolic flow. That diastolic flow is very, very damped here. Okay, it's severe congestion there. So this is a normal RI. This RI is more than 0.8, and this is again still worse. So again, as I said, these are the intrarenal veins, which is a negative flow here, similar to the portal vein, which is positive. The intrarenal veins are negative, and you can see the arterial flow also. You can see the arterial waveform because sometimes they overlap. They are very close together. So this is how a normal intrarenal venous flow looks like. It's a continuous monophasic flow like the portal vein, but it is in a negative direction. If the venous congestion increases, it becomes pulsatile. Normally, it is less than 30% pulsatility. Okay. If it increases further, it becomes biphasic. Okay. You have a systolic wave and diastolic wave. If it increases further, you have only a monophasic wave, which is just the diastolic wave. So this is how a severe venous congestion looks like. Only a diastolic wave there. Now, putting it all together, how do you interpret vexus? The first step is, are you awake? Okay, the first step is IVC. So IVC should be plethoric. Measure IVC in both the axes, not in one axis. Very important. Where do we measure the IVC? 2 centimeters from the RA-IVC junction, or 1 centimeter from the hepatic vein which drains into the IVC. IVC is plethoric, go ahead. IVC is not plethoric, don't go ahead. So the first step is hepatic vein Doppler. So mildly abnormal, severely abnormal. Then the portal vein Doppler, again normal, mildly abnormal, severely abnormal. Then the renal vein Doppler, intrarenal venous Doppler. So these are the 3 venous Doppler which you do. Now interpretation is grade 0, no plethora, no venous congestion. Grade 1, IVC is more than 2 centimeters plethoric, and any combo of normal or mildly abnormal patterns. So mildly abnormal, any of these normal or mildly abnormal patterns along with a plethoric IVC is grade 1. Again, not very high venous congestion. Grade 2 is IVC more than 2 centimeters and 1 severely abnormal pattern. So any of these 1 severely abnormal pattern. And grade 3 is again plethoric IVC with 2 or more than 2 abnormal patterns. So that's how you grade vexus. Any problems here in grading? Okay, have you understood this? The theoretical part? Yes or no? Yes, great. So that's the early warning sign of fluid overload. So this is where you stop, don't go further. Okay, don't go further, and in fact de-resuscitate. If required, give diuretics. If required, do ultrafiltration, dialyze the patient, take the water out. Many a times we take these decisions late. Okay, so too late can be very bad. Okay, so don't time it too late. Do your vexus. The idea is to do the vexus in each shift. Okay, just don't do the vexus and forget it. And plan out your therapy as per the vexus. Okay. And see how the VEXUS works. Once you have planned out the therapy, suppose you have given diuretics, the patient is negative, again check the waveforms in the next shift after your intervention or after the dialysis or whatever interventions you do. So when can I use VEXUS at the bedside? Titrating diuretics in heart failure. So the original paper by Dr. Philip Rolla and colleagues was in heart failure patients who were ventilated. Okay. Early sepsis, again, early stop to point for fluids. Use your falls along with it for the upstream markers. For the downstream markers, use VEXUS. Heart failure with AKI, that's the reason why we are doing this, supporting cardio-renal dysfunction. Now, what are the scanning tips? Breath holding in cooperative patient. Most of our ICU patients will be dazed, not cooperative, will be tachypnic, so breath holding may be difficult. Systole and diastole, ECG leads are very, very useful. Those of who have heard Dr. Portala yesterday, many a times you can misinterpret, especially the hepatic vein Dopplers and portal vein Dopplers if your ECG leads are not used. Intrarenal veins, because you can see the renal artery, you can time it with the renal artery, so that's not a problem. Scans, lot of normals so that you can recognize the abnormal. So scan a lot of normals. So first to check out what is abnormal, you have to scan normals. So whenever you are on rounds, you are post-round, get your ultrasound probe and see what is normal. That's very, very important. Once you see what is normal 50 times, you will check out what is abnormal. You will get what is abnormal. So what are the keywords? Consider the entire clinical picture. Okay, VEXUS is just an investigation. Okay, it is not a therapy. Do not forget the basics of IVC, heart and lung ultrasound. That's very, very important. Do not forget that. It is an addition to that. Remember the pitfalls and false positive of all the scans and VEXUS. Solid organs are neglected since it is a radiologist domain. So take that thing out of your mind that I can't insonate the kidney, I can't insonate the liver, I can't insonate the abdomen. Take the probe in your hand and insonate. At the most, first 10 times you will get it wrong. Okay, 11 times, 58 times, 51st time you get it right. And when the radiologist and the cardiologist don't come at night, you are at their mercy. So if you know this, you can do a lot of things at the bedside and change the therapy fast. Bimodal questions and answers. We don't want the exact insonation of the kidney. What is the cortical measurement? What is this? What is that? You want bimodal answers. Act based on findings. That's very important. If you don't act based on your findings, you are not going to help the patient. The outcomes are not going to change. Know the perils and pitfalls. Very important. And of course, we are not deriding our radiologist colleagues. Okay, ask them to do a detailed examination and learn from them when they come the next day. So thanks, and if there are any questions, I can take them. Otherwise, we can move to them. Yes.
Good evening, sir. Sir, in certain patients, especially if you are not able to hold the breath at end inspiration, or in mechanically ventilated patients, we have noticed that with each inspiration and expiration, there is a variability of the SLT, especially the hepatic vein. I find like certain patients are having SD, which is like S more than D in inspiration, and when S more than D during expiration, and there is a reversal during inspiration. So does that have any value, or in that case, how?
See, maybe you have not timed it properly. Do you use a EKG guidance? Have you used ECG?
Yeah, using ECG.
Are you sure?
Yeah.
So normally if you use ECG and if you time it properly, it should not happen. Sometimes there are phasic changes with respiration, you are right, physiologically also. Those may be pitfalls. But what I suggested is when we started, we were not using the ECGs frequently. But since we have started using ECG, especially for the hepatic and the portal vein Dopplers, we are not having much problem. Many a times you don't see the renal veins. So many a times you cannot insonate the renal veins, especially if you have a low-end machine, you cannot insonate the renal veins. So one idea for insonating the renal veins is that you keep your frequency low and you keep your baseline frequency low. I'll show it to you here. So that's it. And that happens, that does happen.
And in case, for example, out of the three, so IVC anyways most of the times will be able to get it. say for example, we are only getting the portal vein and the hepatic vein, but the renal vein flow, I'm not able
That is fine. That happens many a times.
So in that case, can I interpret the findings or like create the vexes based on the other two findings alone?
So that's why it is a combination of all the three veins, not just one vein. And now there is something called as E-vexes. So if you heard Dr. Abhilash yesterday, so if you have cirrhosis or you have patients with cirrhosis or any other pathology, intra-abdominal pathology, you can insulate the IJV, you can insulate the femoral vein also. So that's one more aspect of this. But again, as I said, don't only act just on your vexus findings. You have to select the patient very carefully. Where will you do vexus? So if that selection is there and you know what do you want, should I dialyze this patient? Should I increase the diuretics? He looks dry, but if my vexus score is 2 or 3, I will straight dry him further. Okay, though the creatinine is borderlinely high. So that is the take home. I don't have experience in vexus post liver transplant, but yes, it can be used as the same thing. You can, because post liver transplant, your liver perfusion improves, okay, and it's a normal, relatively normal liver or a hibernating liver. So it is as good as a normal person, not a cirrhotic person. And you can see a flow reversal. If you saw yesterday's lecture, and we have also seen that pre-transplant and post-transplant, there is a big difference in the flow. So the venous congestion is definitely less. And you can do a serial reading. One reading doesn't help. You can do a serial reading in each shift. You can do a study because if you are a liver transplant center, then you can do a study of vexus pre-operatively and post-operatively. So that will be a good thing.
The reliability of IVC post-transplant is something people varying with they don't realize it.
Yeah, so post-transplant in a transplanted patient, IVC may not be reliable. But IVC is a hype thing. So whenever you are a beginner, IVC देखो, inform me the IVC measurements and I decide about the fluid. So most of the clinicians do that who are not into ICU stuff. And then you have to make them de-learn. Okay? So it takes months to tell them that they got lesson. And IVC pitfalls, there are many other IVC pitfalls. As I said, IVC is semi-overt. It's a three-dimensional structure. Yeah, so see there are studies of vexus in right ventricular, not specifically right ventricular infarction, but again they may land up with a right-sided failure. So the dictum is to keep them well hydrated and keep the CVP up. That's the age-old teaching, that you keep the CVP up, don't give dilators, don't give diuretics. But you can do a serial vexus, and if you feel that the serial vexus is, when you started off there was no venous congestion and then now there is venous congestion, you feel that he is going into right ventricular failure, that is the time to act. That is, of course, you have to treat the underlying cause, revascularize them and do it. But that is the time to act. And pulmonary hypertension is not a contraindication to do vexus. In fact, pulmonary hypertension has the same pathophysiology. Now the only problem with vexus is that you can't differentiate between volume and pressure overload. That's the only problem with vexus. But you have to go by the clinical scenario there. So whether to know whether there is a pressure or a volume overload. So in right ventricular failure there will be a pressure overload, not volume overload. Okay, so I think we'll move here. Yeah. So I'll request them to help me out. ये बंद कर सकते हैं ये लाइट बंद ये लाइट बंद कर थोड़ा पीछे का लाइट से इस पे भी आ रहा है इस पे भी आ रहा है ये लाइट हाँ वो वाला कर दो राइट सर मैं भी ब्रेक में बैठ So I'll just show you the sono anatomy first. You know the sono anatomy, but we'll start with the sono anatomy part. उसको बंद कर देंगे. is a curvilinear probe first. Okay. So first is the sonoanatomy of the kidney, and then we'll go to vexus. The first thing is again going to the basics. You have to tap. And okay, this is my pointer. Now different machines have different pointers, so you always tap and see. Okay, I'm tapping here. That's the pointer. Okay. So in abdominal examination, the pointer should be towards the right side. For the cardiac, it should be towards the left side. But it doesn't matter. Suppose you are switching it, you should know which side you are keeping the pointer. So there are two methods to exfoliate the kidney. The first method is go in the right kidney will be like.
Because these people, they are unable to see where you are actually insulating. If you are interested, you can come there.
Come here if you want.
Yeah. EV will show you everything. But
yeah, this will show you everything.
That side will be better.
Yeah. So you can see nicely, my pointer is cephalic. The piece that's cephalic there. Okay. That's my liver. And this is the Morrison's valve which you are seeing. So if the patient is cooperative, ask him to turn to the other side, the left side to insulate the right kidney. Can you see the kidney properly? The upper pole and the lower pole. So I'll increase the depth. So the organ of interest should be in the center. So disclaimer, I am not a radiologist, but you learn it the hard way. And if you pick up the probe every day, you will learn it better. And see, nobody will tell you don't insulate the kidney, don't insulate the liver, it's our domain. Radiologists won't tell you that. So can you see it nicely? Yes. So upper pole, okay, the lower pole there, the pointer is cephalic, so upper pole there, lower pole there. And you can see the calyces very nicely, okay, those hypoepic structures above the above the pyramids is the cortex. The sinus is the hypoepic structure in the middle which you are seeing. This is the sinus. The hypoepic line which surrounds the kidney capsule and it moves like the kidney size around 10 to 12 centimeters, anything less than 8 is small, okay, but there may be variations. You have to insulate both the sides. The left kidney is slightly superior and posterior, so you have to go more posterior in the posterior axillary line. Here I am going in the mid axillary line. You can see it's around 10 to 11 interspace there. Okay. That's the longitudinal. I'll fan from anterior to posterior. I'll fan again here. Okay. You can see the anatomy very nicely. You can see the pyramids there. You can see this cortex. You can measure the cortex, and then I will go in the transverse direction. This is the transverse view. And you see the transverse view very nicely. That's the transverse view. And I am insulating again the lower pole here. My ultrasound probe is spanning towards the lower pole. And my ultrasound probe again is spanning up there. Okay, that's the upper pole there. That's the lower pole. Very small movements you have to do, very small movements. So that's the kidney sonoanatomy. That's the Morrison's also. This is one of your fast window also. Okay, so right upper quadrant fast window also. No free fluid there. Okay, and you have to check the upper pole and the lower pole also. Now we try to insolate the intrarenal vein. Ideally that is to be done last, but since we are insulating the kidney, we will insolate the intra. I am putting it on the color of the. Can you see this nicely? So those are the arcuate arteries. The red are the arteries, not red means it's towards the flow. So the arterial flow is towards the flow. Red doesn't mean that it is arterial always. But here, since it is towards the flow, it is arterial. And you can see those blue lines accompanying those arcuate arteries. Those are the intrarenal veins. Can you nicely identify those? Are you okay? Yes or no? Yes. Oh, okay. Are you tired? You need a break? No. So then I put a pulse wave Doppler there on one of those veins. Ashish is very cooperative, so I insulated him in the afternoon. Thank you, Ashish. And I can ask him to श्वास रोकूं थे 1 minute. Can you see that nicely? Yes. Shwash. So if you can see, the artery and the vein both are insulated. The arcuate arteries are on the positive side. Okay. Negative side is the intrarenal vein. That's a monophasic flow. Okay. And here I don't require EKG guidance because I can see the arterial flow. I know where is the systole, I know where is the diastole. So whenever there is an increase in the venous congestion, what will happen? It will be a pulsatile flow. It will go to a systolic and diastolic, and finally only diastolic, and then only diastolic will increase. So that's the severe condition. So this completes the intrarenal vein. Okay, so this is a good machine. This is the best machine. Epic. We are lucky to have Epic, or we are unlucky to have Epic. We have to insulate on Sona site, okay, and then only we will be good at the access. Okay. So this is fine. Very nice. Easy. आप भी कर सकते हो. अगर आर्टरी भी आपका साथ में आर्टरी आएगा ही, विद रेस्पिरेशन आर्टरी आएगा ही, तो फिर that is not a problem. It is good because you know where is the system and the diaphragm. You can time it. Okay. So now let's go to I'll show you. So whenever you want a EKG guidance, all our ICU monitors have a cable which goes into this. Okay. There is a connector here. Different machines have different connectors, but you may require just the 3 leads. Can help me put in a 3 leads. So let's insulate the liver again. So now the depth is less. I will increase the depth. So that is the transhepatic view for the IVC and the aorta both, to increase the gain a bit. Can you see the aorta and the IVC both? Okay. So that's the transhepatic view. Now aorta, IVC is intrahepatic, aorta is extrahepatic, okay, and IVC collapses with respiration, whereas aorta is pulsatile. And I put the M mode on here. Now for the transhepatic measurement, they are slightly more than the subxiphoid measurements here. You can see the portal vein very nicely. Can you see the portal vein up there? That's the portal vein. Those are hyperechoic borders because of the fibrocollagenous tissue, and that's why there's a stack sign there of the portal vein. That's the portal vein, that's the stack sign. Can you see that? That's the main portal vein. And I can put the color Doppler there. I'll just use my depth setting. Yeah, that's it. Yeah, that's it. So I'm going to put the color Doppler there. You can see the red flow there. Okay. That's the red flow there, which is towards, my flow. And I'm going to insulate that. Yeah. Can you see that nicely? Great. Happy. So that's again the monophasic flow which is positive because it's towards your probe. It doesn't mean that red is artery. Towards your probe, that's why it's above the baseline. What will happen to this flow when the venous congestion increases? So it will be pulsatile. So normally it is less than 30% pulsation. So you take the highest point and the down point there, and you see the pulsatility index. So normally it is less than 30%. So as the venous congestion increases, it will increase between 30 to 50. If the venous congestion increases further, it will go above 50%. So that's how it goes. So severe will be more than 50%. Okay. So this is portal vein. Okay, any doubts here? So now let's go to the hepatic vein. So I will use your phased array probe so you can time it with the EKG, the ECG. So I will change the. So that's your phased array probe. Fine. So again, you can see the ECG there. Yeah. You can see the ECG there also. So again, pointer, my pointer is here. Nice pie wood. So for the one tip for the sub-xiphoid view is that if the patient is cooperative, ask him to fold the legs. Yeah. And Ashish is very cooperative. So you can see the sub-xiphoid 4-chamber view. That's the only view where you see the liver. Okay. That's the only cardiac view where you see the liver. That's the RA. That's the anterior pericardium. Liver first, anterior pericardium. That's the RA, tricuspid valve, RV. That's the LA, LV, mitral valve. I'll increase the depth further. And now I'm going from the 3 o'clock position of the pointer. The pointer is at 3 o'clock. I'm going from 3 o'clock to 12 o'clock. That's your IVC. Okay. Looks plethoric to start off with, but it's not plethoric. So now that's the hepatic vein which is joining the IVC. I'll go distal to that. And you have to, ideally you have to get the cursor of the MO band perpendicular. This is not exactly perpendicular, but this is slightly better. Namshas ji. Sword. Ye. Sword. Ye. Sword. Okay. So this is the collapsible IVC. So will I go for the Vexus? No, I won't go for the Vexus. And I can see the IVC. Yeah. Can you see the IVC there? That's the IVC. Can you see that? It is semi-ovoid, okay? And it's in the liver, so that's not the aorta. Can you see it? Namshas here. Collapsing nicely. You can see it's semi-ovoid. So use both the planes, okay? Don't use only single plane. That's fine. So again, I can see the transhepatic view there. So sometimes the bowel gap hinders the sub-xiphoid view. I can see the transhepatic view. Not a very good view here, but yes. The aorta is down below. This is better. Can you see that? You can see the pulsatility of the aorta down there. That's the IVC there. So now the last but not the least is the hepatic vein Doppler. And you see a pipeline hepatic vein there, which is draining into the IVC. So that's the middle. The right and the left are besides that, and you can see it draining into the IVC. Can you see this? It's draining into the IVC. I will take the middle one, which is very nicely seen there, and put my pulse wave Doppler. go downstream and you get a better view rather than very close to the IVC. Okay, so can you identify the waves? So you see the ECG, EKG, QRS after QRS, so your electrical event is followed by the mechanical event. So that's the systole. After the QRS is the systole. So that's the first negative wave is your S wave. Then after the T wave is your diastole. You can see the negative wave, that's the D wave. And after that there is a small positive undulation, that's your A wave. Not very well, but it's seen better here. That's your A wave. Yeah, here also you can see. Here also you can. And intermittently you may see a V wave, not always seen, but you may see a V wave. So this is a normal waveform. How do you interpret it? When the venous congestion increases, what will happen? Yes. So the S wave will shorten, the D wave will increase, then the S wave will further become shortened, the D wave will increase, then there will be a reverse. The S wave will go up and the D wave will go down. So some pitfalls are hyperdynamic circulation, that's a problem. You can get merging of both the waves, S and D, and you can misinterpret it as only a D wave. So that has to be timed with the EKG. So what I do in my practice is that I use my phase array probe for the hepatic and portal vein. For the renal veins, I use my curvilinear probe because the footprint is good and the pickup rates are better with that. So only one small technical tip I would like to give you here is an analysis. So this is a wall filter. If you can come here and sorry. So can you see that this is a wall filter? So every machine has a wall filter. So use it, keep the wall filter low. Okay? Keep the wall filter low. And the gate size also you can keep it smaller than this if you want. You can change the gate size. And keep the frequency between 1.25 to 1.5. So that's how you do it. The main thing is wall filter. If you increase the wall filter, then you won't get your intrarenal veins properly. So that's the trick. So this is a wall filter. Every machine has a wall filter. So think as all your machines will have a wall filter. You can see that?
What does wall filter do?
Frequency of wall filter will attenuate the extra, what you call the sound will be filtered. And since these are low frequency vessels, so your frequency should be very low. So if you keep a higher wall filter, it's not going to pick up those frequencies. And Doppler works on the principle that the Doppler flow should be parallel. The angle of insulation should be near zero. If it is perpendicular, it's not going to help. So all these veins we go parallel. Okay. And last but not the least is that don't forget your basics of lung ultrasound. Okay. So I insolate the upper blue point. Okay. So that's your A profile. You can see the sliding very nicely. So a dry lung there. The dry lung in the upper blue point of quadrant 1. The dry lung again here. Can you see the A lines, parallel A lines and A dash lines very nicely with sliding together. A dry lung in B profile in blue point 2. And again I go to the flaps. So I have to increase the depth there. So this is the liver. Again a dry lung there in flaps. Okay, and then insolate poches again. Push it forward. Your lung insolation is not complete till you insolate the prone points. So that's your lower prone point or quadrant 6. That's my lower prone point. Okay. So COVID was a time when we used to insolate the prone points, especially when the patient used to be in prone ventilation during a therapy for ARDS or awake proning also. So again, nicely seen, and then upper blue point as well. So these are for your lung is your end organ. So if you see B lines are significant, B lines are significant. But sometimes you have an interstitial lung disease or you have an interstitial pneumonia. So if you have interstitial lung premorbid interstitial lung disease, you have some history. If you have interstitial pneumonia, again you have history. But interstitial pneumonia and the LV function is normal. Do a E by E prime. So the E by E prime is more than 14. E by E prime average is more than 14. That means you may have a You may have a LV dysfunction, that is preserved LV dysfunction, preserved LV function, but heart failure. So that is the time probably you will get diuretics and use your anti-failure. But if your E/E' is normal, treat it as interstitial pneumonia. And then guide your fluids accordingly. So if there are no other questions, then we can go. So other tips are that you have to, if the patient is cooperative, you have to instruct the patient what you are going to do, so the examination becomes easy. And the pretest probability is very important. So you know your history, you know your clinical findings, the pretest probability is very important. You have to know what to expect from your ultrasound and act on that. So you can get total in subconscious. Hepatic and portal portal vein will be hyperechoic. Hepatic vein will be thin wall, it will drain into the IVC. Portal vein is not going to drain into the IVC. There is something called as Indian fissure, Indian lower fissure. That's the point where you have your portal vein. That is the point. You can insulate it here also, and you can insulate it from there also. That's the hepatic vein. Three hepatic veins, can you see that? Yeah, that's the middle hepatic vein. Can you see it draining into the IVC? IVC, drain over. And then that's the stat sign. It's a hyperechoic border, and you can see the hepatic vein also. This is hepatic vein. That's the portal vein. So stat sign is the bifurcation of the portal vein into right and left. Right and left. Stat sign. Transversely, like this. Keep the probe transversely for abdominal aorta insulin. So that's your IVC, So the right, on the right side you will see the IVC. That's my right side. That's the IVC. Can you see the IVC? And it's intrahepatic. Can you see the IVC? Just besides that on the left side you will take it. And the most important thing is clean your probes. Okay, so the person who is going to do the sonography is going to clean your probes. We take care of our iPhones, your fancy phones, but the probe is the most important thing in the ICU. So the person who is going to do the sonography will clean the probe, however junior, however senior he is.
The basic housekeeping rule is to sanitize it before using it.
Yeah, that is very important. So sanitize the probe as per your norms. That's very important. And we thank a big hand to Ashish.
So the person will charge it, so we will get the bill. The whole body vexes us in the LBC everything.
So thank you, Turaskar sir. So I think one of the very interesting session, and it was eye-opener actually. So going ahead further, you have to learn more and more practice, because unless until you do practice, I am sure you are just going to forget it. These are all skills actually what you require going wherever you are working in the ICU. You need to do it repeatedly. That is the main crux. Theoretically, if you read it, is not going to add any value to you. So practice. Keep your probe, how to keep the probe, how to fix up the machine, how to analyze the things. At least 100 ultrasound, 100 your normal things, unless until you see, you are not able to differentiate what is normal and what is abnormal. The most important thing, what sir told is to differentiate between normal versus abnormal. So with this, we are going to end today's session, and I really thank all of you to be here till the late evening, 7:30. And I request Dr. Biswa Vikas Mahanti to felicitate Toraskar sir. Sir, we'd like to felicitate you, sir. Please come to the stage for such a wonderful lecture. Dr. Biswa. And all of you, please share the feedback form.
Sir, 1 minute. Light बंद करो.
Sir, light please. And all of you, please scan and give your feedback form, because that is very important. And tomorrow we expect you to be sharp at 8:30 in the auditorium, because tomorrow also we are going to have a very marathon session almost. So please be in time, otherwise it will be very difficult for us to manage the things. Okay, we will be sharp starting at 9 o'clock, and wish you all the best. And whatever you learned today, go read and practice on the patient.
Can I expect 1 or 2 feedback from you? Anybody wants to share how the day went ahead?
And about your certificate and books, we will be giving you tomorrow. Okay?
So who is going there? Not able to attend it tomorrow.
No, then see, MMC you have to attend 2 days course, because otherwise your MMC points will not be valid. That is the main thing. So that is the most, because the MMC observer is he comes and sees, so that is the reason. So you have to come tomorrow. So at the end of in the evening only we can give the MMC points. So please be there tomorrow.
And you can scan the QR code we have said for becoming a member in the Nephro Critical Care Society. I think everybody has received that QR code.
There is a link. There is a link which is shared on the group. Just open that link and share your feedback.
So many things are coming. So in this month only you will get all these like Zoom meetings as well as troubleshooting, problem-based scenarios discussion also online afterwards, after this CAB.
Anyone want to give any feedback, 1 or 2? Most welcome. Anybody would like to say something, or else we will wind up. Ganesh, you want to say something, please?
Good evening, everyone. Thank you for the opportunity. It was indeed an academic feast we had today. The fear of CRRT has been reduced now. Now we will get less scolding from Sodip sir after initiation of CRRT. Fear has been reduced. Thank you everyone for this wonderful session.
We expected feedback, but this is about the course, not about Dr. Subhadev. You have shared your feedback about Dr. Subhadev.
Share one feedback for the course.
So actually the content was awesome, especially the Vexus thing, which was totally new for me at least, and the workstations like CRRT and ECMO with CRRT, which was very new for me. I had never had an experience to know these things before. So it was indeed a enriching experience to have all these things, which it has enlarged our vision of the CRRT. That is the thing. Thank you.
I just clarified a lot of doubts regarding the CRRT and how to initiate and everything. The course was extensive, covering many topics. So it was a really good experience.
Would you like to give some feedback further to improve, or any area you need to work in this?
So some of the topics were little, if there was a little more time spent on some of the topics, it would have been more better. Yes.
So the main thing is they have more hands-on experience. Okay, we'll take care from the next. Okay, thank you.
and we are waiting to welcome you again at 8 a.m. tomorrow. Thank you.